Very good morning to all of you. Good morning and a warm welcome to all respected seniors, dear friends and students. As we are presenting CCR by Department of Clinical Nutrition and Dietetics today, and there are many delegates and students outside of our university due to inaugural midterm meet. I would like to tell you that CCR is a routine activity of our university in which each department present a case on each Friday with a view to impart some practical knowledge to our students regarding disease outcome and its management. So before proceeding to the CCR, let me introduce our department. So luckily, this Friday it was our turn when Dr. V.S. Saraswat was planning to conduct a midterm meet of Indian National Association for Study of the Liver. So we combined both the things together to give maximum benefit to our students. So let me introduce our department. Department of Clinical Nutrition and Dietetics was established in the year 2012 with the aim to take care of nutritional needs of all IPD and OPD patients. Our services include clinical dietary services as well as academics. Under clinical services, we take care of nutritional needs of a broad spectrum of patients as we have all types of super specialty services in our institution like bariatric surgery. For example, a diet prescription for a 2-year-old PEM child will be entirely different from a diet of an adult with solid organ transplant. Similarly, diet prescription for a pregnant lady admitted in a obstetric ward with hyperemesis will have an entirely different diet prescription in comparison to a female admitted in critical care unit with HALEP syndrome or eclampsia. So it's just an example. We take care of a wide spectrum of patients' nutritional needs. In under academics, we run graduation, post-graduation, and doctoral courses in clinical nutrition and dietetics, as well as we provide facility of internship for nutrition students outside of our university. We have many publications in the national and international journals. This is our team. It is a very young and dynamic team, and I am really thankful to each and every my team member who are tirelessly working with me day and night for better patient outcome. These are the glimpses of our routine activities. We are doing diet counseling in individual as well as on group basis. We monitor kitchen also where patient food is prepared, as well as we do mass audits also where food is prepared for students. These are some pictures from our educational activities. We also take classes of elective courses and value-added certificate courses as well, which is open for all students of our university. We take sessions of nutrition not only in university but outside university. We are very active in different types of nutrition awareness programs, like we actively participate with our medical team in health checkup camps. We organize different types of nutrition awareness events in under breastfeeding week or national nutrition month, whether it be international women's day, and as well as outside of our university we spread nutrition awareness. Here are some glimpses. These are some pictures of our teaching and training programs which are provided to different staff members like kitchen staff or nursing staff or ASHA workers, and as well as we give training in inside ward also to attendants. So now come back to our CCR, which its topic is transplant, to give a clinical picture of the case. Welcome, Dr. Karan.
Good morning, everyone. At the outset, I would like to thank Dr. Vinita for such a warm and humble introduction. And happy World Health Day to all. As you know, today is the World Health Day, and the theme of today's Health Day is health for all. So we have taken a very simple case which is commonly encountered in our practice and which is related to a major stigma in our society, that is alcohol use. So how to prevent that, how to treat that, what are the ill effects, we will be discussing the journey of a patient. So we have a 35-year-old male who is working as a staff nurse in a government medical hospital who presented to our OPD with complaint of yellowish discoloration of eyes and urine for the last 20 days. It was a painless, progressive and non-cholestatic form of icterus which was not preceded by any prodrome in form of fever, malaise, arthralgia, Patient denied any history of alternate medicine use. There was no fever, no abdominal pain, no any other features of other chronic liver disease like ascites, hematemesis, melena, or altered sensorium as hepatic encephalopathy. There was no significant past or the past history of any major medical illness. Now the major thing is the patient was consuming alcohol. So first thing, as we have many PG students among us, the first thing is now the term alcoholic should not be used. It is a stigmatizing, demeaning to the patient. Instead of word alcoholic, the international consensus is to describe them as alcohol use disorder. It's a disorder, it's a psychological problem rather than stigmatizing the patient per se. So for the resident, when you are taking history of any patient who consumes alcohol, you have to ask five things. First of all, amount. What amount of alcohol he is taking? Like our patient used to consume 4 to 5 drinks per day, which is equivalent to 40 to 50 grams of alcohol. Frequency. At what interval he is used to take? Uh, then third thing is duration. For how long he is taking? Then is the episode of binge drinking. Binge drinking is if at a single time a male consumes more than 6 drinks and a female consumes more than 5 drinks, it is described as binge drinking. And when was the last intake? This patient had last intake 3 weeks back. He was taking 4 to 5 drinks per day for the last 3 years. And with the occasional episode of binge drinking once every month. If you can see very carefully, I've used the word drink, 4 to 5 drink. So what is one drink? A person may be consuming B to 330 ml of beer, 240 ml of the malt liquor, or 150 ml of wine, or 40 to 45 ml of whiskey, which is the hard liquor equivalent to rum, gin, or tequila. So these are the various alcoholic content in the various beverages, and amount of each of them is equivalent to 10 gram of absolute alcohol. So a person who is consuming 3 beers versus a person who is consuming 1 drink of whiskey, 3 beers are more hazardous than a single drink of whiskey. So it is the absolute alcohol concentration than the type of beverage, which is a common myth that I'm taking beer only, which is a soft liquor, so it will not harm my liver. It is wrong. Second thing for the resident is whenever suppose a person who is taking a liver disease to alcohol or not. To answer this, whether this alcohol is significantly leading to any pathological problem or not, there is a scoring system which is used to identify this alcohol use disorder, known as alcohol use disorder identification test, in short form audit. Audit C. This is simply based on 3 questionnaires, and for each question there is an answer for which there is a grading ranging from 0 to 4. You have to add the just the number, and if the score comes out to be more than 4, then the person is having alcohol use disorder, and that disease could be attributed to you drinking. And how many times you have an episode of binge drinking, that is more than 6 drinks. So this is a very important question. The commonly answer which we get in a OPD setting is, हाँ सर मैं तो पार्टी पे पीता हूँ. वो पार्टी की फ्रीक्वेंसी क्या है, पार्टी हर हफ्ते हो रही है कि रोज हो रही है, दैट यू हैव टू आस्क. So any score more than 4 indicates alcohol use disorder. So coming back to our patient, not deviating from the topic, our patient was having tachycardia, which is a surge response commonly seen in patient with alcoholic hepatitis, his edema and parotid swelling, again a feature of alcohol use. So while examining a patient with alcohol use or alcohol-related hepatitis, we have to also look for other stigmas or the signs of chronic liver disease. If I proceed from head to toe, we have to look for the fetor hepaticus. This is the ammonical order typically seen in patient with alcoholic liver disease. Spider nevi, dilated vessels in the superior vena cava territory, that is the upper limb and the chest and the backs. Gynecomastia in males and breast atrophy in females. Axillary hairs are lost. Dupuytren contracture typically on the ulnar aspect of the hand. There are contracture formation in patient with alcoholic liver disease and testicular atrophy. Fortunately, our patient didn't have any of these findings, but since they are a resident among us, I wanted to highlight what other things, positive things they must have to look for in a patient with alcoholic liver disease. Going by the examination, typically all the inspection, palpation, percussion and auscultation. In inspection, it was a flat abdomen with centrally placed umbilicus. In superficial palpation, there was no tenderness or normal temperature. In deep palpation, liver was palpable. While describing any organomegaly, we have to describe the extent of organ palpable, what is the consistency, what is the margin like, what is the surface of the organ, and whether that organ is moving with respiration and tenderness. So this patient had a 6 centimeter palpable level below the right costal margin, which was firm in consistency. having sharp edge, smooth surface, and it was moving down with respiration. Uh, Again, palpable liver in palpation doesn't mean hepatomegaly. It could be because of the pleural effusion. Sometimes sub push the liver down and make the liver palpable. So to actually see that whether it is hepatomegaly or not, one has to determine the liver span, which is determined by percussion. You have to percuss simple that finger method, that flexor fleximeter. Upper border is percuss, then the lower border, and in between the lines, the span is the liver span. If the liver span is more than 10 simple use disorder, I will put alcohol-related hepatitis as the first differential. But at the same time, we have to rule out other causes like infective viral hepatitis, drugs, autoimmune hepatitis, Wilson's, and biliary obstruction can also lead to similar picture. So we should not be perplexed by the only single history that patient is alcoholic and should not forget the testing for other causes. There can be combination of two things, or other things could be the superseding one. Coming back to the labs, in the normal the blood picture, the CBC, RFT, LFTs, and INR, patient was anemic with the leukocytosis. Again, I would like to emphasize leukocytosis is a picture of alcoholic hepatitis, can occur without infection also. So all the patient with raised counts in patient background history of alcohol doesn't need antibiotic. Raised counts are not equivalent to sepsis or antibiotic use. His INR was raised 2.4, prothrombin time of 24. Bilirubin, as you can see, was very high, 24.9, with direct fraction of 23.3. AST to ALT of 254 and 113, low albumin, GGT of 568. What does this GGT indicate? GGT in the biochemical parameters has only two indications. One, if it is elevated along with alkaline phosphatase, it indicates biliary obstruction. Isolated GGT elevated is a common feature which indicates recent alcohol use. If a person who is consuming alcohol and other tests can be normal, but raised GGT will indicate that patient has consumed alcohol. Second thing in this LFT is important thing is AST to ALT ratio. Normally alanine transaminase L for liver. Liver ALT is more specific to the liver injury. Any viral hepatitis, autoimmune, they will cause elevation of ALT. But in case of alcoholic hepatitis, it is the aspartate transaminase AST which is elevated more than the alanine transaminase. So as you can see that was more than ALT, and typically AST to ALT ratio of more than 2 indicates alcoholic hepatitis, is a cardinal features of alcoholic hepatitis. Other etiological factor like the viral screen for hepatitis B, C, A, and D we have ruled out. Autoimmune workup was negative. We have ruled out by doing anti-nuclear antibody, anti-smooth muscle antibody, and IgG level. Wilson's for screening, we did a ceruloplasmin level which was well within normal limit. In ultrasound, apart from normal hepatomegaly and slightly coarse echo texture, nothing remarkable. There was no ascites, mildly enlarged spleen, and slightly dilated portal vein. So we have the lab picture, we have the clinical picture. We after the clinical picture, now we have ruled out the other causes. So working diagnosis is probable alcohol related hepatitis. Again, we can't use word the definitive. To describe, label it as definitive alcohol related hepatitis, we need a biopsy. So what next for this patient? Uh, Whether we should do a liver biopsy to confirm the diagnosis, or we can start treatment just on the basis of probable alcohol related hepatitis. If we need a biopsy, do biopsy help in the management of alcohol related liver disease? And since this patient has having a coagulopathy, INR was raised 2.5, is it wise and safe to do a biopsy in such a coagulopathic patient or not? To answer these questions, first of all, is a liver biopsy needed to confirm diagnosis? Answer is no. Biopsy is not required. One can biopsy is only done only if there is a dilemma among the diagnosis. Suppose this patient is also consuming alternate medicine, Ayurvedic herbal medicine, or having some viral biomarkers also turns out to be positive. To determine which is the major factor leading to jaundice, we need a biopsy. Second question, does biopsy help in the management of alcoholic liver disease? Yes, biopsy doesn't help in diagnosis per se, it helps more in prognostication of the patient. Just a simple thing. In a biopsy, we have to look for two features. One is inflammation and one is fibrosis. Inflammation is reversible, fibrosis is generally irreversible. If we do a biopsy and find more of fibrosis and less of inflammation, then patient should be counseled straight away for transplant rather than trying and waiting for the medical management. And if the biopsy shows more of inflammation, then the patient should be tried with medical management, and then if medical therapy fails, only then he should be shifted for transplantation. And the other thing, the third question, how to do liver biopsy in a patient with coagulopathy? For that, it is a technique, transjugular liver biopsy. Instead of doing doing percutaneous directly, liver capsule is not punctured. A big biopsy needle is there around 3-4 feet long, which is inserted into the jugular vein like the central vein, and while crossing the internal jugular vein, IVC, crossing the heart, it reaches the liver, and without puncturing the capsule, we can take out a biopsy specimen. For this patient, we did a transjugular liver biopsy, which showed feature of neutrophilic inflammation. There was an mild increase in periportal fibrosis. There was a significant macrovascular steatosis. Ballooning degeneration of hepatocyte was also seen. Mammary duct bodies were there, and there was a pericellular fibrosis. Overall, the biopsy picture was favoring diagnosis of alcoholic steatohepatitis. So again, after the thing is the patient, how to assess severity in a patient who has now confirmed alcohol-related hepatitis. Since there are PG students also, this could be a neat question. There are two ways to determine alcohol severity in a patient with alcohol-related hepatitis. One is the discriminant factor, MADRS discriminant function, and second is the MELD, model of end-stage liver disease. For discriminant factor, the simple formula 4.6 multiplied by the prolongation in the prothrombin time, then add bilirubin level to it. If the values turns out to be more than 32, it is severe alcohol-related hepatitis. And for MELD, there is an online available calculator. Just feed the 4 values, you will get a number. If the value is more than 20, it is a severe alcohol-related hepatitis. So our patient has a definitive alcohol-related hepatitis proven by biopsy. Severity, it is severe as the MELD score is 32 and DF is 92. Now, how a patient with severe alcohol-related hepatitis managed? Here I would like to clarify on a common myth. Whenever a person have jaundice now, first thing the family do is now cut down the food. Would start the patient on boiled vegetable, stop oil, stop everything. So this is a common misconception and common myth. A patient with alcohol-related hepatitis or any jaundice, there should not be any restrictive diet. There should be additive diet. They should be fed extra rather than stopping their diet. So first of all, the principle is stop their alcohol completely, which the patient will always does. Second, and the most important aspect is nutrition. Patients should be encouraged to eat more, and more. There is only treatment for alcohol-related hepatitis which has proven to improve the mortality. And third one, among the medicines, it is a steroid. If the inflammation component is there in the biopsy, patient should be given a trial of steroid, short dose, short duration, 28 days. Another things, this pentoxifylline, silymarin, ursodeoxycholic acid, GCSF, and a common drug known as rehaptin is I commonly see in the prescription of patient with alcoholic hepatitis. They should not be used. There is not even a single trial showing their benefit. It is just a psychological thing. We are giving pentoxifylline, urso, silymarin, GCSF. There is not a single evidence which support their use in patient with alcohol-related hepatitis. Instead of giving these drugs, one should consult for the patient to eat more. So prednisolone is the standard medical therapy which improves short-term mortality. Coming to the importance from the diet in alcoholic hepatitis, here's a very beautiful study conducted by Mendenhall et al. In around 2001. Here you can see that if he took a patient with alcohol-related hepatitis and checked their calorie intake. If you can see that those person who was consuming more than 3,000 kilocalories per day, the mortality rate was less than 2%. And those who were consuming less than 1,000 kilocalories per day, their mortality rate increased to 40%. Similar study was conducted by Chetan Kalal et al. From ILBS. He divided the patient into two groups, one who were consuming more than 25 kilocalories per day and other who were less than 25 kilocalories per day. As you can see that increased calorie intake improved survival in patient with alcohol-related hepatitis. So it is not the medicines alone which will work. It is the diet which has to be given, supplemented along with the medicine to improve outcome in patient with alcoholic hepatitis. So to take the journey forward, then the dietary and the other aspect, I would like to call Dr. Samiksha to take the journey forward. Thank you.
Thank you, Dr. Karan. So, as a dietitian, the current issues to solve from our side was abstinence from alcohol, to improve the patient's food intake, and to prevent or improve frailty and sarcopenia if present. No, so we follow a standard protocol for the steps of nutrition care process, which involves or which starts with screening the whether the patient is malnourished, assessing the nutritional status of the patient, then determining what the nutritional diagnosis is, and accordingly plan the dietary intervention followed by monitoring and evaluation. The assessment of nutritional status assessment involves 4 steps, which are commonly said as A, B, C, D: anthropometry, biochemistry, clinical examination, and dietary record. So there are various screening tools available to assess the nutritional status or the risk of malnutrition in liver disease patients, out of which we use the Royal Free Hospital Nutritional Prioritizing Tool, commonly known as RFH NPT, because it is more objective in nature and does not require any special equipment. So here is the format of the Royal Free Hospital Nutritional Prioritizing Tool. It takes into consideration various factors, whether the patient has fluid overload, what was his BMI, and does he have unplanned weight loss in the past 3 to 6 months, what was his dietary intake. And accordingly, correspondingly, scores are given, with where the 0 score means that he is at low risk of malnutrition and score of 2 to 7 means high risk. Since our patient was a case of acute alcoholic hepatitis, he came under the category of high risk of malnutrition. Next, we assessed the anthropometrical parameters of our patient. He was found to be underweight as per his height. His BMI was calculated using height and weight, and it was found on the lower side of the normal range for adults. His other parameters which were of importance for us was mid upper arm circumference, which was measured using standard inch tape. Then skin fold calipers was used to determine tricep skin fold thickness, and the values here denote that he was having low body stores and low lean muscle mass. Next, the next step includes biochemical parameters, and the lab reports which were of nutritional significance here denotes that our patient was anemic and was deficient in vitamin B12 and vitamin D status. Now, the third step of assessing the nutritional status of a patient involves the clinical examination. So here's a picture of an elbow of a person. Can anyone from the students here tell me what condition this picture denotes and which nutritional deficiency causes it? Anyone from the audience? Yes? So this is spinoderma, commonly known as toad skin, which is caused by vitamin A deficiencies. So one more picture for you. Can anyone identify the deficiency associated with it and what this condition is called? Gliosis, because of riboflavin deficiency. All right, then this koilonychia, because of iron deficiency. And this is a picture of a tongue. Yes, indicating glossitis because of riboflavin deficiency. Now, some more signs and symptoms like gingival swelling and gum bleeding, perifollicular hemorrhage, both because of vitamin C deficiencies, then brittle nails and leukonychia because of calcium, protein, and zinc deficiencies. And also, thiamine deficiency is also very common in alcoholic patients, and the initial symptoms of those include paresthesia, anorexia, impaired reflexes. So this is the picture of our patient's status. We found that his skin was slightly dehydrated and his nails were pale, but there was no prominently visible sign of any underlying nutritional deficiency. Next, we assess the sarcopenia patient. Sarcopenia is the general loss of muscle mass strength, which happens because of advancing age, but is accelerated in case of liver disease patients. Sarcopenia was assessed using a tool known as short physical performance battery. Basically, this particular tool uses 3 different parameters. First is repeated chair stands, where the person is asked to hold his arms like this so that he is not taking the support of any chair, and is asked to attempt 5 chair stands repeatedly in a fast motion, and we record the time he is taking to do that. Next is balance test, in which 3 different positions, as you can see, he is asked to attempt each one for 10 seconds each. One is feet together. He has to just hold the position so that we can see what his muscle coordination strength is. Next is semi-tandem, when we touch the toe of one to the heel of another, and the third is full tandem. Each step for 10 seconds each, and we record the time. Third one is gait speed, when the person is asked to just walk for a length of 4 meters, and we record the time. Now, the short physical performance battery, on the basis of those 3 parameters, scores are given from 0 to 12, where the 0 denotes worst performance and 12 denotes best performance. Our patient score came out to be 9, which indicated that he was frail and possibly sarcopenic. Next, we wanted to assess the frailty in our patient, because frailty is of very importance in case of liver disease patients. Frailty means general loss of muscle function. Now, frailty is assessed using liver frailty index, which again uses 3 parameters: hand grip strength using dominant hand grip strength using hand dynamometer, then attempt of 5 chair stands, time is noted, and again balance testing when those 3 foot positions are recorded for 10 seconds each. So this was our patient status, and there are various online calculators available to identify what the LFI of the person says, and it came out to be 4.78, indicating our patient was frail. The fourth step of assessing the nutritional assessment is the taking dietary history of a patient. We asked the patient what his dietary history was for the past 3 days, and using standard comprehensive exchange list given by Indian food composition tables, we calculated what his energy, protein, carbs and micronutrient intake was. It came out to be suboptimal, or we say very poor, because he was taking only 50% of his energy requirements, 20% of his protein requirements, 20% of carb requirements, and so on, as you can see. So based on all those 4 parameters, A, B, C, D of assessment, where we saw that our patient was underweight, he had low muscle mass reserves, he was frail, malnourished, and his biochemistry reports revealed that he was anemic and was deficient in vitamin B12 and D. No clinical signs and symptoms, prominent clinical signs and symptoms were present, and his dietary recall indicated that he had suboptimal dietary intake along with his diet deficit in all the major micronutrients. So to conclude the nutritional diagnosis, it was found that our patient was malnourished. Now, I would like to request dietitian Kirti on stage to carry forward the case.
Thank you, dietitian Samiksha. So we move forward to the next step, that is the medical nutrition therapy. So basically in this, before proceeding towards the intervention plan, firstly we settle down the short-term goals and the long-term goals. So our short-term goals was to ensure abstinence from alcohol, to increase the overall oral intake so that we can improve the lean body mass as well as the muscle mass of the patient, and to correct micronutrient deficiencies that were present at the time of admission. For the long-term goals is to achieve ideal body weight, to maintain adequate micro and macronutrient status, and to impart nutrition education to the patient so that he improves the overall quality of the life. Next step is the guidelines. So the guidelines were followed as per INASL, that is Indian National Association for the Study of Liver. It is recommended that the patient of hepatitis should be given 30 to 35 kilocalorie per kg per day. Protein should be given to a higher range, that is 1.2 to 1.5 gram per kg per day, and emphasis should be there on mineral and vitamin count. So basically thiamine, vitamin D, vitamin B, C and magnesium and zinc are focused in terms of micronutrients. Daily nutritional requirements. So as per the INASL guidelines, we calculate the patient daily nutrition requirements which are shown in the table. So according to this, calories that were given were 1960 calorie, 84 gram of protein, 294 gram of carbohydrate and 50 gram of protein. Sodium that should be given to the patient is less than 5 gram per day, and micronutrient requirements were calculated as per the recommended dietary allowances. So the prescribed hospital diet and intake. So before proceeding towards the diet, vitamin B, iron and vitamin B12 were corrected as per the standard protocol followed by the clinician. For the diet, this is our table shown from day 1 to day 12. So basically, initially the patient was on liquid diet. As the patient was not eating well, the oral intake was very low. To encourage the patient, we started from the liquid diet to a soft diet and then shifted to a high protein diet. So from day 1 to day 12, it is observed that oral intake of the patient was improved in terms of calories as well as protein, from 600 calories to 1340 calories to 1835 calories at the time of the discharge. This is the next step, that is the monitoring and evaluation at the time of discharge. As seen from the table in terms of ABCD, that is anthropometry, biochemistry, clinical signs and dietary intake, we can see that the patient improvement was there from the time of admission, that is seen in the third column from the time of discharge. So overall the overall intake and the weight of the patient increased. This is the discharge diet plan that was given to the patient. So overall, a high calorie, high protein diet was given to the patient to improve the overall lean body mass and to improve the muscle strength as well. So various food groups are mentioned in the given diet chart. Overall, the emphasis should be also there while planning the diet plan, that we include a evening snack for them. Basically, whenever a patient has a dysfunction of liver, so the glycogen stores are very low. So whenever the patient is on long fasting, we need to give good amount of carbohydrate rich evening snack so that the patient muscle breakdown is prevented overall. This is the dietary recommendations. So dietary recommendation in such cases are abstinence from alcohol. We should encourage patient as much as he can so that the overall calorie as well as the protein count increases. Energy density foods such as we can give extra sugar, good, honey, butter, ghee should be given so that overall the patient's calorie intake increases. Regular salt should be given to maintain optimum diet intake, and high salty foods such as pickles, papad, chutney, namkeen should be avoided. So for the next step, I would like to call Dr. Vinita Bansal ma'am to conclude the case. Thank you.
Thank you, Kirti. As we can see that patients showed a good improvement in terms of anthropometry, physical ability and dietary intake at the time of discharge. We can also see that patient course on steroid and diet. Patient responded well on steroids when he was taking proper diet, and it is quite evident from the slide. All blood parameters were improved, and we called patient after 3 months, and we found a dramatic improvement in the anthropometry. Patient gained 12.5% of weight, and there was 25% increase in mid-upper arm circumference. Skin fold thickness was increased up to 83%. Hemoglobin was also increased because of diet also, and as corrective doses of iron were also given by our clinicians as well. Clinical signs were also improved, as when patient was admitted he was bedridden, but after 3 months he was walking without any support, and of course diet compliance was around 100%. He was following the diet which was prescribed at the time of discharge. So take home messages are: single drop of alcohol is dangerous to health. Nutritional frailty and assessment tools should be regularly and frequently used for these type of patients, not only for liver patients but also for other patients of oncosurgery or organ transplant who are at risk of malnutrition, as these are good predictor of malnutrition. Then nutrition is the most important aspect. Of course, we can say it is the first line of treatment for alcoholic liver disease patients. Earlier it was neglected, but now it is as important as medicine. So I would like to say thanks to our management, entire Department of Hepatology and Liver Transplant, especially Dr. B.S. RSS sir and Dr. Karan, patient and his family members for cooperating with us, entire CCR review committee, as their valuable guidance made this presentation dramatically improvement, and my entire team of Department of Clinical Nutrition and Dietetics, because without their support I won't be able to present this case here. Thank you so much. Yes, sir. Sir, 3 grams. Egg white will provide 3 grams of protein. Steroids were given by our clinician counterparts, so they can answer this question well. Any other query from the audience? Yes, sir. Yes, sir.
I think Dr. Kunteta's question was that are fibrotic changes in the liver following alcoholic injury, are they reversible? Well, I think there are good data now to show that even from the stage of cirrhosis, reversal can happen if there is strict abstinence from alcohol, no further injury, and comorbid conditions like obesity, which often coexists in alcoholics, in people who consume alcohol, is taken care of. So then, even from advanced fibrosis to cirrhosis, reversal can happen. But then this requires abstinence over a period of years, not days, weeks, or months. After 3 or to 5 days, we are now doing fibroscan regularly in our department, which documents reversal of stiffness and resolution of fibrosis.
while the inflammatory phase, of course, is resolves quite quickly. Yes, Dr.
Which is the preferred route for a biopsy, a transjugular or a transcutaneous, and why?
Biopsies these days now are done by multiple routes. Even endoscopic ultrasound guided biopsies are being done from the both lobes of the liver. So percutaneous, transjugular, and these. The standard procedure is percutaneous liver biopsies. But in people who have high risk of complications like severe coagulopathy, deep jaundice, or large ascites, where whenever you do biopsy through an ascitic fluid, you're going to get complications of hemoperitoneum, you prefer a transjugular route. So since our patient had this person had very deep jaundice and his INR was also prolonged, I think it's 2.4 or 5. So it was safer to do it as by the transjugular route. I think our intervention radiologists are doing it regularly and we're getting good quality tissue from the transjug route. Ji, Doctor.
Sir, since there is some time, I will like to highlight that nowadays we are getting more and more patients of non-alcoholic fatty liver disease and extending it to hepatitis and then cirrhosis of liver, and then of course many of them are also developing hepatocellular carcinoma. So please throw some light on this.
Well, I think as and when the Department of Hepatology gets its turn for doing a combined clinical round, we are planning to discuss this topic. This, in fact, today, I think there are statistically recorded data which show that about 35 to 40% of the population of our country, you can imagine the numbers, and globally the prevalence is 25 to 30% of fatty liver disease. Normally, healthy liver contains 5% fat. And ultrasound picks up grade 1 fatty liver once it crosses 30% fat in the liver. So the presence of fat goes through stages. People can simply have so-called metabolically healthy obesity with fat in the liver but no inflammation. But about 20-25% of them over a period of time will develop inflammation, which becomes hepatitis, steatohepatitis, which another 15% of this group with steatohepatitis progresses to cirrhosis. And today, one of the most common causes of liver failure is so-called cryptogenic cirrhosis, which is due to fatty liver disease. And one of the largest indication, most numerous indications for liver transplant is NAFLD. And NAFLD also results in hepatocellular carcinoma. So the full spectrum of liver disease is replicated by fatty liver. And alone itself, it creates problems, but quite often people drink, and many who drink are overweight. People are diabetic. They may be taking medications for various conditions which will exacerbate the fatty liver. So it plays a significant role in the progression of other causes of liver disease as well. And it's an important public health problem which needs to be managed aggressively. Well, I think Live 52, you should ask from the Ayurvedic fraternity what their rule is. There is no clinical trial or data from in clinical hepatology or medicine that supports any beneficial effects. Empirically, they have been given and they are supported, but the standard test that we follow of evidence-based medicine using randomized controlled trial data to show benefit, it does not exist for these products. As I think Karan did point out, silimarin, ursodeoxycholic acid, there is a long list of other medicines that have been tried for alcoholic hepatitis without much benefit. So, not established.
Used as a common appetite enhancer for the public, people who are not having appetite, give them sorbilin. One time, the sorbilin sample have been tested. They have been found to contain 13% of absolute alcohol. That's why the appetite increases. A patient consuming the sorbilin leading to alcoholic hepatitis, no cause was found out. Finally, the sorbilin was the cause of alcohol-related hepatitis.
Well, see, I think drop is going a bit too far when you say that. I think Karan talk to you about the quantum of drinks. Now, I think the frequently asked question is Is it safe to drink? No, it depends on how you define safety. If the concept of safety is that I drink this quantity indefinitely for prolonged periods and still there will be no harm to the liver, then I guess the statement that Dr. Karan had made, that uh, there is no safe quantity of alcohol defined, holds good, because if you even consume so-called safe drinks, that is up to 2 drinks in men and 2 to 3 drinks in men per week, and 1 to 2 drinks per week in women, over a period of time, as over if you follow it up for 20, 30 years, these people will develop alcoholic liver disease, cirrhosis. Whether they eventually succumb to it or not is a different question. So when we consume alcohol, you are trading the pleasure of the alcohol for some injury. And if you stay in moderation, that is fine. The alcoholic liver disease, at autopsy at age 90, you might have a cirrhotic liver, but you have been healthy and well during life. On the other hand, it will be an extremely small minority of people who consume only 1 drink a week for their life. Invariably, people, the quantum of alcohol they consume goes up over time. People get into binge drinking. Drinking wine with food, people generally consider healthy, but now there are data from France and European countries that even these people eventually will, over a period of time, develop liver disease. So I guess safety is very much in the eye of the beholder. If I take one drink, I may be well for 10 years, and nothing may happen. But for over a life span, it creates problems.
Sir, there's a like passive smoking. How much is the passive alcoholism, that alcohol fumes if you are sitting with the friends?
Passive smoking, yes. Passive drinking, no. Nothing much happens from the fumes. I think a more pertinent topic to this would be your gut microbiota. You may not know, but there is endogenous alcohol production from the gut microbes when you consume this, and some research studies have quantified, but except in very rare situations, these are small quantities of alcohol to which the individual is exposed, and they generally have not been implicated in any liver disease. जी. Apart from drinking alcohol, alcohol के बारे में डिटेल बता दिया कि इससे क्या होता है, क्या नहीं होता, we have discussed about. But apart from alcohol, what other things one must carry as a lifestyle to have a healthy? Apart from alcohol, we have discussed, but what would be the other lifestyle? Probably. I think the question that was asked, I think the most important one is to maintain your ideal body weight and regular exercise. People have talked about 2 to 4 cups of coffee if they are taken, that is black coffee without sugar and milk, prevents a lot of inflammatory liver diseases as well as disease in other parts of the body. But I think maintaining an ideal body weight is probably the best way to ensure that the fat content in the liver does not increase and fat related injury does not happen. And I guess that is probably even or as tough as giving up alcohol for a person who uses alcohol, because losing weight is one of the challenges of modern day life. We have gotten into a dietary habit of fixed times and fixed meals, where whether you are hungry or not, you open your tiffin and you sit down and have your meal because that's what is expected. But with that, you do not spend the kind of calories you consume, and fat accumulates and eventually leads to problems. Right. Dr. Vinita, yes, sir. So, nutrition is important, as you have said, for all patients. And we all know that egg is a very good source of the vitamin that protein also was trying to ask. So, those people who do not want to take egg, what are the good sources of vegetarian sources of protein, which are not very expensive, which we can tell patients that consume these items in the diet?
Yes, sir. Actually we counsel patients regarding dietary exchanges also, to give a variety in their diet. In place of one egg, if doesn't want to eat egg, then 40 grams of paneer or 30 grams of roasted chane or 50 grams of tofu or 1 katori dal can be included. That will replace the quantity of protein equivalent to one egg. Yes, sir. Yes, sir. Yes, sir. Hmm. Yes.
Becomes like just like function like egg.
Yes, sir.
So
Yes.
just like that mechanism, we can suggest the patient
Yes,
so
sir.
that it can
Definitely.
give the benefit of the
Hmm.
complete protein. Like
Yes, sir. Yes. Egg is the complete protein, but cereals lack lysine or pulses lack methiosin. So the ideal way to eat diet is, sir, whatever we are eating in a traditional Indian diet is mixed diet, in which we combine things together. We eat rice with pulses, or we eat khichdi in which rice and pulses are mixed. We eat dalia in combination of pulses. So I think we eat idli and sambar. Batter is mixed with, in dosa batter also rice is mixed with urad dal. So that is the I think very nice practice to provide a maximum optimum quality of the protein, as it will give complete protein to us. Yes.
It's Dr. Vinita's show. She tells you that the show is over. Okay, thank you very much.
Thank you, sir.
I only have a request to the
How are you?
that we should probably answer the diabetes. Thank you all.
Thank you so much. Thank you, sir.
everyone. First of all, I'll welcome you all on behalf of Mahatma Gandhi Medical College and Indian National Association for Study of Liver over this single theme meta meeting on nutrition in chronic liver disease. Over next 2 days, we'll discuss the role of nutrition in CLD, what to do and how to do it. As we all know, nutrition is very important in all patients who are sick, who have chronic liver disease, and it is one of the neglected aspect that we see in our day-to-day practice. And malnutrition is very common in these patients of chronic liver disease because of poor oral intake, their restrictions in their diet, catabolism, sepsis, altered sensorium, and multiple GI issues that they face. So it's need of our to understand the basic concepts of nutrition, how to do nutritional assessment and manage these patients. So today we'll start with our first session that is on nutritional assessment in chronic liver disease. To start the session, I'll invite the chairpersons, Dr. Sandeep Nijavan sir, Professor and Head, Department of Gastroenterology, SMS. He is President, Indian Society of Gastroenterology, to the dais. Dr. Mukesh Kalla sir, he is Director, SR Kalla Hospital, a senior gastroenterologist and therapeutic endoscopist, and has keen interest in POEM and third space endoscopy. So I request the chairpersons to start the proceedings.
Good morning, ladies and gentlemen. Welcome to the first session of a single theme INAZL midterm meeting. The first session is on nutritional assessment in chronic liver disease, and we have 3 talks in this. And the first talk will be by Dr. R.K. Dhiman. He doesn't require any introduction to this gathering. He is a senior hepatologist. He is the president-elect of INAZL and is presently director at SGPGI. And he has got special interest in hepatic encephalopathy, liver transplantation. He has got more than 400 national and international publications. And he will be speaking why is malnutrition important in liver cirrhosis. Dr. Dhiman, please.
Thank you, Professor Nijavan. At the outset, I'm thankful to Professor Saraswat and his team for the invitation to this very important meeting, that is in nutrition in chronic liver disease. Framework of my talk would be that I will first discuss in very short definitions, then the impact of the malnutrition specifically in relation to the 2 phenotypes of the malnutrition, sarcopenia and the frailty, and finally the conclusion. Malnutrition. It is a clinical syndrome that results from the imbalance of the nutrition, whether it is a deficiency or the excess, and that cause miserable adverse effects on the tissue and the body forms. Body form means body shape, size and composition, or function, and our clinical outcome. Outcomes are also included. It represents a spectrum of the nutritional disorders across the entire range of the BMI, and it leads to adverse physical effects manifesting phenotypically as frailty and the sarcopenia. As far as the prevalence is concerned, the global is between 24 and 82%, and it is higher in India, that is between the 47 and 84%. And the higher prevalence of the malnutrition in Indian population is because of dietary differences and lower mean muscle mass in Indians. And it increases with the age, severity of the liver disease, as the liver disease severity progresses from child A to the C, and similarly with increasing MELD score. It is higher in men than the women and in patients with the alcoholic liver disease. Coming to the phenotypes, that is the sarcopenia. It is a progressive and generalized skeletal muscle disorder associated with an increased likelihood of the adverse outcomes, including falls,
fractures, disability, and the mortality. And this phenotypic representation is primarily the loss of the muscle mass. Frailty, a clinical state of the decreased physiologic reserve and increased vulnerability to the health stressors. And the phenotypic representation of the impaired muscle contractile function. So this is the one figure that summarizes everything and practically answers the question that has been raised to me. If you know that there are several factors that leads to the malnutrition, it is inadequate intake of micronutrients or uptake also, and the excess of intake of the macronutrients. So many factors that leads to the malnutrition. And in addition, there are other factors like cirrhosis related factors and other systems factors, including the physical inactivity, environmental and organizational factors that lead to the malnutrition. If you focus to diagnose all these problems, it is very difficult bedside unless we have the phenotypic representation in the form of the frailty and the sarcopenia. And these factors that I have told you that leads to the malnutrition, they also independently affect the frailty and the sarcopenia. And these two phenotypes ultimately they lead to the adverse health outcomes, which include increase in the decompensation of the liver disease, increased healthcare utilization, maybe the repeated hospitalizations also, healthcare also burden also, and decrease in the health related quality of the life, mortality, and ultimately adverse post transplant outcomes. So the practically if you see over here, the two phenotypes ultimately leads to the adverse health outcomes. That is the reason why the malnutrition is important in chronic liver disease. And moreover, I would like to tell you that it is all reversible also, that it becomes very important for the screening purpose, for the diagnosis purpose, and the reversibility factor also. So there are several impacts, including negatively impact on the morbidity and the mortality in patients with the cirrhosis. It affects mortality both before and the after the liver transplantation. I'll come to them one by one. More likely to have the hepatic decompensation in the form of the hepatic encephalopathy or ascites, reduced quality of life, increased risk of the infection, and so on. And in patients with a NEFR, the patients have higher likelihood of having this steatohepatitis or advanced liver fibrosis. It is associated with the decreased survival, increased treatment-related mortality, and tumor recurrence in patients with the SCC and in children with the end-stage liver disease. Sarcopenia is associated with adverse outcomes, including growth failure, hospitalization, infections, and the motor delay also. And coming to the first evidence that I'd like to tell you, I would like to discuss the three meta-analyses and the systematic reviews. The first one is the aim was to study the association between the sarcopenia and the risk of the mortality. It included 22 studies with of approximately 7,000 patients. And what they have concluded that sarcopenia, if assessed by the L3 and SMI means skeletal muscle index, it was associated with approximately twofold higher risk of the death. And every 1 centimeter square per meter square increase in L3 SMI and 1 millimeter per meter increase in the transverse Swiss mother thickness, they were associated with 3% and 12% reduction in mortality risk. That means if it is reversible, then the mortality also goes down. That is a very important message. And the better survival has been demonstrated after the TIPS in patients in whom skeletal muscle mass increased compared with those in whom skeletal muscle mass did not change or become less. And what they have demonstrated that the sarcopenia prevalence is around 40% in this population in meta-analysis. It is more in male, I already told you, in patient with alcoholic liver disease, and more in increasing severity of the liver disease. As far as the cumulative survival is concerned, 1, 3, and the 5 year, it was lower in patients who were having the sarcopenia compared to those who did not. So I would like to conclude this meta-analysis by saying sarcopenia alone is highly and independently associated with the higher risk of the mortality in patients with the cirrhosis. And the improvement in the sarcopenia is associated with decrease in the mortality risk. That's the more reasons why the malnutrition is much more important in this patient and has to be screened and diagnosed as early as possible and treated. Another systematic review and meta-analysis that included 19 studies, approximately 3,800 patients, and the prevalence of the sarcopenia was assessed on the CT, varied between 22 and 70%. An association between the sarcopenia and the post-transplantation and waiting list mortality was described at the 4-6 in 4 out of the 6 and the 6 of the 11 studies. What they have concluded that the pooled hazard ratio of the sarcopenia, which was independent of the MEL, and the post-transplant mortality was approximately twofold higher. And similarly, the wait list mortality is again nearly twofold higher in these patients. And ultimately, that can be concluded, sarcopenia is an independent predictor. Once I am saying the independent, that is independent of the MELD or the CTP for outcome in liver transplant patients. So there are limitations with the MELD also. Because it's failed to assess the nutrition and the functional status of the cirrhotic patient. So there is one study where they have included the sarcopenia in the MELD score, and they demonstrated it improves the utility of the predicting survivor, particularly useful in MELD score which is less than 15 or child's PUG score of the A and B, that is the compensated or early decompensated cirrhosis, is particularly helpful if the sarcopenia or nutritional status is added to the MELD score. And here you can see in the picture also, those who are having the sarcopenia, they have the decreased survival. Another meta-analysis of the 47 studies, 8,850 patients also, and the primary outcome was the pre and the post-transplant mortality. Very definitions, and they have used so many nutritional assessment tools also. But one thing they have concluded, irrespective of the diagnostic definition or the diagnostic tool that they have used, they have demonstrated that there is increase in the post-transplant mortality. In addition, they have also demonstrated sarcopenia via cross-sectional imaging associated with the strongest evidence of predicting the post-transplant mortality. I would say this kind of the study, they are the gold standard as far as the sarcopenia assessment is concerned. So far, I was discussing the studies which were having the ambulatory patient, and this is the one study where they have included the acutely ill man undergoing urgent evaluation and the liver transplantation. And the conclusion, the results are the same, that those who are the sarcopenic, they have the increased mortality. And they have also concluded that those with the sarcopenia were more likely to male to have ascites, a higher MELD score, and the need for the hemodialysis also. Almost the similar conclusions that we have in the previous studies. Now coming to the impact of the frailty. And in a prospective 300 outpatient study, frailty was described by the CFS and with the score of more than 4, and the primary outcome was unplanned hospitalization or the death within 6 months of the study entry. And out of these, 18% patients were frail, and 30% of the patients, they had unplanned hospitalization or the death within the 6 months. And they concluded that the CFS more than 4 was independently associated with the increased rates of the unplanned hospitalization or the death, and with a odds ratio of 3.6. And there was also dose response they have demonstrated with the odds ratio of the 1.9 per 1 unit increase in the CFS. So the frailty independently is also affecting the mortality in these patients with this liver cirrhosis. The frailty is strongly and independently associated with an increased risk of the unplanned hospitalization or death in outpatients with the cirrhosis. There are many other studies also. In other study, the frailty which was measured by the liver frailty index, and they have also demonstrated that frailty is associated with a nearly twofold increased adjusted risk of the death also. And in others study where the disability was assessed by the need for some assistant with three or the more ATLs, and they have the similar conclusion that there is a two-fold increase in the mortality, and the odds ratio for 90-day mortality was 1.83. Changes in the frailty over the time, and what they have demonstrated, whether it's the worsening or the improvement, and they also govern the mortality risk in these patients, in this population also. Over 1093 patients cirrhosis at 8 US centers, they have included these patients, and what they have demonstrated, each zero point 0.1 unit change in the liver frailty index for the 3 months, which was associated with the twofold increased hazard ratio of the waitlist mortality, and it was independent of the MELD score. Cumulative rates of the waitlist mortality at 6 months were 12% among those who experienced severe worsening compared with the 7% among those who remained stable. And what they have demonstrated that improved frailty scores demonstrate 6-month cumulative incidence of waitlist mortality only 0.6%. That means if there is an improvement in the frailty, that also causes the decrease in the mortality also. Otherwise, it increases. This is the another very important study and the last study that I'm going to discuss. That is a functional decline in the patient with the cirrhosis awaiting the liver transplantation. And they have objectively measured functional decline in patient with the cirrhosis awaiting the liver transplantation and its association with the waiting list mortality. The patient, those were listed, they have the MELD score of the more than 12. Single sender underwent functional status assessment every outpatient visit and using the short physical performance battery. So it score is between the 0 and the 12, and the 12 is the robust, and it consists basically of the gait, chair stands, and the balance tests also. So these are the results. Here you can see grip strength. If there is an increase per kilogram increase, that is improvement. It is associated with the decreased hazard ratio and the reduction in the waiting list mortality by the 11%. Similarly, for the gait speed as measured, increase in 1 meter per second, again improvement, reduction in hazard ratio, and the reduction in the mortality by 28%. But in opposite, there's a chair stand where the it increases by per 1 second, and it is an impairment, and they have demonstrated increase in the hazard ratio and the increase in the mortality, the waitlist mortality by the 7%. And here you can see the three scenarios, that is the predictive probabilities of the survival for the three males who have the baseline grip strength of the 30 kg and the baseline MELD score for the 17, and it does not change for the next 12 months. What happens in the first scenario where there is no change in the grip strength, and here you can see the survival, and the next scenario is that there is a modest decline in the grip strength from 30 to 26%. So there is a decreased survival, and the ultimately the maximum impact is on when there is a severe decline in the grip strength, that is 30 to 20%, and there is a reduction of the survival you can see in each panel. And we can conclude the liver transplant candidates experience significant functional decline on the waiting list despite modest wait time and the low baseline MELD. So it is very important that these parameters has to be sought in these patients who are in the wait list for the liver transplantation. And decline in the physical function is associated with an increased risk of the death and the delisting independent of the liver disease severity. So, ladies and gentlemen, I'd like to say that I have produced in front of you several evidence that say that there is an importance of the as far as the diagnosis and the treatment of the malnutrition in patient with the chronic liver disease. And I would like to conclude the prevalence of the malnutrition in patients with the cirrhosis is high. Frailty and the sarcopenia are important phenotypes of the malnutrition in patients with the cirrhosis, and the sarcopenia is a robust predictor of a wide spectrum of the outcomes in the adults with cirrhosis, including mortality, both before and after the liver transplantation, hepatic decompensation, reduced quality of life, increased risk of the infection, and the prolonged hospitalization. And the frailty has been strongly linked with the mortality in both the ambulatory as well as in acute care settings as in the post-transplant setting. And early diagnosis and management of the malnutrition is thus the need of the hour in these patients. Thank you so much.
Thank you, Dr. Deepan. It was an excellent talk with very crisp take-home messages. One question is like almost all cirrhotic have malnutrition, like 70 to 80%. Then in our clinic, we should have assessment for the nutrition for each and every patient. So you should have a nutritionist at your clinic because there has to be some objective evidence of malnutrition, and accordingly, I mean, you can act and improve the nutrition. So, what is your take on that?
I think you are right. If you say that if the 80%, approximately 80% of the cirrhotic patients, they have malnutrition or the different kinds of the phenotypes in these patients, and if they have the adverse health outcomes also. What you said, I think it is right, that you have to screen these patients who requires the complete assessment for these with the nutritional tools also. And once you find, you rightly said also, you should have a nutritionist also to take care of these patients. I think we have the department in AIMS. It is not a department of the gastroenterology, but also the human nutrition, which is the very important part of treating the not only the gastroenterology or the patients with the liver diseases also. I do agree with you.
I hope I'm audible with microphone seems to be malfunctioning. I think the point you made about the extensive prevalence is there, that improvement of frailty or improvement of malnutrition also improves the outcome. But I mean, the question is which subset of cirrhotics do you choose? People who are decompensated, ascitic, who are already very severely sarcopenic, does it all, are they the targets for treatment, or should people who are more robust and more active be better targeted for improving results and outcomes of transplant?
The studies those have focused, including 3 meta-analyses also, and the results demonstrated that it is child A or B cirrhosis. And similarly, the MELD score also reasonably well maintained MELD score. These are the patient who gets the most benefit from the intervention for the nutrition. But it does not say that the others will not benefit also. So whatever the approach we have with these patients, I think as a hepatologist, I would continue with those patients also.
Thank you, sir.
Thank you so much.
Thank you. has interest in ECLF and Rebecca as well. And he has to spearhead 100 national public meetings. Stage is yours.
Thank you. May I have my slides, please? At the outset, I am extremely thankful to Dr. Vivek Saraswat and really amazed at his stamina of continuing to organize the CMEs. And at the palatial auditorium, which looks like our alma mater auditorium at Ames. What I'm going to talk to you is the relevance of the sarcopenia as well as the pathogenesis of sarcopenia and frailty. At the outset, let me be very clear, going by the format of the academic exercise today, there's going to be a lot of repetition, not only in my talk, but in the subsequent talks also, because of the overlapping topics. But this may be to our advantage because it will try to reiterate what we're trying to learn, or it may be taken as an annoyance because of the repeated repetition. So, may I have the slides, please? Till the slides are ready, can I ask the question to Dr. Dhiman? If you do the same studies in patient with renal failure, and if you look at sarcopenia, those with sarcopenia or without sarcopenia, is the outcome different? Suppose a patient of kidney disease, and you look at the outcome. So does sarcopenia matter in, say, CKD? Any disease undergoing any major surgical intervention, if you look at the muscle mass, would it be same or different?
This one's working.
Thank you. Yeah, as the slides are ready, the topic which has been allotted to me is frailty and sarcopenia and chronic liver disease, pathophysiology and clinical significance. All of us know that cirrhosis by default is a progressive disease. So it was very difficult to see one of the meta-analysis presented by Dr. Dhiman that over a period of time of 1 year, some of the patient will continue to have the same MELD score. I thought it was a progressive disease, and with passage of time, most of the cirrhotics will decompensate and will present with ascites, hepatic encephalopathy, variceal bleeding, renal dysfunction, and finally hepatocellular carcinoma. We do have robust tools to look at this decompensation, which can be predicted and analyzed objectively by looking at the CTP score and the MELD sodium score. But here is a new entity called sarcopenia, which negatively impacts the survival, the quality of the life, response to the stressors, and increase post-op hospital stay. Unfortunately, there is no robust way of assessing the type of dysfunction in the form of sarcopenia because of the concomitant and compounding problems of associated obesity as well as the presence of the ascites, which tries to mask the assessment of sarcopenia. As elegantly showed by Dr. Dhiman, that there are strong association of sarcopenia with increased mortality, septic complications because of the hyperammonemia, presence of the overt encephalopathy, and increased risk need for hospitalization, as well as increased risk of infection after surgery. And hence, there is a, as Dr. Sandeep also very rightly said, we need to have some robust parameter to objectively tell us as one stop solution for assessment of sarcopenia, that too in our busy practice in day to day, knowing very well that majority of the practice is still in the private sector in the Indian scenario. Is it prevalence? And answer is big yes, as has been previously mentioned, that majority of the patient, more in the alcoholic than in non-alcoholic cirrhosis, do have underlying malnutrition. Depending upon the type of parameter you use to assess malnutrition, the various studies have shown the prevalence to be ranging anywhere from 20 to 50%. In fact, the veteran administration group in US showed that almost 100% of the patients who are undergoing liver transplantation do have sarcopenia and malnutrition. This is one of the studies which shows us the prevalence of sarcopenia in various setups in depending upon the type of the diagnostic criteria which we use to assess the sarcopenia. So what is malnutrition, what is sarcopenia, and what is frailty? Let me just try to redefine and define it for you. Malnutrition is defined by WHO as a disease entity which either has a deficiency or excess or imbalance of either the energy or the nutrients. So that can be in the form of skeletal muscle loss, adiposity, adipopenia, as well as micronutrient. So it is a composite combination of all these factors. Too much of the fat, too little fat, skeletal muscle loss, and micronutrient deficiency. That is what is malnutrition as per the WHO definition. Whereas if we talk of sarcopenia, which is more relevant to us as clinicians, as treating hepatologists, it is a combination of the three things. You need to have loss of the muscle mass, which can be documented by various means. You need to have a loss of skeletal muscle strength, which can be depicted by just looking at the hand grip exercise, and loss of skeletal muscle function, which can be picked up by the frailty index. So a combination of the mass, strength, and the function, that is sarcopenia. Whereas frailty is just a state in which you are vulnerable because of your non-resilience to the number of different stresses, which could be in the form of trauma, surgery, etc. It primarily involves two things. It involves weight loss and sarcopenia. It has a clinical phenotype which is defined by Fried Frailty Index. As Dr. Dhiman has told us, frailty is something which has been derived from the geriatric population. Everybody understands in the common colloquial language, a frail person means a person who is more prone to develop all sorts of problems. And how do we document it? You look at the 5 parameters: weight loss, exhaustion, slowness of the gait, slow physical activity, and weakness. Mind you, all of these are subjective parameters. But for us as treating clinician, as Sandeep has really pointed out, that we need to have one objective parameter to tell us sitting in our busy clinics what is sarcopenia. And this is the generally accepted definition, which is gender and age and BMI specific, which is a combination of the muscle mass, muscle strength, and the muscle performance. For us, I think an L3 SMI gives an excellent index which has the best correlation. And finally, before trying to decide which patients are likely to have problems following liver transplantation, we have this new index which has a combination of, it has a trinity of three things: liver grip strength, timed chair stand, as well as the balancing testing. And depending upon this computer generated formula, anybody who has an index of more than 4.5 is supposed to be having a high liver frailty index and is likely to have more mortality. This will be discussed by Dr. Sareen in the subsequent talk. Why do we have sarcopenia at all in patients with chronic liver disease? You have portal hypertension, its complication. You have a state of so-called pro-inflammatory cytokines landing up into the various components in the intra and extracellular fluid compartments. You have hyperammonemia. You have physical inactivity because of the disease process and concomitant obesity. You have impaired insulin resistance, both because of the liver disease as well as because of the NASH per se, in addition to poor reserves of the glycogen in the liver with concomitant increase in hepatic gluconeogenesis. What causes malnutrition in patients with the chronic liver disease? You have poor dietary intake, you have concomitant malabsorption, and you have a lot of metabolic disturbances. The reasons for poor intake include nausea and vomiting because of the ascites. You have impaired gastric and the gut motility. Patients do have poor appetite because of the upregulation of the leptin and TNF alpha, which is a part of pro-inflammatory cytokines. You have altered taste because of the zinc deficiency. You have restriction of the diet, because we tend to tell our patients, especially with a poorly conceived idea, that if somebody has had encephalopathy, they should have a protein restriction in the diet. You tend to restrict the salt in the diet. By the default, patient will take less diet. And finally, alcohol per se is a major cause of chronic liver disease, and most of these patients will be spending more time drinking alcohol than having a good diet. In addition, these patients have malabsorption, which results in photosystemic shunting, which is also caused by chronic pancreatitis because of the alcohol. There is a bile acid deficiency, especially in patients with cholestatic liver disease. Repeated GI bleeding may lead to loss of the protein, and then you have concomitant small bacterial overgrowth syndrome, which can lead to uh, malabsorption in these patients. In addition, the state of the cirrhosis is associated with a lot of metabolic disturbances. And as Dr. Deeman said, that muscle is an important metabolic organ in the total homeostasis of the body. In hypermetabolic state, you have patients with increased sympathetic activity, hyperdynamic circulation. Obese patients typically are less likely to move around and have associated endocrinopathies. And patients with sepsis have a lot of cytokine storm, which is leading to changes in the muscle functioning and the muscle strength, as well as increased gluconeogenesis, which is a component of the poor glycogen reserves in patients with poor functioning liver, is associated further with the breakdown of the fat and muscle. All of these individually and collectively lead to loss of the muscle strength, function, and the mass. In addition, patients have alteration in the pro-inflammatory cytokines because of the hyperdynamic circulation and alteration in the gut barrier function. There is a transgression of the pro-inflammatory markers as well as the bacteria and their bacterial products across the gut membrane into the circulation, leading to pro-inflammatory states in the various parts of the body. All of us know that by default, cirrhosis is a prolonged fasting starvation state, and fasting in of 8 to 10 hours in cirrhosis is akin to fasting in 72 hours in a healthy person. And in addition, there is a recurrent loss of the protein because of the GI blood loss, repeated paracentesis, and diuretic use. If you look at the muscle, the way the muscle is formed and broken down and homeostasis is maintained, there are three major enzymes which tend to lead to proteolysis, that is muscle breakdown. UPP pathway, lysosomal autosomal pathway, as well as calcium dependent calpain pathway. And if you have a reduction in the muscle mass strength, that is sarcopenia, so these two enzymes will try to suppress the formation of the muscle, that is myostatin and the AMK kinase, whereas there is two genes and the enzymatic pathways which will tend to cause synthesis of the protein, that is mTOR as well as the IGF-1, which is locally produced. In the normal course of the events, the moment you have glucose and the amino acids, they go into the cell and they tend to stimulate mTOR. mTOR is something which is going to lead to synthesis of the protein. There is also a good homeostatic mechanism that if you have too much of the protein synthesis, same AKT which is stimulating mTOR tends to stimulate FOX receptors, which will lead to protein breakdown. So there is a balance which is maintained. That means if you are having lot of substrate in the form of glucose and amino acids, you are going to produce a lot of protein. And if the too much of the protein is produced, that is sensed by AKT, which tends to balance the production, overproduction of the protein, leading to the muscle breakdown. However, what happens in patient with cirrhosis of the liver is that if you are having poor nutrition, you will have reduced supply of the amino acid into the muscle, so that the muscle mTOR is not stimulated. But unfortunately, the AKT pathway, which is stimulating the breakdown of the muscle, that continues to be active. So the muscle formation is getting decreased, whereas the muscle breakdown continues. So this imbalance between the two leads to a state in which you have muscle loss. In addition, hyperammonemia, which is a cardinal component of the decompensating liver disease, results in impaired muscle protein synthesis. It increases muscle autophagy, leading to the muscle breakdown. It leads to increase in the NF-kappa B, which leads to increased expression of the myostatin, which is an inhibitor of the protein synthesis. It also leads to mitochondrial dysfunction, so that energy is not generated. And because of the consumption of the BCCA in and by utilization of alpha ketoglutarate, you have a deficiency of the TCA substrate called alpha ketoglutarate. Let's see what happens in fed state. In fed state, you have a carbohydrate and glucose, which is the primary substrate for a number of organs. If you have an overnight fast, then you tend to have glycogen, which is utilized for energy. Unfortunately, in patients with liver disease, you do not have enough glycogen storage, and hence you have to bank upon amino acids as well as the fat to give you additional source of energy. This is called gluconeogenesis. Now, since there is not enough of glucose in the body, so muscle breaks down. Once the muscle breaks down, it produces two types of amino acid: branch chain amino acids as well as the aromatic amino acid. Now, muscle has an enzyme called alpha ketoglutarate dehydrogenase, which is typically located in the muscle bone. So, BCCA is used to form glutamate, which tends to take excessive ammonia from the blood to produce glutamine. So, muscle is doing a job of extracting hyperammonia from the circulation and trying to deactivate it. But the muscle is also producing a lot of aromatic amino acid which cannot be used in the muscle. So the muscle breakdown of the protein is only leading to depletion of the branch chain amino acid, whereas aromatic amino acid continue to go up. So this imbalance between the two results in something called imbalance between aromatic amino acids and the branch chain amino acid. And I'm sure Dr. Dhiman is the leading person in demonstration of hepatic encephalopathy related to this alteration in the aromatic amino acids. And we know that with supplementation of the BCCA, there can be some improvement. In addition, there is an alteration in the intestinal function because of the increased gut permeation of the systemic endotoxemia. There is increased activation of IL-6, and TNF alpha also tends to cause proteolysis by trying to stimulate myostatin as well as by suppressing the formation of the muscle. Alcohol per se has multiple effects. Patient who continues to drink alcohol by default tends to suppress an enzyme called transcarbamyl amylase in the liver, which is important for the hepatic ureagenesis. So by default, ammonia cannot be converted into urea because of the alcohol. In addition, alcohol has a direct effect on the muscle, leading to by stimulation of the UPP mechanism and leading to muscle breakdown. So alcohol has multiple effects in trying to increase ammonia in the blood and trying to suppress the formation of the muscle by stimulating myostatin. In addition, all these patients with NASH will have and chronic liver disease will have multiple endocrine changes characterized by decrease in the testosterone and abnormal growth hormone activation. This again leads to in stimulation of the myostatin and suppression of the mTOR, leading to sarcopenia. By default, most of the patients with obesity and tense ascites may not be able to move around, and once you have decreased physical activity, there will be less and less stimulation of the mTOR, and hence the basic stimulus for the muscle synthesis decreases and patients will have sarcopenia. In addition, sarcopenia will have multiple miscellaneous effect like reduced glucose intake, increased insulin resistance. Myokines, which are released because of the deposition of the fat in the muscle, again have pro-inflammatory components. It has an effect on the quality of the life, leading to the muscle cramps and chronic fatigue. Sarcopenia in patients with cirrhosis of the liver may be because of the liver disease per se, which is primary sarcopenia. In addition, it can also result from lifestyle changing, deconditioning in patients who are sick. This is called secondary sarcopenia. And then you have patients with advanced liver disease because of the pro-inflammatory cytokine in various parts of the organs other than the liver, that is disease related. And finally, if you have macro and macronutrient deficiencies, they have direct and indirect effect on the formation of the muscle. Significance of malnutrition and sarcopenia has been very well presented by Dr. Dhiman. Just to repeat that once you have sarcopenia, you're more likely to die, you have more inflammation, you have more hepatic encephalopathy, and more likely to decompensate. This is a summary of what Dhiman has already presented, that it has been shown that the fact that you have protein allergy malnutrition, you have 3 times higher chance of hepatic encephalopathy. A low hand grip exercise predisposes to you to have 29% more chance of having hepatic encephalopathy. Each 100 meter reduction in the 6-minute walk test is associated with reduced survival. An increase in 1 point in the fright fertility index led to 45% increase in the mortality, and reduction by 1 point in SPPB, that short physical battery test, leads to 10% and 19% increase in the mortality, and has been shown by Montino that low skeletal muscle mass is associated with substantial mortality. Mind you, this is all over and above the established conventional CTP and MELD score, and hence there is a concept that is something called MELD sarcopenia score, which has been developed by Montana et al., which gives you much better prognosis and outcome. And even after transplantation, again, to if I have to repeat what Dr. Dhiman said, that with increase in the every decrease in L3-SMI, there is a higher chance of infection, and every substantial reduction in the centimeter scale of the total psoas muscle is associated with significant mortality and the morbidity. And what is the outcome after liver transplantation? It has been shown that both during and after liver transplantation, this is just a repetition what Dr. Dhiman has already presented, that during and after liver transplantation, if you have substantial sarcopenia, you are more likely to have mortality, increased hospital stay, and poor outcome after surgery. Do we have therapeutic implications of nutrition and sarcopenia? Answer is yes. If you make lifestyle changes, if you indulge in exercise and physical activity, if you tend to give anabolic hormones, if you tend to lower the ammonia level and try to make attempts to reduce portal pressure, maybe liver transplantation may have a far better outcome. This will be presented by the subsequent speaker. Does transplantation help? Answer is, if that is the basic problem, doing transplantation should help. But we should remember, once you do transplantation in patients with liver disease, most of these patients are on immunosuppressive drugs. They are likely to produce NAFLD, as well as a number of these drugs will have an adverse effect on the sarcopenia. So generally, sarcopenia may even worsen after liver transplantation. It improves only in 1/3 of the patient after liver transplantation. So post-transplantation also, patient continue to have a risk of sarcopenia. To sum up, ladies and gentlemen, frailty and sarcopenia have overlying features in patients with chronic liver disease. It is definitely associated with higher risk of encephalopathy, ascites, and as a poor pre and post transplant liver outcome. Sarcopenia per se adds 10 additional extra points to MELD, and by Montana's study has clearly shown that if you use a new index called MELD sarcopenia, that gives you better assessment of the outcome of the patient than MELD alone. OPD-based evaluation of sarcopenia is best done by either a chair stand test or a hand grip exercise, and Dr. Dhiman has very elegantly shown that any change in the hand grip strength of even 1 kg tries to make you on the brighter side of the outcome. And gold standard as of now for assessment of the sarcopenia is the CT based assessment of the L3-SMI. Pathophysiology of the sarcopenia is still in bits and pieces. Myostatin is the main myokine which is important for degradation of the protein, and if you try to come up with myostatin antagonist, that may be the game changer in patient with chronic liver disease. mTOR is a chief protein synthesis target, and if you have agonist of the mTOR, that is something which will be useful in patients with sarcopenia. And sarcopenia primarily evolves around hyperammonemia, and I think that Dhiman can come out with newer agents which can tend to lower ammonia. But as of now, ladies and gentlemen, we talk so much, but we have very limited option of changing the outcome in patients with sarcopenia and liver disease. Thank you so much.
Thank you, Anil, for an excellent presentation as usual. And we'll have questions at the last. Actually, we'll have another talk by Dr. Sunil Taneja. He is additional professor, Department of Hepatology at PGI Chandigarh. He has special interest in nutrition and liver disease, and that's for we are here. And also in NASH. He has more than 130 national and international publications. He'll be speaking on reaching a nutritional diagnosis with bedside tools for nutritional assessment and which is the best.
Thank you very much, sir. My sincere thanks to Dr. Saraswat for giving me this opportunity. I'm going to talk about bedside tools for assessment of malnutrition in patients with cirrhosis. Can I have the slides, please? Okay, so the concept of malnutrition, sarcopenia and frailty has already been given by Professor Dhiman and Professor Arora. I'm just going to highlight 2-3 points here. When we are talking about malnutrition in patients with cirrhosis, we are talking about undernutrition. Though there is a concept of sarcopenic obesity also, but primarily when we are talking about malnutrition in cirrhosis, it's undernutrition. The second point about frailty, when we talk about frailty, it's about function, muscle function. This is, we are talking about physical frailty. We're not talking about other domains, cognition, cardiac, health related quality of life. So whatever studies are available, they are all looking at physical frailty right now. Though there is some data which shows that physical frailty and other components should be measured in the same patient. The third is sarcopenia. When we're talking about sarcopenia, we are talking about muscle mass. And various definitions have been proposed for sarcopenia also. I'll just talk about it in a minute. So, sarcopenia and frailty, there are two overlapping conditions. It's very clear now. Whatever definitions are available, they started with muscle mass, then they came to muscle function, and now we are talking about other components, health-related quality of life and cardiac function and neurocognition and so on. So the prime importance is given to functional muscle impairment. And when we talk about muscle mass per se, it is sarcopenia. And we are talking about muscle function, it is primarily frailty. So this is about physical frailty, sarcopenia, and physical frailty and sarcopenia. So any patient with cirrhosis, we need to do nutritional assessment. And first and the foremost is to do a screening test. This is the EASL guideline, which means that any patient with cirrhosis, you should do a screening test. Anyone who comes with cirrhosis and has decompensation, just look at the BMI. If it is less than 18.5, they invariably will have sarcopenia and frailty. And if they are child C cirrhotics, invariably they will have cirrhosis. They will have malnutrition. So in these patients, you need to do specific tests. You try and look at sarcopenia and frailty, and then take measures to improve sarcopenia and frailty. The other group of patients which are compensated cirrhosis or early decompensation, there you need to do screening. Screening can be by multiple screening performers are available. You can do subjective global assessment and other tests. The most accepted for patients with chronic liver disease is the Royal Free Hospital Nutritional Prioritizing Tool. And in this, you look at the BMI, the fluid status of the patient, unintentional weight loss, and whether the patient is acutely ill or he's been having this disease for a long time. Try to assess them and give them low risk score, moderate risk, of high risk. So if they are in moderate and high risk, then you have to take measures to improve both of these. And if they are low risk, then they have to be serially followed up to look for development of sarcopenia and frailty and then treat according to that. Just a word about this definition, which was proposed in 2018. This definition was proposed in the geriatric population. This has been extrapolated in patients with cirrhosis now. The first definition which came was, it talked about muscle mass only, but this was revised in 2018, where they looked at the muscle strength, muscle quantity, and not only quantity, they looked at the quality also, and low physical performance. So there's an overlap between frailty and sarcopenia, as I've already said, but definition wise, if you have low muscle strength, low muscle quantity or quality, or low physical performance, then you can fit these patients into the definition of sarcopenia. And then you can grade them as pre-sarcopenia, sarcopenia, and severe sarcopenia also, which is similar to what you call, when they have severe sarcopenia, they will have all the components, and this is what is seen in physical frailty. So let's go to the specific assessment of malnutrition. For muscle strength, the best and the simplest is the hand grip strength. I'm going to talk about it a little later. For physical performance, 3 tests which can be used at the bedside are the gait speed, 6-minute walk test, the chair, and the balance test. Now, if you have to look at the muscle quantity and the quality, anthropometry has been used for ages. It's been used in children for assessment of malnutrition, but it's not a good test for assessment in patients with cirrhosis. It varies with the fluid status. It varies with the inter-observer. There's an inter-observer variability also. And most of the guidelines do not recommend alone anthropometry for assessment of malnutrition in patients with cirrhosis. This is very clear now. What are the other tests which can be used? Bioimpedance analysis, DEXA scan, small data on ultrasound assessment. The gold standard, as has been said by Dr. Dhiman and Dr. Arora, is CT or MRI scan. And when you talk about muscle strength and physical performance together, you're talking about physical frailty. Here, you're not looking at cognition, health-related quality of life, and cardiac manifestation and so on. So this has already been discussed. Specific assessment for sarcopenia, CT-SMI, is for muscle mass and quality. You are looking at L3 level, the muscles at the L3 level. Why do you use this muscle? Because this is not affected by the fluid status of the patient, and it is independent of the activity of the patient. Even if the patient is not mobile, then also it's a true reflection of the muscle mass. And the total cross-sectional area of the abdominal skeletal muscle is taken at this level, and you try and calculate the skeletal muscle index. Along with this, you can look at the muscle quality, because in cirrhosis or in especially in NASH patients, this muscle is replaced by fat, and fat has a detrimental effect on the quality of life as well as the outcome of patients with cirrhosis. And this study, which was done by Carey et al., this is from the large North American cohort, and they showed that if you have sarcopenia based on the SMI, they have a poor outcome as compared to patients who are not sarcopenia. And subsequently, a lot of studies have replicated this data. There is some data on normative data from Indian population also. We've tried to see SMI, gait speed, chair stand in patients who were not non-cirrhotic, and mean CT SMI was 44 in males and 41 in females, hand grip strength 35 and 25, and mean gait velocity 1.86 and 1.76, though this data has not been published. This is from Dr. Sandeep Sidhu's group from Ludhiana. What does INASA recommend for diagnosis of sarcopenia? So primarily they're talking about muscle mass. You can use either DEXA, BI or CT SMI, and this is the gold standard. What about the bedside test? The best bedside test is the muscle strength estimation, and this can be done with a hand grip strength. A simple hand dynamometer can be used. It's inexpensive and effective method for detection of malnutrition. Lot of studies which show that it predicts incidence of major complications and mortality. And what are the cutoffs which can be used? These are the cutoffs which are based on BMI. What has been suggested now is that grip strength less than 27 in males and less than 16 in females, you can diagnose sarcopenia with good positive predictive value. This is the data from our institute, and in 155 patients, we looked at this correlation of CT SMI with hand grip strength, and it had a very good correlation. We also derived this cutoff for screening of patients with cirrhosis, and at a cutoff of 31, it had the highest sensitivity and specificity. So this can be used as a screening tool, but it cannot replace CT SMI for diagnosis of sarcopenia, because obviously this also has its own fallacies. So how do you approach patients with sarcopenia? If you have cirrhosis, just look at the hand grip strength. If it is less than 31, yes, do a CT SMI or MR if required, and look for sarcopenia. If it is no, then you can just follow up, and if required, then do a CT scan or an MRI if other features are also suggestive. A very important paper, I want to discuss this, calf circumference as a useful predictor of sarcopenia in patients with liver disease. This is a Japanese study, 525 patients, and sarcopenia was diagnosed by hand grip strength and SMI by BI. And they also looked at the anthropometric measures and calculated the area under the curve for diagnosis of sarcopenia. And look at the results. Calf circumference has the highest area under the curve of all the anthropometric measures. And at a cutoff of 35 and 33 in females, you can very well diagnose sarcopenia. I think more data is required on this use of calf circumference. Simple bedside test, you can do it in decompensated cirrhosis. You can do it in ICU also. In all your ACLF patients who are in ICU, just look at the calf circumference and take out the cutoffs, and then, but obviously you need gender specific, you need ethnic specific data on this. But yes, looks promising. So let me summarize the modalities which can be used. Anthropometry can be used, but lot of limitations. CT SMI is the gold standard. DEXA, bioelectrical impedance have been used. Ultrasound, 2 studies. Let me just show you our data. We've done this in 52 patients. We looked at the quadricep muscle thickness and the feather index. Good correlation with CT SMI, 0.7, but not very good. And area under the curve of quadricep muscle thickness and quadricep muscle feather index was very good for diagnosis of sarcopenia. Okay, let's move on to frailty. Lot of tools have been assessed. Fleet Frailty Index, CFS, Liver Frailty Index, Short Physical Performance Battery, 6-minute walk distance, gait speed. We did a comparison of the tests, and whichever test you use, all are comparable. The gold standard now is Liver Frailty Index. It is more objective, looks at the grip strength, chair stand, and balance. And if the LFI is more than 4.5, then you can label them as frail. So this is a simple test which can be done at bedside, can be done in outpatient, and can be done in both compensated and decompensated cirrhosis. The caveat is you can't use this test in ICU. Now, this test was based on this study by Jennifer et al. And they showed that the MELD sodium plus frailty index had a better prediction of outcome as compared to the MELD sodium score alone. And it was also predictive of the waitlist mortality in patients with cirrhosis. Now, what is the Indian data on this? This was a letter to editor by Dr. Shweta from Apollo Max. And they looked at the this LFI in healthy adults, donors, in fact, 242 donors and 272 healthy healthcare workers. And they derived this cutoff of 3.49 and 3.68. And they showed that the prevalence of frailty was 59.45%. So, whatever, irrespective of the cutoffs which have been used, it has been seen that it is predictive of mortality, and the prevalence of frailty and sarcopenia in patients with cirrhosis is pretty high. The other test, which is simple enough, is short physical performance battery test. In this, the gait speed is replaced by the hand grips. The hand grip strength is replaced by the gait speed, and the maximum score is 12. A score of less than 8 points towards poor physical performance, and this is also a simple test which can be used at the bedside for assessment of assessment of frailty. I think the liver transplant surgeons would be very happy if the patient comes in walking and asks for a transplant. So gait speed is one parameter which can be used. Simple, quick, safe and highly reliable. Lot of data to show. Widely used in practice. Look at the 4-minute walking speed, and if it is less than 0.8 meters per second, it is indicative of frailty. That means they do not have good performance status. You should wait for transplant, or you should try and improve this. The last test is simple, is 6-minute walk test. You have been using this in COVID also. Walking speed less than 1 meters per second or walking distance less than 400 during a 6-minute walk test is suggestive of frailty. And it has been seen in studies that it is associated with poor liver transplant outcome, especially below a cutoff of 250. So we've also looked at this gait speed and hand grip strength and compared it with CTSMI. A good correlation with CTSMI, 0.78, not very good in fact, but yes, it does correlates with CTSMI for assessment of sarcopenia. Area under the curve is pretty good, but yes, they can be used. All these tests can be used for screening. Again, I would like to reiterate this that screening by hand grip strength, gait speed, etc., whatever you want to use, but diagnostic is L3SMI for sarcopenia. So just coming back to this slide again, for muscle mass, INASL recommends DEXA, BIA or CTSMI. For strength, it is hand grip strength, and for physical ability, you can use the gait speed test. And this is a diagnostic toolbox. Look at the physical exam of the patient. If there is muscle wasting, if he's walking with a aid, and if he's unable to stand when it comes to your OPD, that means he's frail and sarcopenic. You need to do something about it. And objective measures I have already discussed. So just the last slide, algorithm is here. Child C cirrhosis, obviously they are high risk of malnutrition. Sarcopenia and frailty both should be assessed, and measures should be taken to improve this. In all other patients, look at the nutritional screening tools, whatever you want to use. And if they are into the medium or high risk group, then sarcopenia and frailty assessment and treat according to that. So let me conclude here. Sarcopenia and frailty assessment should be inherent components of nutritional assessment. The gold standard is CT or MRI based estimation of muscle mass. Hand grip strength is simple, inexpensive and effective method for detection of muscle strength in patients with cirrhosis. And for frailty, LFI and short physical performance battery are quick, safe and reliable tests. Thank you very much for patient listening.
Thank you so much for such an elaborate and comprehensive discussion on frailty and sarcopenia. We all understand that these are two important things which should be observed on bedside assessment, and they have a significant prognostic implications. So maybe on the behalf of the organizing committee, thank you, Dr. Deeman, Dr. Roda sir, and Dr. Tanejan. And Dr. Shiv Sareen is on already logged in. So we'll be eager to listen to him further on this topic of liver frailty index. Thanks a lot. Thank you, esteemed chairpersons and speakers, for an enlightening session on nutritional assessment in chronic liver disease. Good morning, all. It is an honor to be speaking before you today. To begin our second session, let us please invite to the dais our esteemed chairpersons for the session, Dr. Subhash Nipalia, sir, Professor and Head of the Department, Medical Gastroenterology, Mahatma Gandhi Medical College, Jaipur, Dr. Anurag Govil, sir, Senior Consultant and Head of the Department, Medical Gastroenterology, Santokba Durlabji Memorial Hospital, Jaipur, and Dr. S.M. Sastry, sir, Additional Professor in Department of Hepatology in ILBS, New Delhi. Morning, sir. I would also like to request our esteemed chairpersons to kindly invite to stage Dr. Shiv Kumar Sarin, sir, to deliver a state-of-the-art lecture, Liver Frailty Index, its evolution, utility, limitations, and future prospects. So as to say, where are you going, LFI? In Latin, Quo Vadis, LFI. Thank you. Over to you now, sir.
Good morning. It is my pleasure, in fact, it's an honor to invite Dr. Sareen for a state-of-the-art lecture. I am his student and, in fact, probably do not even deserve to be at the chair. Dr. Sareen needs no introduction. All I would like to say to one of my best teachers in life is that, to talk of his publications, his presentations, it will take probably one full session to do so. So two things just I would like to mention. One is that he has single-handedly brought India to a very prominent position on the world hepatology map. And no conference, no book, no recommendation, no guideline is really complete till Dr. Sareen fine-tunes it. Dr. Sareen, sir.
Thank you very much, Anurag, for your kind words, and it's an honor and privilege. I wish I was amongst all my friends and colleagues in Jaipur, where I come from, whether I'm in Delhi or anywhere. I am from Jaipur. And thank you, Dr. Dadich and Dr. Saraswat and Karan for inviting me. I would like to share, is my screen visible to you and my slides? Are my slides visible? Are my slides visible or no? Sorry.
Hello. Yeah, visible, sir.
Visible, and can you hear me, please?
Yeah, clear, sir.
Okay, thank you. I know the academic excellence of Vivek and Karan and Sunil, so they have given me rather a Latin title, and I will bring greetings from an Indian institute where we have bright faculty and brighter residents. Where are we going? So, Dr. Taneja, I heard partly, has very beautifully defined and given a lot of data on sarcopenia, which is as per definitions, a physical state defined by the loss of functional skeletal muscle mass. So here we are limited to skeletal muscle mass and maybe function. But frailty is a biological syndrome, involves the whole body, of decreased physiological reserve and increasing vulnerability to health stressors leading to adverse health outcomes. So, in my personal opinion, sarcopenia should be part of frailty, and frailty is a bigger issue than sarcopenia alone. You may have probably good muscles, but you may still be frail, and this is what happens in acute on chronic liver failure, which I am not discussing. Sarcopenia recently has, I'm sure this slide must have been shown, has now low muscle mass, low muscle strength, and maybe low physical performance. But everything is related to muscle. And now, as rightly said by Sunil, the intramuscular adipose tissue is the biggest challenge. 5%, 6%. So, liver fat of 5% or muscle fat of 5% is as important. But I'll touch now frailty. This is a concept. Here you will see, like in acute and chronic liver failure versus decompensated cirrhosis. In acute on chronic, you are here. In decompensated, you are here. Similarly, in not frail, you are here. In a cirrhotic who is not frail, he is here. A frail cirrhotic is here. And then there is an acute stress. Then this fellow goes down. He may come up, may not be to the same level. But in the frail, cirrhotic, decompensated, he will probably go down and adverse outcomes will come. So if you remember this basic concept, we have a clarity of reserve. So there are several scores, and Dr. Taneja had briefly mentioned. I'll try and discuss some of them. So CFS actually started from the Canadian group and changed to clinical frailty scales. There are many others. Let's look at the two important scales. The advantage of CFS, it has 9 categories. Very fit or robust, well with treated morbidities, apparently vulnerable, mildly frail, moderately frail, severe, very severe, terminally ill. Now, sometimes they're overlapping and sometimes subjectivity may come in this. The Fried Frailty Score, very popular some times ago, you have weight loss, hand grip strength for males is less than 27, female 16, exhaustion on SSD scale, slowness of gait, activity level being low. Now, it is a bit cumbersome, takes about 15 minutes. Short performance battery, rather easy. There are 3 types of balances. The same have been used in LFI, side, tandem, semi-tandem. Gait speed, you have 4 meters and you will do it 2 times. And if you can do it, the patient can do it about 1 second per minute or in 4.8 seconds. Then you have 4 points. Then it keeps on going up, and you have then 5 chair stand test, the time taken. If it is 5 times up and down is less than 11.19 seconds, you get 4 points. Now, suppose you are sitting in the outpatient and you ask the guy to stand up 5 times, he will not come back to you. What I do practically is 2 times. First time he tries to understand and I don't measure the time. The second time he gets up, he is now used to it. I will measure that time. And I would say roughly about 2 to 2.5 seconds. And I would also look at his thigh muscles, quadriceps, and sometimes I would also, and the guy is, of course, putting his hands across the shoulders. To me, this is the best test which I use in outpatient every day for every single patient. Liver Frailty Index from Canadian group, Jennifer Lai, Punita, and others. This has 3 parts: hand grip, chair stand, and balance. And as rightly said before, frail is more than 4.5, pre-frail 3.2 to 4.5, and robust is less than 3.2. They claim it takes 90 seconds, but I have tried, it takes about 3 minutes or so. So, of the available tests, what we are generally using is LFI. And where does it take us? And short performance battery, I think a single test with 5-chair stand or 2-chair stand should be standardized. Now, this paper has already been referred. I think it's a very important and very useful paper where the Chandigarh group has compared the 100 males and 16 females and a 16-month follow-up. At baseline, 43% of the patients had, according to LFI, frailty. And this is same whichever scale you use. What is important is at the end of 6 months, they assess two parameters, mortality and hospitalization. Mortality was significantly higher, hospitalizations were significantly more. The limitation of the study is they did not differentiate a decompensated or a compensated cirrhosis clearly and also the etiology so clearly in the outcome measures. This is how the first papers from Jennifer Lai's group came. It has already been alluded to the hand grip strength, which tells you nutrition, the chair stand, which tells you muscle strength. I'm a bit worried about keeping the eyes of the person closed because that will come into balance. So I generally would avoid making the patient blindfolded. Now, this is the neuromotor coordination. 10 seconds, these are the three positions that you have, and you ask the patient. Now, when you have carefully look at these lines of Kaplan-Meier, those who had a MELD sodium of 14 means they were rather good. They were not transplant, they probably were compensated. Compare them with frail. This is the MELD sodium 14 and this is the frail. The difference is not too much. Is not too much. This is the first study and I'll show you the subsequent studies. Then the MELD sodium is 23 in robust versus frail. The difference is huge, almost 20% or so. Now, a little bit more into this test. When you have, and you have to use a calculator for this, you have to see one part of this is patient is not at the back, patient is at the edge, and the legs are close by. This is the reason I'm showing you this particular figure. Now, let's go further onto the relevance of reality. Now, this is a subsequent paper from Jennifer Lai 4 years later. Now, here they say a patient who has got a liver frailty index of cutoff about 4.4 at 3 months and 4.2 at 6 to 12 months. So they have brought it down from 4.5 to about 4.2 or so, and they have added. But there is not major difference. Here is MELD sodium, and here is frailty. In the previous study, in the same group, you will find there was a huge difference, but now MELD sodium has been shown. These are caveats. Now, this is a very important study where you will see the discrepancy from the same group, and how they have analyzed their data. That's a huge data of 822, and this has been 4 center where they have used this data. Now, those who are robust is 16%, pre-fail 53%, and frail are 24%. This is compensated cirrhosis. In compensated cirrhosis, frail versus pre-fail, the difference is huge, which is unacceptable. In future studies, next. But what is surprising is pre-frail at the end of 1 year in compensated versus pre-fail at the end of 1 year in decompensated. This guy has improved. This guy has worsened. Very, very surprising. All right. The role of reality on liver transplant outcomes. You all know that if MELD is above 18, frail is behaving bad, but not as bad. And if the MELD is less than 18, the difference is huge. It only shows Once the patient decompensates, then there is much relevance of frailty in transplant. 16% to 23% is just 7% of the patients added. Here 14. So you can see the discrepancy in the initial part of their studies. They say this is the cutoff. They bring it down from 4.5 to 4.2. And here they have, in the previous study, they say compensated, also huge difference. But here there is a discrepancy. Now, this is the third part of the study, which is frailty study, which is for liver transplant patients. Now, between the frail above 4.5, they have not used 4.2, and non-frail, the post-transplant length of a stay of more than 12 days was seen in 42%. ICU stay is in about 35%. Hospitalization days within 90 days, transplant of more than 17 days, 35%. And non-home discharge means not actually going to home, to hospice or somewhere, 16%. It clearly shows frailty influences outcomes in liver transplant. But when you look at it, non-frail versus frail, more than 4.5, there is hardly any difference up to 3 years. So what worries me is that all these data increases the cost. We understand the cost of hospital stay is more, but what it shows you that up to 3 years, you're almost running neck to neck. Maybe at 5 years, there is some difference, but not at 1 or 3 years. They have suggested that you must add 9 points of frailty to meld sodium. Now, this slide shows you the caveats in the current assessment of LFI. And I want each one of you sitting there to make your own frailty assessment. Don't just believe what they have said. These are patients who don't have liver disease, 109. These are patients with CLD, 91, not cirrhosis. These are the patients who are compared with a cirrhotic, these are cirrhosis patients. So cirrhosis, going for transplant, chronic liver disease, no liver disease. LFI, these are all robust. These may be pre-frail kind of a thing. Now see the difference, the three variables. The grip strength is better in those who are going as transplant. They are worse, higher LFI, but the grip strength is more. There is hardly any difference in the chair stands number per second, hardly. Here the variability is more, but otherwise I wouldn't believe much. This versus this may be significant. So now you see balance seconds, they are same. Hence, if you have 2 out of 3, one is better, one is equal, one is worse, I am surprised that the frail cohort has this much of LFI. Third, their percentage of people who have 14% of the patients are frail. When you look at these carefully, this data makes us wonder there is lot of subjectivity in at least chair stands and maybe balance or so. Hand grip is quite objective. These are subjective to some extent. So when you look at this data, you will realize that we are still in nursery as far as assessment. And these are from amongst the best groups. Most data, 80%, are from just one center. Having said that, I'll briefly touch upon pathophysiology and then management studies. Frailty is whole body. It is a biological system of a person which is affected. And I'll start from most neglected but most important is the endocrine changes. Here for females, estradiol, or males, testosterone. Just 30%, 20%. David Von Thiel has just written an editorial on this in Hepatology International. Reduced hormones and vitamin D. With this, you have gut microbial changes, your immunity is down, there is a cognitive dysfunction to some level, and of course, all this plus your muscles are weak. We are not talking of muscle alone, which is your sarcopenia. We are talking of a system, multi system. And what all adds to it, you know it well. There is a beautiful work by Naveen, hasn't been published. What is the role of HVPG and frailty? Was presented at ASLD this year. I'm not giving details of that due to limitation of time, but frailty generally for a cirrhotic patient will be more with aging, more when you have diabetes or dyslipidemia, and if the patient is immobilized for one reason or the other. And of course, all these will add to it. But see that sarcopenia is one of the many things. There are many, many other things. Let me tell you very briefly, if you have a patient who comes first time for ascites and he has stabbed 5 times, you see his muscles are gone. These are pathogenesis and treatment options for frailty. I'll not go into details, but just to say that you start from the urea cycle, which is less, ammonia more, more myostatin. To me, this is half of the frailty part. Hyperammonemia persistent is the major cause for frailty. All other endocrine organs, diet, others are taking a part. You can improve upon this by handling this. The glycogen is stored, so don't give carbs to a patient. Give fats because the liver can use fats. There is bacterial translocation, endotoxins, you have pathogens, you have decreased activity, very importantly, mitochondrial and ribosomal function. So, muscle mass and functions are decreased. This is our prescription, what we would do. And this is at the top. Fat, 35 or more kilocalories, proteins, of course, and coffee and late evening snacks. It reverses the negative nitrogen balance to positive nitrogen balance in just 3 days' time. You have to reduce ammonia, you have to add branched chain amino acids, and I will show you some data on testosterone and physical activity. Testosterone, remember, inhibits myostatin and activates mTOR, the regenerative pathway. Exercises, you are fully aware, aerobic, resistance, flexion, neuromotor. This is what has been prescribed, the ratio of aerobic to resistance, 3 to 2. I'll come to it in our protocols that we use. What does endurance or aerobic exercise do? Decrease fat mass, especially from the muscles. The muscle fat has to be removed. If the muscle has 6% fat, it is insulin resistant. 8% fat, it is totally like a diabetic muscle. So aerobic exercises are required and it improves cardiovascular function. Resistance exercises bring hypertrophy, myofibrillar protein synthesis. This is, I have copied from Punita Tandon's work on nutritional prescription. I won't go into details of this, just to say that in non-obese, they also recommend 35. I would say even in obese, as far as the patient is there, try and maintain the calorie, but increase the burnout and the time. Now some ILBS data. This is a study which was done, I wish we could have done more, is to see the effect of structured exercise and nutrition on the liver frailty index. The study was done by Dr. Varsha, who unfortunately could not come here. The primary objective is to see change in performance parameters and LFI after 4 weeks, just 4 weeks. And secondary objective is to see the adverse events, weight change, and nutritional intakes. Prospective April 19 to March 20. These are the standards that we have used, like LFI and others. Now, A 4-week program has 8 sessions of supervised exercises, 2 per week, by physiotherapists very competent, at least 3 sessions a week of self-monitored at home, which are video monitored, and a diet which is 20 to 30. We try to give them more, but somehow it is not acceptable, so we made it an optimal thing. So this is the schedule: aerobic, resistance and stretching, frequency, intensity and time. Of the 96 patients of cirrhosis, 79 were pre-fail, 14 frail, 6 were robust. So if you look at Indian data, I heard the Chandigarh group, maybe we are having more because of the referrals for transplant. So almost you will see 90% or so are frail or pre-fail. And of the exercise program, normal compliance is 10%. We were happy to have a 2/3 compliance. These are the patients, their baseline data, and they completed. You can see child B and C. You can also see that the functional hand grip was around 25, and non-dominant, dominant hand. There was not a major change. Now you see the overall liver frailty index pre-intervention and post improved by 0.3 units. 6 minutes walk improved by 34 meters, and the gait and the balance also improved. The objective to change in performance parameters of LFI before and after. 8 patients became robust from pre-frail, 4 from pre-frail to frail. Secondary objectives: adverse events none, body weight not major, protein intake improved. So the conclusion is a structured exercise program is acceptable in India and feasible. And every patient gets a cardiac assessment, echo, and also pulmonary function. And 4 weeks of monitored exercise and nutrition improves. Other studies are 3 months and 6 months. Maybe we should do longer studies. Now, very important study is the next study. This is done by Sushrut, presented at ASLD 2 years ago. This is what we have been doing. What showed you, and you all are doing so well. Exercise and nutrition is next. And exercise, nutrition, and testosterone. And this is a very structured RCT done. These were the group of patients 50 and 52 with a CTP of about 9, MELD of 23, and appendicular muscle of about 6, and hand grip is about 26, and liver frailty of about 4. So the endpoint between the exercise and nutrition versus testosterone was there was almost 66% increase in the appendicular muscle index, limb index. The secondary endpoints, the hand grip, the strength, 6 minutes walk test, they all muscle mass, bone mass, reduction in ammonia, NF alpha, they all actually were achieved. The liver frailty score also improved from 0 weeks to 24 weeks, 3.9 to 3.2, and here it came to 3.7. So adding testosterone maybe has an advantage, and the serum testosterone levels are generally low, and after giving injections they increased compared to no testosterone group. TNF levels which were at baseline, and compared to that in the TNF levels also were better. Frailty category, you will see percentage of subjects showing improvement in frailty, or pre-frail to robust, or improvement from frail to pre-frail to frail, frail to pre-frail. And hospital admissions, you can see cumulative admissions in the next versus next testosterone group. Cumulative admissions, infections, AKI were also less. So to put it together, exercise, nutrition plus testosterone, what we call as the next protocol, is safe, more efficacious and acceptable. The person also feels कि कुछ हुआ है, something has been done for me. This is given deep intramuscular and you can see 6 injections have been given. So my last slide is to answer where we are and where are we going. We know frailty is there in cirrhotics, more than a average same age elderly individual or any age individual. We know it. Assessment in my mind is very, very primitive. And I know that INASL has endorsed LFI. I have also part of INASL. I will also endorse it. I'm not against it. But when I look at objectively, sometimes I laugh at myself. What am I accepting? It's very crude as of now. We need to improve upon it. Each one of these must be very carefully assessed. Maybe the short battery performance or some other test with larger scale. If you have only 3 levels, you make a mistake. Relevance of reality in cirrhosis, we know it is relevant. How relevant and in which category of patients, especially in alcohol, we don't have any data on frailty. Pathophysiology of frailty, absolute, because this is a cumulative mass of total body's response in a cirrhotic, whether it is immunity, whether it is your heart, whether it is your lung, whether it is your muscle. So pathophysiology of frailty to me is ammonia, but maybe many more things are. Management strategy is too limited. Rehab, a structured program may help. Testosterone may help, but next means we have to go to next level. And therefore, I would like to end up by what a beautiful editorial Vivek and Karan have written, untangling the web of malnutrition, sarcopenia, and frailty in chronic liver disease. I think you are the leaders, you are holding this meeting. Untangle it, and I'll be very happy to give my small contribution by my own critical analysis. Thank you all. At least we have started moving. Thank you. Can't hear you, Dr. Nepalia sir.
I'm here, Dr. Salim.
I can hear you now, sir.
You helped us in clarifying many of the points. Highly thankful to you for this section.
Thank you. Thank you very much.
Here we are shortly starting with our inauguration ceremony.
A very good afternoon to all, respected dignitaries, eminent clinicians, faculty members, and delegates. On behalf of the Mahatma Gandhi University of Medical Sciences and Technology, the Department of Hepatology, Pancreatobiliary Sciences and Liver Transplantation, Mahatma Gandhi Medical College and Hospital, and the organizing committee, I welcome you all to the single theme midterm meeting of INASIL, that is Indian National Association for Study of Liver, organized under the aegis of Mahatma Gandhi University of Medical Sciences and Technology and endorsed by Indian Society of Gastroenterology Rajasthan Chapter, Indian Dietetics Association Rajasthan Chapter, and the Jaipur Gut Club. On behalf of the organizing committee, I heartily welcome the chief guest of this inaugural ceremony, Honorable Vice Chancellor Mahatma Gandhi University of Medical Sciences and Technology, Dr. Sudhir Sachdev. I also extend a very warm welcome to the guests of honor, Secretary General INSL, HOD Hepatology, PGI Chandigarh, Dr. Ajay Duseja, and President-elect INASL, Director SGPGI Lucknow, Dr. Radha Krishna Dhiman. I request the members of organizing committee to escort our honorable chief guest and dignitaries to the dais. Please give a huge round of applause for the dignitaries as they occupy the seats on the dais. I also request the organizing chairman of this event, Dr. Vivek Anand Saraswat, head of the department Gastroenterology, Mahatma Gandhi Medical College, and the organizing secretary, Dr. Sunil Kumar Dadij, head of department of Gastroenterology at SN Medical College, Jodhpur, to join the dignitaries. As a mark of auspiciousness and prosperity, I request our chief guest and other dignitaries to begin the ceremony by lighting the lamp. It's time now to extend a formal welcome to our chief guest and guests of honor by presenting them with floral bouquets. And first and foremost, I would request the organizing chairperson, Dr. Vivek Saraswat, to present a floral bouquet and welcome our chief guest, Honorable Vice Chancellor, Dr. Sudhir Sachdev, sir. I now request Dr. Sunil Kumar Dadish, the organizing secretary, to present a floral bouquet and welcome Dr. Radha Krishna Dhiman, who is the president-elect of INASL. And I would request Dr. Karan Kumar, the joint organizing secretary, to please come up on the stage and present a bouquet to our guest of honor, Dr. Ajay Duseja. Dr. Duseja is Secretary General of INASL and Head of the Department of Hepatology at PGI Chandigarh. I also extend a very warm welcome to all the other eminent and revered experts of hepatology seated off the dais. A special mention of our patrons, Dr. Subhash Nepalia and Dr. Sandeep Nijavan, and all eminent faculty who are seated here. As you all know, this midterm meeting is organized with the topic Nutrition in Chronic Liver Disease, and this program shall cover clinical as well as pathophysiological aspects of nutrition and other ailments of the patients with chronic liver disease and liver cirrhosis. The sessions shall give emphasis on the practical aspects of management of these disorders, especially the nutritional management. And the highlights of the program are informative state-of-art lectures delivered by eminent national and international faculty, and also quiz and debates in these 2 days of academic extravaganza. I would now request the organizing chairman, Dr. Vivek Anand Saraswat, to deliver the welcome address.
Respected Dr. Sudhir Sachdeva, Chief Guest and Vice Chancellor of the Mahatma Gandhi University of Medical Sciences and Technology, Professor R.K. Dhiman, Guest of Honor and Director SGPGI, who is also the President-elect of INASL, Professor Ajay Duseja, Guest of Honor and Professor, Head of the Department of Hepatology at PGI Chandigarh, who is also the Secretary General of INASL, Professor Dadich, Organizing Secretary and Head of Gastroenterology at Jodhpur, dignitaries of the dais, senior faculty members, colleagues, residents and students of the Mahatma Gandhi Hospital. It gives me immense pleasure to welcome all of you to this 1.5 days meeting, which is a single theme meeting devoted to nutrition and chronic liver disease under the aegis of the Indian National Association for Study of the Liver, and being hosted here at the Mahatma Gandhi University. This is also the first national level meeting that our fledgling Department of Hepatology, which is barely about a year old now at the Mahatma Gandhi Hospital, is organizing. As has been said earlier, and you've already heard eminent speakers talk about this topic since this morning, nutrition is a very integral, a very important part of the management of chronic liver diseases, but a relatively neglected, overlooked part of the entire subject. And the usual course that one sees is every patient who comes to liver disease wants to know what he should eat, what he should not eat, kya parhez kiya jaye. Doctors do advise him, but going into depth and discussing them in their busy routine doesn't happen, and often the patient gets referred to the dietitian. And rather cursory attention is paid to this very important topic. Of late, in fact, over the last couple of decades or so, the importance of nutrition has been very well realized, and almost all the leading international associations, including the American and the European societies, ASPEN, ESPEN, as well as the liver societies, have issued guidelines, have issued consensus statements on how nutrition management should happen. Of late, newer concepts in nutrition, frailty, which was generally the domain of geriatrics, people have realized that premature frailty develops in people with severe liver disease. The loss of muscle mass, generally associated with aging, happens a bit prematurely here in liver disease patients. and as well as the entity of sarcopenic obesity. With the epidemic of obesity raging across the globe, sarcopenia developing in them in cirrhotics, they have a special significance for patients with liver disease, affecting their not only the course of the disease but outcome after liver transplantation, as we have heard. So we thought that spending some time talking in depth about the various ramifications and aspects of the nutrition in liver disease, as well as trying to deal with it in a more practical how to do it approach, involving, apart from clinicians, also members of the dietetics and clinical nutrition fraternity on whom we depend so heavily, as well as at some point we also will have to involve physiotherapists, because you've just heard how important it is to for exercise to be a part of this program. Keeping all this in mind, we thought we'd organize this meeting, and uh, with the very eminent over 25 leading and top hepatology experts from our country, as well as a large number of faculty members from our state of Rajasthan and from Jaipur, will share their knowledge during this period, during this meeting. And we hope that the debate and the quiz will also enthuse people. We are planned for tomorrow. So, with all this, we look forward to having a very educative and instructive 1.5 days on this topic, and I welcome you all to who are here to to partake of this feast of knowledge on nutrition. Well, not just nourishing you as the feast, but I mean this is the idiom that one uses for the what we are likely to experience over the next couple of days. With these few words, I welcome you once again, and I hope that you enjoy your stay for the next 1.5 days here. Thank you.
Thank you, sir. The goal of INASL is to promote the discipline of hepatology in India. It conducts various educational programs to spread awareness about liver disorders and also to update about latest advancements in their management. We are fortunate to have amongst us an eminent hepatologist, head of the Department of Hepatology, PGI Chandigarh, and Secretary General of INASL, Dr. Ajay Duseja. I request Dr. Duseja to address us on this occasion and also to share some brief about INASL and its activities. Please give a huge round of applause.
Thank you and good afternoon, everyone. Dignitaries on the dais, Professor Sachdev, Professor Saraswat, Professor Dhiman, Professor Dadich, and dignitaries of the dais who have joined us for this inaugural function. Again, on behalf of Indian National Association for Study of the Liver, it's my privilege and honor to welcome you all to this single theme meeting on nutrition and chronic liver disease, which is so very important. INASL, or Indian National Association for the Study of Liver, is a non-profit organization which looks at the interests of hepatologists in this country, and we are close to around 1,000 gastroenterologists or hepatologists who are presently the members of this particular association. If you have to know, maybe for the younger colleagues, I think just about the history of hepatology or history of INASL. The discipline of medicine, and we were all kind of together in the discipline of medicine. And then there was a breakaway for gastroenterology initially, and then the hepatology came in. Similarly, if you look at the history of associations of in this country, there used to be only one big association called the Association of Physicians of India, API. And then in early 60s, there was a breakaway, and the Indian Society of Gastroenterology was born. Then it went on, and the liver was again part of that. Hepatology was kind of part of that. And I think maybe in early 70s, 73, 75, there was a group which again separated from Indian Society of Gastroenterology, and that group initially was called as the Liver Study Group. And it went on for again maybe a few years, maybe around 15-20 years. And it was in 1992 that the first time this name of Indian Association for Study of Liver, that time called as INASL, was again formed. And thereafter this was renamed after a few years for some reasons as Indian National Association for Study of the Liver. So, this, as I said, is an organization which works for the interests and for the goal of promoting the goal of discipline. Goal is to promote the discipline of hepatology in this country. As I said, we are close to 1,000 members, and the numbers are growing every day. So we keep doing a lot of academic activities. We keep doing a lot of research activities. We promote the young talent, and we come out with various practice guidelines, not only for the gastroenterologists and hepatologists of this country, but also for the physicians of this country. And we do a lot of academic activities, and academic activities we do have what we call the annual meeting of INASL every year, which happens in first or second week of August. And rather, I'll take this opportunity to extend invitation to all of you to join us in Bhubaneswar this year, which would happen. Our annual meeting is from 3rd to 6th of August in Bhubaneswar. But in addition to the annual meeting, we do have lots of other, midterm meetings, and this meeting is one of such meetings, which is happening, on nutrition and chronic liver disease. Beyond this, we do have now a series of, meetings which have been started on fatty liver disease. There are a series of meetings which have been started on, will start on hepatocellular carcinoma and various other areas, which we feel are of interest to the physicians and hepatologists are usually covered. So I think not going further, I would say that we do have our official journal. Maybe Dr. Dhiman will speak about that, and which is as he said, we come out with various guidelines and all. So I'll take this opportunity to maybe thank the Mahatma Gandhi hospital team, especially Professor Sarswat and Professor Dadich, Dr. Karan, Dr. Nijavan, and everybody as the Jaipur team who have taken this initiative and given have and organized this. I would say the single theme meeting on nutrition, which is an area which is not very frequently discussed and which is so very very important. So my special thanks to that from INASL and from the INASL Governing Council. I think many of the dignitaries here are the ex-president and the ex-secretary general of INASL. Professor Sarswat himself was the president of INASL. Dr. Dhiman was the secretary general. Dr. Puri here is the treasurer. And there are a lot of other governing council members, the present and the ex-governing council members. So from the everyone from the governing council of INASL, my special thanks to the organizing team and to all of you for joining us in this meeting. And I'll take this opportunity to request, especially my younger colleagues, to become the members of INASL, which can be done offline or online. You can just go onto the website of INASL, become the INASL members, be the part of this, hepatology team, I would say. And thank you very much again. And we look forward to again an academic feast on nutrition and chronic liver disease for next 2 days. Thank you very much.
Thank you so much, sir. It's indeed our privilege to have another eminent hepatologist, Director SGPGI Lucknow, and the President-elect of INASL, Dr. Radha Krishna Dhiman, amongst the dignitaries. I request Dr. Radha Krishnan to address us on this occasion.
Thank you, madam. Dignitaries on the dais, Professor Sudhir Sachdev, Vice Chancellor, Professor Vivekanand Saraswat, HOD Hepatology, Professor Ajay Duseja, Secretary General INASL, Professor Sunil Dadich, HOD Gastroenterology, SN Medical College, Jodhpur. Dignitaries of the dais, my dear colleagues, ladies and gentlemen. Indeed, it is a privilege for me to be the part of this function in the midterm conference of the INASL. You have heard about the INASL, its growth, its progress, and what the activities are being done by the INASL people persons also. But I'll just discuss 2 or 3 things that have been done in the INASL during various phases, various periods also. And one of the major achievement of the INASL is creating the clinical practice guidelines. And for the last, I would say 8 or 10 years, several clinical practice guidelines have come on various topics of the state importance, local importance, as well as the national importance. If I talk of the national importance, it is the viral hepatitis. We have the National Viral Hepatitis Program, and we have created the clinical practice guidelines also. The other that we have on the nutrition, on the material this conference is being done, that is the nutrition in the chronic liver disease, one of the very famous clinical practice guidelines all over the world also. Many other topics like hepatocellular carcinoma, hepatic encephalopathy, renal failure, and many more things also. I think that is the great achievement. If I have to place in Azal as far as the order that has produced the maximum number of the guidelines, it comes after the ASLD, that is the American Association for the Study of the Liver, EASL, that is European Association for the Study of the Liver, and the APASL, Asia Pacific, and then comes the ENASL also. So it is a, I would say, I congratulate uh, the various secretary generals, presidents who have, with the help of those, that we could be able to create these guidelines. And another thing is that every society has its own journal, and we have our own journal also, and that is Journal of the Clinical and Experimental Hepatology, and it was started in 2011 in a annual conference of the INAZL being conducted at the PGI Chandigarh. And during that, I am being the honored that I was the first chief editor of that journal also. And now it is the 12th year of the publication. It is already PubMed indexed also, and the more likely to get the impact factor this year only. So this is one of the most reputed international journal that belongs to our own society, the INAZL. Third thing that I will talk to you in brief, that is the hepatology department. So all the, like the gastroenterology or cardiology or many other branches, this department have been created for the first time at the PGI Chandigarh. And Dr. Duseja knows, and Dr. Chawla at that time was the head of the department. And we worked a lot about it, and we created the department and started the DM program in hepatology along with the critical care in hepatology as well as the liver transplantation program. And I'm happy that the Mahatma Gandhi Memorial Hospital has also started the department of the hepatology. Congratulations, Professor Saraswat, for starting this department. I think it is the 8th department in the nation at the moment, in the country at the moment. I think it is a great achievement that we have now another department at this hospital. I don't take much time, and I'll stop here. And my all best wishes to Professor Saraswat, Professor Dadij, and their team also for organizing this very important conference on a very important topic also. Thank you so much.
Thank you, sir. We are fortunate and blessed to have a very eminent clinician and an academician and administrator par excellence, Dr. Sudhir Sachdev, the Honorable Vice Chancellor of Mahatma Gandhi University of Medical Sciences and Technology, as the chief guest of today's program. He is associated with this organization since its inception and has immensely contributed to its progress and success. I request Dr. Sudhir Sachdev to address us on this occasion.
नमस्कार, मैं यहाँ महात्मा गांधी यूनिवर्सिटी ऑफ मेडिकल साइंसेज एंड टेक्नोलॉजी में उपस्थित आप सभी विशेषज्ञों का, जो कि इस समय पूरे विश्व में भारत में लिवर को लेकर के जो सिनेरियो है उसको एक नक्षत्र की तरह से आपने चमका के रखा हुआ है, मैं आप सभी का हृदय से स्वागत और अभिनंदन करता हूं। आज हमारे बीच मंच पे
आदरणीय डॉक्टर राधाकृष्ण जी धीमन, डायरेक्टर SGPGI, प्रेसिडेंट इंडियन नेशनल एसोसिएशन फॉर स्टडी ऑफ लीवर, डॉक्टर अजय दुसेजा, सेक्रेटरी जनरल INASL, प्रोफेसर एंड हेड हेपेटोलॉजी PGI चंडीगढ़ हैं आप हमारे बीच। आज की इस मिड टर्म मीटिंग जो कि न्यूट्रिशन एंड क्रॉनिक लिवर डिजीज पे आज हो रही है, उसके ऑर्गेनाइजिंग चेयरमैन डॉक्टर विवेक आनंद सारस्वत, जो कि महात्मा गांधी विश्वविद्यालय में हेपेटोलॉजी डिपार्टमेंट के विभागाध्यक्ष हैं, डॉक्टर सुनील दाधीच ऑर्गेनाइजिंग सेक्रेटरी हैं इस मिड टर्म मीटिंग के, पेट्रन्स डॉक्टर सुभाष नेपालिया जी जो पूर्व में SMS मेडिकल कॉलेज के डीन प्रिंसिपल भी रह चुके हैं, वर्तमान में आप गैस्ट्रोएंट्रोलॉजी के हमारे यहाँ मेडिकल गैस्ट्रोएंट्रोलॉजी के आप प्रोफेसर हेड हैं, डॉक्टर संदीप जामन मुझे इस समय नजर नहीं आ रहे, वो भी पेट्रन्स में से हैं, डॉक्टर SS शर्मा, श्याम सुंदर जी शर्मा। मैं इसके अतिरिक्त जितने भी ऑल रेवर्ड प्रोफेसर्स, हेड ऑफ द डिपार्टमेंट, सीनियर फैकल्टी, कंसल्टेंट्स, पूरे भारत में नेशनल एमिनेंस के जितने भी लोग यहाँ उपस्थित हैं, विश्वविद्यालय की तरफ से, इस विश्वविद्यालय के संस्थापक डॉक्टर ML स्वर्णकार जी की तरफ से, विश्वविद्यालय के चेयरपर्सन चांसलर डॉक्टर विकास चंद्र जी स्वर्णकार की तरफ से आप सभी का हृदय से स्वागत और अभिनंदन करता हूं। महात्मा गांधी विश्वविद्यालय में मेडिकल कॉलेज, डेंटल कॉलेज, नर्सिंग कॉलेज, फिजियोथेरेपी कॉलेज, ऑक्यूपेशनल थेरेपी कॉलेज, कॉलेज ऑफ हॉस्पिटल एडमिनिस्ट्रेशन, कॉलेज ऑफ हेल्थ इंफॉर्मेटिक्स, पैरामेडिकल कॉलेज, हम तमाम संस्थाओं को चला रहे हैं। मेडिकल कॉलेज की संस्थापना सन 2000 में हुई और इस समय 2023 में प्रतिवर्ष हम 250 विद्यार्थी MBBS में हमारे यहाँ प्रवेश लेते हैं। 167 पोस्ट ग्रेजुएट स्टूडेंट्स प्रतिवर्ष एडमिशन लेते हैं और सुपर स्पेशलिटी में हमारे यहाँ 62 एडमिशंस पर एनम इस समय हो रहे हैं। महात्मा गांधी विश्वविद्यालय में डिपार्टमेंट ऑफ HPB सर्जरी है, हेपेटोलॉजी डिपार्टमेंट है, GI सर्जरी है, मेडिकल गैस्ट्रोएंट्रोलॉजी है। हम सतत नियमित रूप से लिवर ट्रांसप्लांट कर रहे हैं और मुझे आपको बताते हुए हर्ष हो रहा है कि अब तक हम 55 लिवर ट्रांसप्लांट कर चुके हैं और आप सभी की साक्षी और सानिध्य में 56वां लिवर ट्रांसप्लांट इस समय चल रहा है, इस समय अस्पताल में हो रहा है। लिवर ट्रांसप्लांट के अतिरिक्त महात्मा गांधी मेडिकल कॉलेज में 1500 से अधिक, लगभग 1540 किडनी ट्रांसप्लांट अब तक हो चुके हैं। इसके अलावा कॉम्प्रिहेंसिव कैंसर केयर हमारे यहाँ उपलब्ध है, जिसमें हम मेडिकल ऑन्कोलॉजी, सर्जिकल ऑन्कोलॉजी, रेडिएशन ऑन्कोलॉजी, ऑन्कोपैथोलॉजी, न्यूक्लियर मेडिसिन, तमाम फैसिलिटीज के साथ हम सुविधाएं दे रहे हैं। अन्य सुपर स्पेशलिटीज भी हमारे यहाँ चल रही हैं, लेकिन विशेष रूप से जिस बात को मैं आज आप सबके बीच यहाँ एडमिट करना चाहूंगा कि डॉक्टर विवेक आनंद सारस्वत और GI सर्जरी, HPB सर्जरी में डॉक्टर विनय कपूर जी के ज्वाइन करने के बाद लिवर ट्रांसप्लांट का जो सिनेरियो हमारे यहाँ बदला, उससे निश्चित रूप से राजस्थान के लोगों को एक लाभ मिलना शुरू हुआ और इसका क्रेडिट मैं इन दोनों के अतिरिक्त आपके इस एसोसिएशन को भी देना चाहता हूं, जिनके लगातार ये प्रयास रहे कि पूरे भारत में इस प्रकार के सर्विसेज सबको मिलनी चाहिए। आप सब लोग यहाँ एकत्रित हुए, आप सब लोग यहाँ आए। मैं एक बार पुनः विश्वविद्यालय की तरफ से आप सभी का हृदय से स्वागत, अभिनंदन करता हूं। आप यहाँ रहेंगे, किसी भी प्रकार की असुविधा हो उसके लिए मैं स्वयं जिम्मेदार हूं। कोशिश की है डॉक्टर विवेकानंद सारस्वत जी ने और विनय कपूर जी ने कि आपको किसी प्रकार की असुविधा न हो, लेकिन फिर भी यदि कोई बात हो तो आप हमारे साथ एक्मोडेट करें। लेकिन जितने भी लोग यहाँ बैठे हैं, आप भविष्य में किसी भी प्रकार का कोई एकेडमिक कार्यक्रम, किसी भी प्रकार की कोई वर्कशॉप, किसी भी प्रकार का कोई सिंपोजियम, कोई भी चीज, कॉन्फ्रेंस आप ऑर्गेनाइज करना चाहते हैं, मैं इस मंच से, इस विश्वविद्यालय की तरफ से ओपन आप सबको आमंत्रण, खुला आमंत्रण देता हूं। आप संपर्क कीजिएगा विवेकानंद सारस्वत जी से, विनय कपूर जी से, और यदि मेरे से भी संपर्क करेंगे तो मैं भी सदैव उपलब्ध हूं। लेकिन इनसे आप लोग परिचित हैं, आपके लिए संपर्क करना आसान है। आप कोई भी योजना बना करके भेजिए, महात्मा गांधी विश्वविद्यालय हर पल, दिन में, रात में आपके साथ, संस्थान की तमाम सुविधाओं के साथ और यदि आप चाहेंगे कि किसी प्रकार से आर्थिक सहयोग भी हो और वो एकेडमिक कार्यक्रम हो सके, तो उसके लिए भी मैं बिना जाने खुली सहर्ष स्वीकृति डॉक्टर अनिल स्वर्णकार जी के बिहाफ पे देता हूं। आप सभी का सदैव स्वागत, अभिनंदन, और इस मिड टर्म मीटिंग आपकी बहुत अच्छी हो और आप जिन नतीजों की एक कामना करके, एक आकांक्षा लेकर के यहाँ एकत्रित हुए हैं, उनमें भी आप कामयाब हो। मैं अपनी तमाम शुभकामनाएं आपको इस अवसर पे देता हूं। थैंक यू वेरी मच, धन्यवाद।
Thank you so much, sir, for your words of encouragement and wisdom. As a mark of our gratitude in having our chief guest, guest of honor, and other dignitaries, it's time now to felicitate them. And I would request Dr. Vivekanand Saraswat to felicitate our chief guest by presenting him with a shawl. Okay, sir. So, on request of our chief guest, I would request Dr. Saraswat to felicitate Dr. Radhakrishna Dhiman, the President-elect of INASL. And of course, this is the tradition of Mahatma Gandhi University. Every guest is welcome. So, it's an honor to have you, sir, with us. जी Dr. Ajay Duseja, the Secretary General of INASL. And now, finally, to felicitate our chief guest, Dr. Sudhir Sachdev. थोड़ी भरपूर तालियां बजाइए. It is such a nice gesture on behalf of our Honorable Vice Chancellor, sir. Thank you so much, sir. I now request the Organizing Secretary and Head of Department of Gastroenterology, Dr. Sunil K. Dadij from SN Medical College, Jodhpur, to deliver the vote of thanks.
Thank you, ma'am. Dignitaries on the desk, Professor Sudhir Sachdeva sir, Dr. Vivek Saraswat sir, Dr. Dhiman sir, and Dr. Duseja sir. It's my pleasure to propose vote of thanks. Special thanks to Mahatma Gandhi Medical University for providing us this platform, and your unconditional support and guidance was very extraordinary in organizing this meeting. My sincere thanks to INSL Governing Council for allowing us to organize this single theme meeting on nutrition and chronic liver disease. A special thank to Dr. Ajay Duseja, who is the Secretary General of INSL. We have been talking so frequently in last few months, at times very odd hours, but he's always supportive and positive. My thanks to all the faculties who have traveled from all across the country and delivered their best. My thanks to all the delegates who are present physically, as well as who are also present online to attend this meeting. Thanks to whole organizing team, especially the organizing chairman, Professor Saraswat, my teacher, very a person full of energy, always positive, and he is the main behind this meeting. My thanks to my joint organizing team, the young bubbling hepatologists, Dr. Karan, Dr. Akash, Dr. Rajat, Dr. Abhinav, Sudhir, and many more, to help in organizing this very important conference. And my vote of thanks is incomplete without mentioning few pharma people who have supported us from their wholehearted to financially to conduct this meeting. And thank you very much.
Thank you, sir. With this, we come to the end of this inaugural ceremony. Once again, I, Dr. Bushra Fiza, convey my best wishes and greetings to all the delegates as well as the organizing committee members. May this event turn out to be as fruitful as it has been planned. Thank you so much. We shall be continuing with the sessions as in the event calendar given.
Thank you.
On dietary prescriptions in chronic liver disease, I would like to call upon stage the chairpersons, Dr. Radha K. Dhiman sir, Senior Hepatologist and Director in SGPGI Lucknow and elect President of INAZL, Dr. Dinesh Agarwal sir, Senior Consultant in Department of Medical Gastroenterology in Santokba Durlabji Memorial Hospital, Jaipur, Dr. Gaurav Gupta sir, Professor, Department of Medical Gastroenterology, SMS Medical College, Jaipur, Dr. Mukesh Jain sir, Associate Professor, Department of Medical Gastroenterology, SMS Medical College, Jaipur. I request the chairpersons to start the further proceedings.
Without wasting time, the session will be dietary prescriptions in chronic liver disease. May I request Dr. Pankaj Puri to come over the stage to deliver a talk on the principles of nutrition. Dr. Puri, please. He is Director in the Department of Hepatology and Medical Gastroenterology at Fortis Escorts Liver and Digestive Disease Institute, New Delhi. Welcome you, sir. Welcome to Jaipur.
Thank you, sir. It's a pleasure to come to Jaipur. I grew up in Jaipur and I have fond memories of my stay and my early education in Jaipur, and it's a special place. I must thank Dr. Saraswat, Dr. Dadich, and Dr. Karan for giving me the opportunity to come back to my native place. I'll be speaking on principles of nutritional management. There are many talks which are going to subsequently follow and which are going to give detailed talks. I'll be giving some sort of a curtain raiser as to what is to come. The importance of nutrition in patients with chronic liver disease and transplant candidates has been well recognized. Malnutrition is common. In India, it's about 47 to 84%. It's more than that in the general global population. It increases with severity of liver disease, and there are associated with the risks of decompensation, infections, and increased waitlist mortality and poorer outcomes after liver transplantation. Pre-transplant decompensation is higher, infections are higher, mortality is higher. After transplant, these patients do poorly. They tend to stay longer in the hospital, they have increased mortality, and they have more complications. These were the guidelines which were alluded to and which were published by NASL. I'll be covering this under the following heads. First is nutritional assessment. Who needs nutritional management? What is the basic nutritional requirements? How do we treat the malnutrition? How do we treat in special situations? I'll be covering just basics of these because all these will be covered subsequently. Some debates on branched chain amino acids, oral versus enteral and parenteral and enteral feeding formulas. Nutrition assessment is required in all patients except those who have overt malnutrition. We don't need to test them anymore. They need nutritional management. People with low BMI or obese who are advanced liver disease, they all need nutritional management. Various screening tools have been referred to and published and given by the previous speakers. And the Royal Free Hospital Nutritional Prioritizing Schools tool has been probably the better of the lot. And this has been already shown by the previous speakers. So the basic nutrition requirements in patients who are hemodynamically stable and who have a sedentary lifestyle, the calorie requirement is 35 to 40. kilocalories of energy per kilogram of dry body weight. The proteins requirement are 1.2 grams per kg of dry body weight. In malnourished patients, 1.5 gram per kg, and if they're critically ill, the protein requirement may go up to as much as 2 grams per kg. The carbohydrate should be 50 to 60% of calories, and the fats 20 to 30% of calories. In people who are obese, the calorie requirement should be less, and it'll go depending on what the BMI is, go down to 25 to 35, and even lower if the BMI is more than 40. If they have ascites and edema, we must correct to see what would be the dry body weight. The empirical correction for ascites would be 5% for mild, moderate, and tense ascites, and reduce an additional 5% if they have bilateral pedal edema. So if we treat the malnutrition, we must give at least 30 to 35 kilocalories per kg of dry body weight. The meals should be frequent. They should be 4 to 6 hourly with complex carbohydrate dense bedtime snack and a protein rich breakfast. I would tell my patients, eat the moment you get up, eat after dinner before you go to sleep. So your duration of fasting is less. If you're fasting too much, you're letting your muscles break down. We must assess them for vitamin D deficiencies. Vitamin D replacement is required. There would be fat-soluble vitamin requirement in cholestasis, thiamine, and alcohol, and various ammonia-lowering therapies, etc., have been tried for treatment of malnutrition. In special situations, I'll just briefly touch on these. In critically ill patients, nutrition can be compromised because they're often kept nil-loadly for bleed. They are kept fasting for procedures. They may have ileus as a part of sepsis. They're catabolic. They have a high protein and nutritional requirement. Hypoglycemia is common, and often vitamin deficiencies are related to liver dysfunction, inadequate intake, and malabsorption. In GI bleed, they will usually be kept fasting, and people have been concerned about placement of nasogastric tubes, but they are not contraindicated, and even in the presence of varices. This was a meta-analysis which compared early enteral nutrition versus delayed enteral nutrition in patients with GI bleed. These were 5 trials of 313 patients, and it showed that early enteral nutrition within 24 hours does not result in any significantly higher bleed and mortality compared to delayed nutrition, but it decreases hospitalized days. Similarly, this study was done by Dr. Sidhu from our country, and it showed that in early feeding after esophageal band ligation in cirrhotics is safe. This was a randomized controlled trial, and they had 2 groups with early feeding where diet was given within 1 hour after varicose ligation, and a solid diet after 4 hours. In a delayed feeding group, the patients were fasted for 4 hours. Diet was given till 24 hours and solid diet for next 48 hours, and a regular diet after 72 hours. And they showed that early feeding was safe, it provided better nutrition, and there was lower incidence of infections. In hepatic encephalopathy, this was a trial which came in by Maharishi et al., and it looked at the efficacy of nutritional therapy in cirrhotics and minimal hepatic encephalopathy. They had 2 groups. Group 1 was of 60 patients. There was nutritional therapy with calories and proteins being looked after. In group 2, there was no nutritional therapy, and they had the same diet, whatever they were having earlier for 6 months. People who had nutritional interventions had higher reversal of encephalopathy, increase in PHES, improvement in health-related quality of life, and lower progression to overt encephalopathy. So we all used to wonder, in our early days, we were taught hepatic encephalopathy, don't give proteins, and this was an erroneous observation. And the first study came out in 2004 of normal protein for hepatic encephalopathy. But overall, in net, the decision is that protein restriction is not recommended in patients with cirrhosis and hepatic encephalopathy, and it is rather detrimental in patients with cirrhosis. Alcoholic hepatitis, more prone to be having malnutrition and thiamine deficiency. In liver transplantation, these patients are often malnourished, and the body cell mass in assessment is a better predictor of outcome than just the Child-Pugh score. Pre-transplant nutritional support has been shown to improve enteral nutrition. And similarly, in post-transplant, again, this was a study in 50 patients, and if they had nasogastric feeding or IV fluids, they found that there was reduced viral infection and trend towards decreased infection with enteral feeding. So we should start enteral feeding as early as possible within 12 to 24 hours and consider parenteral only if the gut cannot be used. Branch chain amino acids, there's a talk subsequently on it, and it has been recommended in patients with liver disease, but the potential benefits need to be validated further, and I'm not going to dwell more on this because there's a full talk. The only problem of branch chain amino acids is that the protein content is lower, and it becomes very difficult to achieve the protein requirements with purely branch chain amino acids. Oral versus enteral versus parenteral, which one to choose? The gut should be used as far as possible. If the patient is not taking adequately oral, use tube feeding. Parenteral is only if there is prolonged poor oral intake or they cannot tolerate oral enteral or there's a prolonged ileus. This was a meta-analysis of oral and enteral nutritional supplementations of 6 trials, 4 enteral, oral and 2 enteral of 470 patients. And there was significant reduction in overall mortality in patients who took oral therapy. The last thing which I shall just briefly touch on is enteral feeding formulas. There are various types of feeding formulas. These can be polymeric formulas, which may be general or disease specific, like you may have diabetic or renal or hepatic. And there may be pre-digested formulas which are semi-elemental for patients who are not absorbing, who are critically ill, who have inflammatory bowel disease. And there are modular formulas, like we may have protein-rich formulas. Often hepatic formulas have been advocated, but the problem is they have low proteins, low fat, and high branch chain amino acids. They also contain some other things which have been promoted to attenuate liver injury. However, the protein content is lower, then we must consider them in hepatic encephalopathy, which is refractory to medical management. More importantly, we must know what is the content of the formula, not just write, this is just a notes from my phone. So if I say this formula will contain so much proteins, so many kilocalories, and this is the scoop size, and how many scoops will contain this amount. So each one of the formulas which are commonly available in your hospital, these are formulas which are available in my hospital. So these are my notes from my phone. So we must know, not just simple give 2 scoops 3 times a day. You must know how many proteins you're giving, how many calories you're giving. To conclude, nutritional therapy can decrease the risk of complications and improve survival, and adequate protein can be safely administered in patients even with encephalopathy. We must supplement intake by enteral nutrition if there's inadequate oral nutrition, and oral or enteral nutrition is not tolerated, then you give parenteral nutrition. The standard nutrition regimen are preferable. While data on branch chain amino acid is not conclusive, it can be used in case of protein intolerance to achieve the desired target of protein intake. Thank you.
Thank you, sir. Thank you, sir. The next talk is on debunking the common myths about diet in CLD, given by Dr. Sunil Dadij. He is professor and head Department of Gastroenterology at SN Medical College, Jodhpur. Sir.
Thank you, Dr. Gora. Can I have my slides, please? Next 15 minutes or so, I'll be telling you regarding common myths and mistakes which we make in our day-to-day clinical practice as far as the nutrition in patients with liver disease is concerned. Do I need to close this?
Okay. So I'll be telling you about the few basics of altered metabolism in liver cirrhosis, and we'll tell you about 10, 15 myths and some facts, and few common mistakes and the take-home points. So, sarcopenia or malnutrition in cirrhosis is quite common, as has been evident by many various talks. It's common in compensated cirrhosis, around 1/3 will have, and decompensated more than 2/3 of will have malnutrition. The mechanisms of malnutrition in liver cirrhosis is many, because of dietary intake, because of malabsorption, because of metabolic disturbances. And once the person is malnourished, it will further aggravate the underlying liver disease. And underlying liver disease aggravation will further worsen the malnutrition. So it becomes a vicious cycle. What happens to the altered metabolism in liver cirrhosis? Liver cirrhosis is a state of accelerated starvation, where there is a reduced glycogen storage, and increased gluconeogenesis, and increased fatty oxide utilization. And this gluconeogenesis comes from the amino acids. Amino acids come from the muscles. Proteolysis, the muscles are lost, and the muscles utilize branched amino acid more commonly compared to the aromatic amino acids. So there is an imbalance between the branched amino acids and the aromatic amino acids. Just to summarize, reduced glycogen storage, increased gluconeogenesis, increased muscle breakdown, increased utilization of branched amino acids, and the increased blood levels of aromatic amino acids. So common myths. First is relying on body weight and BMI to assess the nutrition, as has already been talked. Body weight is fallacious most of the time in patients who are decompensated liver cirrhosis with ascites and pedal edema, and it needs to be corrected by reducing the amount of ascites or pedal edema they have, as already been talked by Dr. Puri. Body mass index is again fallacious in patient with liver cirrhosis, because with edema you can fallaciously measure it wrong if you take the scale weight into consideration. And patients who have obesity, again, they may be having associated sarcopenic obesity, means the loss of muscle and they are obese. So the simple BMI will be fallacious in evaluating the nutritional status in these kind of patients. So what do? We go for screening, and then we assess for the nutrition. Screening is done by BMI. If it is very low, they are very common to have malnutrition. You have various scores already been discussed by previous speakers. And once you screen these patients to have the at risk of having malnutrition, then you assess them for muscle mass, strength, as well as the physical performance. So the fact is, BMI is not good enough to look for malnutrition in cirrhosis. We have to use other tools and mechanisms. Another myth is underestimating the prevalence of malnutrition and sarcopenia in cirrhosis. It has already been alluded by previous many talks. It is quite common. Once you have sarcopenia, there is increased risk of decompensation in the form of ascites and capillopathy, and that would further worsen the sarcopenia, and they have a poor transplant outcome and increased mortality. So the implications of sarcopenia is very great in patients with liver cirrhosis. So a malnutrition should be evaluated for, and the nutrition care should be taken care of very well in these group of patients. Calorie requirement in dietary prescription in cirrhosis. Cirrhosis, as we have already discussed, it's a catabolic state with reduced protein synthesis, increased proteolysis, and increased gluconeogenesis. The total energy expenditure is 1.3 times the total resting energy expenditure. Similarly, the protein requirement is much more in people who have malnutrition or who don't have malnutrition. Both have a higher protein requirement compared to the normal sedentary lifestyle persons. Similarly, in obese, you just have to reduce the calorie, you don't have to reduce the protein intake. And this is the landmark study where people have said that if you add a late evening snack to the in the diet prescription of these patients, they will have a better anabolic response. Similarly, if you add a nocturnal nutrition supplementation to these group of patients, they will have a better nutrition status. So the meal pattern during the day should be frequent and more and small, and I mean the high protein breakfast and the late evening high carbohydrate late evening snack is very important. So the fact is, calorie requirements are not less in patients with cirrhosis compared to the other people, and their diet should be divided into multiple small and frequent meals of 4 to 6 hourly over the 24-hour period. Another myth is prescribing a low protein diet to prevent the hepatic encephalopathy. Why some people believed in this? Because ammonia is the main toxin which is responsible for the causation of hepatic encephalopathy, and the ammonia is produced from the GI tract by the metabolism of proteins. If you reduce the protein in the diet, there will be less ammonia and there will be less risk of hepatic encephalopathy as well as less recurrence of hepatic encephalopathy. But this myth was broken by this landmark study. If you give normal protein, rather there is improvement in hepatic encephalopathy patients. Even protein intake is associated with the prevention of recurrent episodes of encephalopathy, and this is the trial Sudhir is here. In minimal encephalopathy, if you give nutrition therapy, there is an increased improvement in neuropsychiatric performance, decreased risk of developing the overt if you give high protein diet in patients who have a covert minimal encephalopathy. So dietary restriction will have a deleterious effect on muscles in patients who have the history of hepatic encephalopathy. Again, liver and muscle are complementary to each other because in patients with liver disease, because of multiple mechanisms, there is muscle wasting. If you have a malnutrition, it will add to the further muscle wasting. And I told it becomes a vicious cycle. If you improve the malnutrition, if you improve the muscle strength and muscle mass, it will help the liver to recover faster. And you can break this vicious cycle of cirrhosis, malnutrition with sarcopenia and poor outcome. So the fact is, in hepatic encephalopathy, protein should not be restricted. Does source of protein matters? Vegetable, dairy, or versus animal proteins? There are some studies which have shown that the vegetable and dairy proteins are better tolerated than animal proteins because of their low ammonogenic amino acid contents. Vegetable proteins use is associated with the improved nitrogen balance and the improved clinical grade of encephalopathy. There is a weak evidence that vegetable proteins are better tolerated than animal proteins. If there is to meet the protein requirement, then you can add the animal source of protein, but you should always avoid red meat. Subsequent myths will be based on unjustified dietary restrictions in which are advised to the patient with liver cirrhosis. First is cirrhotics should not consume fat. Again, as I have discussed, patients with cirrhosis have poor glycogen reserve, hence the energy extraction shifts from fatty acid oxidation. So if you have a fatty acid available, that may spare the muscle for breakdown to some extent and will prevent the occurrence of sarcopenia. So avoiding fat will aggravate the sarcopenia. Fat should be given in required amount. A strict salt restriction to control ascites. If you go for strict salt restriction, which is less than 5 grams per day, it is associated with the higher incidence of hyponatremia and diuretic-induced renal impairment. Again, strict salt restriction will impair the dietary intake and compromise the energy as well as the protein intake. So a moderate salt restriction, that means 5 grams of table salt daily or 2 grams of sodium daily is okay and should be recommended to patients who have ascites. So low sodium diet should not be advised. It's moderate sodium restriction is good enough. But you should always avoid added salt or snacks which are having high sodium content. Water restriction in patients with ascites. Again, if you go by the mechanism by which the hepatorenal syndrome or the renal injury in these patients occur, you have systemic vasodilatation, splenic vasodilatation, followed by effective arterial hypovolemia. If you restrict water, it will further enhance the hepatic hypovolemia, arterial hypovolemia, and it will add to the hormonal changes leading to the development of hepatorenal syndrome. So water restriction or fluid restriction has got no role in controlling ascites as far as liver cirrhosis is concerned. So water restriction is only advised when they have dilutional hyponatremia. Salt capsule to treat hyponatremia. Again, hyponatremia in cirrhosis is most of the time it's a dilutional hyponatremia. It's a hypervolemic hyponatremia because of imbalance between ADH and aldosterone. So if you give salt therapy to these patients, it will worsen the sodium load, increase fluid retention, and lead to worsening of the cirrhotic ascites. So salt therapy is not indicated in majority of patients with liver cirrhosis. What you need is only the water restriction. Another myth is dietary restriction in obese cirrhotics. Obesity is the independent risk factor for progression of underlying liver disease, whether it is alcohol or any viral etiology. Obese people who drink alcohol will have severe fibrosis than the obese people who don't drink alcohol. Similarly, obese people can have sarcopenia, which is called sarcopenic obesity. So they need to reduce adiposity while maintaining the muscle mass. So the fact is, obese should be given the hypocaloric diet, but the protein should not be restricted in these group of patients. And regular exercise should be also be advised to these patients. Milk and milk products should be avoided in liver cirrhosis. You know, the hepatic osteodystrophy is very common in our country. It is very common. More than 2/3 of all cirrhotics will have hepatic osteodystrophy in the form of either osteopenia, osteoporosis, or osteomalacia. So if you restrict milk or milk products, it will further aggravate. So milk and its products are natural source of calcium and protein, therefore should not be avoided, rather should be used in plant-based. Nutrients and herbal supplementations. Herbal supplementation use is very common, especially in our country, to treat the liver disorders. There are many names available, has been discussed in the morning CGR also. These drugs were found to have unlabeled polyherbals. They have a high level of metals like arsenic and mercury. They have hepatotoxic volatile organic compounds, and they have been associated with drug-induced liver injury, SELF, and they are the cause of mortality in these group of patients. So CAMs should not be used in these group of patients because they are the one who can worsen the, which is a stable underlying liver disease, can be worsened by use of the herbal medications or the complementary and alternative medications. Some common mistakes: forgetting to involve the caregivers. Patient's attendant is equally important than the patient regarding educating the importance of nutritional status and failing to engage in a continuous and the multidisciplinary counseling. So this is very important to have a multidisciplinary nutrition team, which is consisting of a hepatologist, dietitian, pharmacist, and nurses for efficient therapeutic intervention. A caregiver, patient, and the team will have a regular checkup and the re-checkup to ensure that the person is eating enough. Who is not eating enough, finding out the cause and telling them about the changes which should be made to improve the nutrition status. Another mistake is neglecting to adapt the diet when clinical status changes. That means dietary modification is required whenever there is some change in clinical status, like a sarcopenia is, or if person having sarcopenia, malnutrition, or obesity, they need a different dietary prescriptions. Especially a person develops complication, encephalopathy or ascites, or in diabetics, you need a different dietary prescriptions. Similarly, if the person is hospitalized and there is a greater energy support need when they are kept fast for various procedures like CT, sonography, or endoscopy, the oral intake, if it is need to be discontinued, they should be given intravenous nutrition, intravenous glucose. And the people who have low spontaneous food intake, they should always be, or early start of enteral therapy is better compared to the delayed start. Forgetting about sarcopenia in pre-transplant evaluation has already been elucidated by previous other many speakers. Sarcopenia is not a part of conventional prognostic scoring systems. So it's usually is not taken into account the patient's nutritional status. So malnutrition and sarcopenia are important prognostic factors in liver disease. So they need to be considered very well before subjecting a person for transplantation. And these are the studies where the people have shown the importance of sarcopenia, has been discussed by Dr. Dheeman and many other people earlier. And similarly, overlooking sarcopenia in selecting patient for TIPS placement, another common mistake. A patients who have sarcopenia will have poor outcome if they are advised for TIPS. So just to summarize, 4 to 6 meals evenly distributed throughout the day and the late evening snack to shorten the fasting is the key of dietary prescription in liver cirrhotic patients. There is no need for protein restrictions. Encourage diet rich in vegetables and dairy proteins. Moderate salt should be advised in patients who have ascites. Concentrated calorie, including fat and protein, should always be advised. Water restriction only for those who have dilutional hyponatremia. There is no role of herbal medications. Assess the need and supplement the vitamins as and when required. Consider early enteral feeding for patients who are severely malnourished, or if they are not able to take orally enough. And treat sarcopenia with adequate protein intake and exercise program. In obesity, that should be low in diet, should be low in calorie but higher in protein to prevent the muscle depletion. Thank you very much.
Thank you, sir, for a nice and informative talk. Now we are moving to next talk, that is prescribing a diet after nutritional assessment, and which will be delivered by Dr. Ashish Kumar. He is a senior consultant gastroenterologist at the Sir Gangaram Hospital, New Delhi. Sir, please.
Good afternoon, ladies and gentlemen. At the outset, I would like to thank Dr. Saraswat for giving me the opportunity to come to Jaipur to deliver this talk. So I bring you greetings from Sir Gangaram Hospital. Let food be thy medicine. This is what Hippocrates said about 2400 years ago. So every stage of liver disease has specific nutritional needs. So be it healthy, from going from healthy liver to inflammatory stage like chronic hepatitis, fibrosis, cirrhosis, liver cancer, and end stage liver disease, each stage will have their specific need for nutrition. And the factors which influence nutritional needs in a liver disease patient will depend on the stage of liver disease, whether he is having just fibrosis, whether he is having compensated cirrhosis, decompensated cirrhosis. And also it will depend on comorbidities, whether he has diabetes, hypertension, CKD, whether he has deficiencies like he has sarcopenia, he has osteoporosis, and what is the etiology of liver disease. All these factors will lead to deciding on the nutritional needs for the patient. So I would be covering following group of patients who have compensated cirrhosis. The goal is to prevention of decompensation and prevention of sarcopenia. Decompensated cirrhosis, the goal is now recompensation and to make them have a better quality of life. Alcoholic hepatitis patients, where the goal is resolution of alcoholic hepatitis and also recompensation. ACLF, where the goal is survival. And also I would also briefly cover NFLD and NASH patients, where the goal is prevention of progression to cirrhosis. So in compensated cirrhosis, I would thank Dr. Pankaj Puri for making me part of this most important document of NSL on nutrition of chronic liver disease. And it is a comprehensive document which gives all aspects of nutrition. So most of my talk would be based from this. So calorie recommendation for patients with compensated cirrhosis. Cirrhosis is characterized by reduced protein synthesis and enhanced proteolysis because to fuel for gluconeogenesis. And this process of gluconeogenesis requires energy. And so consequently, there's an increase in resting energy expenditure. So normal resting energy expenditure is about 1 into 24 kilocalories per kg per day. That means 24 kilocalories. But in patients with cirrhosis needs higher amount of so it's about 1.3 times the normal. So they would need about 32 kilocalories per kg per day. So in a normal healthy individual, if 1500 is the resting energy expenditure, 200 is the thermal effect of food, 200 is the NEAT or non-exercise activity thermogenesis, and if he's sedentary and not doing much exercise, maybe 100 he's spending in exercise. So for a cirrhotic patient who is compensated cirrhosis patient, if he is doing same level of activity, his resting energy expenditure would be higher. From 1500 it would go up to say 1700. So his caloric requirement would be higher. So we have to take into consideration the higher caloric requirement in these patients with compensated cirrhosis. The protein requirement also goes high. The daily protein requirement in a healthy individual would be around 0.6 or 0.7 gram per kg, but the daily protein requirement in a cirrhotic patient would be about 1.2 grams per kg in absence of malnutrition and 1.5 grams per kg in presence of malnutrition if it is assessed by various modalities. The protein source, as has already been mentioned by Dr. Sunil Dadish, the vegetable protein is preferable because of low sulfur containing aromatic amino acids, which can promote hepatic encephalopathy, and high arginine and ornithine amino acids, which facilitate ammonia disposal. Also, the recommended, if the patient is taking some animal protein also, then the recommended source is either milk-based protein because they contain casein and whey, also eggs and fish and chicken, but red meat has to be avoided. What about branch chain amino acid supplementation? And there have been multiple meta-analyses which have shown that supplementation with branch chain amino acid improves the event-free survival. So, what are the events? Events such as hepatic encephalopathy, ascites. Even it has been shown that it can prevent hepatocellular carcinoma or also help in treating HCC. So many of the societies recommend at least 12 grams per day of branch chain amino acids. For what about patients who are obese, cirrhotics? So first we need to calculate their total energy expenditure, which is where I mentioned the formula 1.3 into 24 kilocalorie. That means about 32 kilocalorie per kg per day. So for a 81 kg obese cirrhotic, the total calorie requirement would be 2600. Now we have to give him some calorie deficit. So we have to reduce by 500 calorie. So 2600 minus 500, that means his dietary requirement should be, dietary prescription should be about 2100 calories. And once we have decided about 2100 calories, the composition should be that carbohydrate should be 50%, fat should be approximately 30%, and protein requirement as approximately 20%, which would be approximately 1.2 to 1.5 grams per kg of the body weight. Now, recommendations for decompensated cirrhosis. The patients with decompensated cirrhosis, when we are calculating their resting energy or the total energy expenditure, we have to do it based on their dry weight, and we have to correct for ascites or edema. So how to correct that? We can use the pre-ascitic weight if that is available, or you can calculate using the ideal body weight based on height and ideal BMI. For Indian population, the ideal BMI would be between 18 to 23. Or you can use the paracentesis weight, or you can correct it empirically by subtracting a percentage. Like for mild ascites, we have to reduce by 5%, for moderate ascites 10%, and for severe ascites 15%. And if the patient additionally has pedal edema, we have to reduce by 5%. So, according to the INASL guidelines, the optimal recommended daily calorie and protein requirement in patients with cirrhosis and both compensated and decompensated, the calorie requirement should be approximately 35 kilocalories, protein 1.5 to 1.2 to 1.5 kilogram, and multiple small frequent meals, at least 4 to 6 hourly, have to be given with complex carbohydrate, bedtime snacks, and protein-rich breakfast has to be recommended. So most of the myths have been busted by Dr. Sunil Dadej. So one of the myths is that patients with cirrhosis should consume low fat. But this is a myth, and patients of cirrhosis have poor glycogen reserve, and hence they require more fat so that they don't have hypoglycemia, and they spare their muscle breakdown. So please do not restrict any fat in patients with cirrhosis. Up to 30% of calories should come from fat, and we should increase their monounsaturated fatty acid and polyunsaturated fatty acids, and balanced omega-6 to omega-3 ratio should be there. We have to reduce their omega-6 vegetable oils, processed snacks, and fried foods, and increase their omega-3, that is fat coming from fatty fish, flax seeds, and walnuts in the diet. And even saturated fat may not be bad for patients with cirrhosis. There has been some evidence that dietary saturated fatty acid downregulates the cyclooxygenase and tumor necrosis factors in patients with alcoholic associated liver disease. So I usually advise my decompensated cirrhotic patients to have ghee lagake. They can have aloo ka paratha, and they become very happy because saturated fat is not restricted. It is more deleterious for patients who are having cardiovascular disease, but patients with decompensated cirrhosis, patients who they need actually saturated fat. Salt restriction for ascites. Cirrhosis induces a positive sodium balance due to impaired renal sodium excretion. So salt restriction is the mainstay of ascites management. However, major issues with salt restriction is that there is a higher risk of malnutrition due to impaired palatability. So a strict salt restriction should not be advised because it is associated with higher incidence of hyponatremia. So moderate salt restriction up to 5 to 6 grams is better, which and we can take care of ascites by increasing the dose of diuretics. What about the dietary prescription in patients with alcoholic hepatitis? Among all the etiologies of chronic liver disease, malnutrition is much more common in patients with alcoholic liver disease, and almost all patients who are admitted with alcoholic hepatitis are malnourished, and because of that, these patients have got higher mortality. And the combination of malnutrition, infection, and organ failure determines the outcome of patients with alcoholic hepatitis. So, the first and most important step in the management of alcoholic hepatitis is abstinence from alcohol and then nutrition supplement. So, what are the causes of malnutrition in alcoholic hepatitis? They are multifactorial. They have decreased protein intake, increased malabsorption. They have mechanical issues due to ascites and increased intestinal permeability, and they have decreased appetite. So all these factors contribute to malnutrition. And all alcoholic hepatitis patients need micronutrient supplements with the thiamine, vitamin B6, pyridoxine, vitamin B12, folate, vitamin A, vitamin C, zinc, and magnesium. So all admitted patients with alcoholic hepatitis should be supplemented with these using the standard doses. Alcoholic hepatitis patients need higher caloric intake, and the multiple studies have shown that the Mendel Health study in alcoholic hepatitis showed that these patients have higher mortality, more than 80% mortality, if they were calorie restricted to less than 1000 calorie compared to those who were consuming to 3000 calorie. And the risk of mortality varies inversely with the daily calorie consumption. So recommended is 30 to 40 kilocalorie per kg per day. What about in ACLF patients where the goal is actually survival? The ACLF patients who are admitted in ICU may need very early tube feeding because they have a net catabolic state due to sepsis, due to organ failure. So they are also having various symptoms like vomiting, GI bleeding, SBP, ileus, and they are kept waiting for hours because they have to undergo various procedures, CT scans, and endoscopy. So NJ, nasojejunal or nasogastric feeding both can be used. The caloric intake should be much higher, 30 to 40 kilocalorie per kg per day, and protein intake up to 1.5 grams per kg per day. Briefly about NAFLD and NASH. The most important treatment for NASH is weight reduction, because with the weight reduction, there's a resolution of NASH, there is a resolution of fibrosis and steatosis. So how do we reduce weight? There are lifestyle measures like diet and exercise, which we can expect a 5% weight loss. But exercise alone is not enough, and we have to always combine it with diet. But if all these measures fail, then we have to go for drug therapies like GLP-1 agonists are now upcoming drugs, or endoscopic therapy, bariatric surgery. But the first step towards counseling of these patients is their dietary counseling. So we have to assess what is the calorie consumption per day, starting from their morning tea to their dinner time. We have to calculate how much calories they are consuming. So this is the example of one patient who came to me, and when we calculated their calorie consumption, he was consuming about 2,800 calories per day, which was way too high for a sedentary individual. He should have been consuming approximately 2,200 or 2,300 calories, but he was consuming 500 calories extra every day, which was contributing to his obesity. So we have to reduce weight, we have to cut down the daily calories. And this is the basic principle of weight loss, is that you have to consume less calories than what you are burning. So try for a deficit of around 500 to 1000 kilocalories per day. And 1 kg of body weight is approximately equal to about 7,700 calories. So if you reduce the calorie intake by just 500 calories per day, you can reduce the weight by 1 kg in 2 weeks' time. So this strategy of continuous energy restriction or daily calorie restriction is simple. And how do you achieve this daily calorie restriction? You can reduce the portion size. You can ask him to take meal in smaller plates so that he consumes less amount of food. Then you can ask him to choose a low calorie dense food. So for example, if he eats even 1/3 of burger, that would be 300 calorie, and he still would be hungry. But if he consumes the same 300 calories in fruits and vegetables, he would feel full. And then we can advise some of the patients who have smartphone that they can track their caloric intake on day-to-day basis. Although most people are not able to do it, but even if 10% are able to do, we can make a big change in that. So this among all these three things, the choosing a low calorie dense food is most important. So in the patients which I just mentioned, if he just instead of taking the normal lunch he was taking, if he replaces it with a plate of salad, he would consuming 500 kilocalories less than what he was consuming, and he would consume approximately 2300 calories, which would actually lead to weight loss in this patient. So we would be able to achieve 12 kg weight loss by just simple one change in the his lunch. And the alternative to daily calorie restriction is the intermittent fasting. And there are many types like alternate day fasting, 5-2 diet, which you can find from anywhere. And we can expect 3 to 8% weight loss with intermittent fasting. And some studies have shown that intermittent fasting can lead to reduction in blood pressure, also improvement in dyslipidemia, and improvement in insulin resistance. So dietary recommendation for NASH: hypocaloric diet, at least 500 to 1000 kilocalorie reduction; low carbohydrate diet, 50% from carbs and less than 5% from added sugar; 30% from fat with less than 10% from saturated fat; 20% from protein; avoid fructose containing diet; substitute saturated fatty acids with the PUFAs and NUFAs; prefer oil with more health benefits, and increase soy content, increase fiber, and ensure adherence to whatever diet he chooses. So take home points, ladies and gentlemen. For compensated cirrhotic patients, the total caloric intake has to be increased to about 32 kilocalories per kg per day. Protein intake should be 1.2 grams per kg if no malnutrition, or 1.5 grams per kg if there is malnutrition. And in obese cirrhotic patient, there should be a caloric deficit of 500 kilocalories. For decompensated cirrhosis, increase the caloric intake even further up to 35 kilocalorie per day, 1.5 grams of protein. Do not restrict fat, but moderate restriction of salt intake. For alcoholic hepatitis patients, increase the caloric intake even further up to 40 kilocalories per kg, and focus on micronutrients because they have so much of deficiencies. For ACLF patients who are admitted, institute early tube feeding because they have very poor appetite, and they have to wait for various procedures. And for NAFLD and NASH patients, reduce the calorie intake by at least 500 to 1000 kilocalories per day, and reduce the carbohydrate intake to 50%. With this, I would like to invite you to our, which we are starting in Asal clinics on HCC at multiple cities. These are the dates. You can get the details and you can register under the patronship of Dr. Subrat Acharya and Dr. S.P. Singh and Dr. Ajay Duseja. I invite you to any of these cities for a simple evening symposium on HCC. Thank you for your patient hearing.
Thank you, Dr. Ashish. We'll move on to the next talk. Whatever said and done, unless the patient will have some chart in the head, what not to eat, what to eat, how much to eat, that all talks will go on. So I'll request Dr. Charadua to come and say the patient from his all problems. The topic will be formulatory diet and monitoring intake. Welcome, Dr. Charadua.
So good afternoon, everybody. At the onset, I would first like to thank the organizing committee, especially Dr. Vivek Saraswat and Dr. Sunil Dhatche and Dr. Bhaskar Nandi, who has introduced me to this forum. While I was spoken by Dr. Vivek Saraswat, he clearly told me we do not want to listen guidelines. We know it all. You have to give us the practical tips. I hope I do justice at the end of my talk, what has been asked by the organizers. So greetings from Amrita Hospital. It's a beautiful hospital, the Asia's largest hospital, 2,600 bedded hospital, a big campus. I would request you all to come and visit us there once. So I'm Charu, I'm the chief dietitian at Amrita Hospital, and I'm trained on FODMAP diets too from Monash University. So, what should actually be the approach to a patient when you are planning a diet? What should be going in the mind of a dietitian? We have to have certain nutritional, medical nutritional goals. We have to improve malnutrition. If we are not able to do that, patients coming to us, it's all theory. We have to convert the theory into practical. We have to correct the nutritional deficiencies. We have to take care what route we have to be taking, how much orally the patient is taking, do we need a supplementation of ONS, etc. The exact calories have to be calculated by us. You cannot just say take one scoop of an ONS. You have to first assess what a patient is eating, how much is the deficit, and then have the calorie planning done. The tools that we are using for assessment, we know there is no gold standard nutrition screening tools, but whatever best suits and whatever best is being utilized in various hospitals is SGA by the dietitians. We need to follow the latest recommendations and make it into the practical knowledge, and we need to have a case centric approach, as we cannot follow a peanut butter strategy for all, and we have to convert the doctor's prescription into the plate of the patient. So we all know, we have been hearing about this since morning, which patient is malnourished. We know we have to focus on both of these patients because of sarcopenia being settling in. And with the numbers being as high in Asian numbers, that 2/3 of the cirrhotic patients have malnutrition, and 4% of the Asian deaths are due to cirrhosis. Despite knowing all this, patients don't walk in to the dietitians. That's the irony, and they do not consume the required calories and proteins. So we should know what is going on. We know there is an inadequate dietary intake. We know there is impaired digestion and absorption. So there's so much which is going on in the patient. As a dietitian, before giving a diet plan, we should know what are the alterations that are happening in the patient, so that we are able to assess and identify the problems and give the diet accordingly. And we should be focusing more on inadequate dietary intake part rather than the other part, because we are not trained enough to take care of the other three aspects. We are trained enough to take care on the only the 1/4 quartile of the situation. We know there is an there is an accelerated starvation phase in all cirrhotic patients. Enough has been talked, so we will not be talking about it. So we have to focus on each and every aspect of the goals. There is an importance of dietitian in a multidisciplinary approach. There are a lot of studies which says if the dietitian is involved from the very beginning, the outcomes are better. So what we need to be doing is a detailed nutrition assessment, a detailed weight loss history. A consultation when a patient is coming to you should not, first consultation should not be less than 30 to 40 minutes. You should be looking forward for all the signs of malnutrition, etc. Lot has been talked on frailty, lot has been talked on hand grip since morning, lot has been talked on sarcopenia. You should be aware of that and do a deep analysis. Do remember to see the feet of your patients. That will give you an idea that yes, the patient has pedal edema, and what state of malnutrition. That's one physical sign telling you that the patient is malnourished. Because when the patient comes to you, there is lots to see, and if you spend too much of time seeing the medical history, you will not be able to give enough time in giving counseling and the healthy tips. That is what is required by you. So in a nutrition care process, once you have identified the nutrition risk, you need to identify the nutritional diagnosis, because that is what you are going to treat. And in nutritional diagnosis, you have to see where and what the problem is. Why is the patient not able to eat? Is the problem because of the disease? Because that you will not be able to combat immediately. The intake is 500 calories and you have to achieve 2200 calories. It will not happen in one day. So you have to talk to the patient how and what steps you will be taking, in how many days from 500 calories to 2000 calories is what you are going to achieve. And you have to get back to the doctor also, and you have to tell him, you have to inform him that what is your plan. But the plan has to be short term and long term. Is there a behavior problem? Is there a dietary myth? Is there a family support problem? Is there an awareness problem? Achieve to the nutritional diagnosis and start treating that, and then the results are going to come. Also make sure that you are doing a short term and a long term planning when you are doing your interventions. You also have to take care that you need to make these patients come back to you for regular follow-ups. One diet consult would never be enough for these patients. They have to consistently come back to your clinic. If they are not coming back to your clinic, results would not be evident. So make sure at every time you're educating them in such a manner that they automatically come back for follow-ups in your clinics. So what happens in IPD? So this is about the OPD aspects. When we talk about inpatient gaps, there are a lot of inpatient gaps when the patient is hospitalized. He is not eating. The food in the hospital is not palatable. It is not by his choice. And because of the dynamics of healthcare, you see a lot of patients are not eating that much what has been prescribed. Your cyclic menu would be 2200 calories. But what is the intake that patient is doing? How are you doing a daily calorie charting? That is very, very important. And how within the limited resources and with the support of ONS. So what generally I have seen is during the hospital stay, all these patients who are on oral diet also, a ONS support is needed. That is very, very important, so that the higher calorie requirements are met. Only through the diet, meeting the calorie and protein requirement, with my experience, I'm talking about it, is not very practical to achieve. Nutrition should be an integral part of the management of cirrhosis disease, but nutrition, especially without monitoring, has its own set of complications. The previous speakers have also talked about the switches that happen, the debunking of the myth. If you're moving from decompensated liver disease to a compensated liver disease, and then you are gaining weight, you cannot follow the diet when the decompensation happens. So you need to switch on and switch off mode, and the dietary recommendations have to change, and that's what the dietitians have to be aware. So if you are an overweight person, you have to guide him on the quality of complex carbohydrates, and you have to make sure, even if you're prescribing a salad to this patient, that salad has to be a protein rich salad, not a vegetable rich salad. Even if you're prescribing a fruit to this person, fruit has to be combined with nuts, for example, to add proteins in the diets, because protein recommendations are not changing for the overweight obese persons. So you have to add proteins even in the low calorie food items that you are giving to these patients. So we know there are various healthy diets. There is a Mediterranean diet, there is a Western diet, there is a DASH diet. But are they actually true in the Indian scenario? People cut, copy, paste. When Mediterranean diet was in a boom, I remember when I started my career late 99 and early 2000, Mediterranean diet was a boom. Every doctor, every cardiologist was talking about olive oil. But are we talking about olive oil today? The answer is no. Our Indian oils are healthy enough, giving us enough omega-3 fatty acids and giving us enough omega-6 fatty acid. A combination of oil, you will get everything. So when patients come and tell you that we are taking olive oil, please tell them it is not one of the healthiest oil. You have to have combination. Olive oil is also not going to give you any omega-3 fatty acids. So you have to mix a combination. So you have to see what your patients are doing. And on the top of it, there is a transcultural diversity in India. There are 41 dietary patterns which are identified in India. So with Mr. Subramaniam in South India, and Mr. Ravi Shankar in North India would not have a same eating pattern. So as a dietitian, it is expected of you that you get into their recipes. Understand, I am not a Bengali. And if a Bengali patient comes and starts asking me about fishes, I need to read, learn, and adapt from the patient. And thanks nowadays to the social media, it has helped us understand more, right? And we're talking about NAFLD, which is on an increasing trend because of the demographics, because of the environment, genetics, and the diet, be it our portion control, be it the processed food inclination. A survey which was done by ICMR, there is a plate that ICMR NIN has launched. I'm not showing that plate. Processed food component is not standing in that plate. But when they did a survey of all Indian diet all across India, even in rural and urban sections both, there is enough element of processed food and trans fat intake in the diet. So remember, whenever you are talking about fat in liver disease patient, you are mentioning about trans fat. All your street food, all your samosas, all your uh, bread pakoras, etc., have trans fat into it. Though we are not restricting fat as per the guidelines, but samosas, bread pakoras, tikkis are not the choices that you will be giving them, and you will be telling them to have that, because that's going to lead to another complications. So what should be a nutrition prescription? So when a patient comes to me, I tell him इन नंबर्स, डॉक्टर ने आपको 1800 कैलोरी बोली है और आपको बोला है 1.2 grams of proteins you have to eat. Are you able to eat this much? He says, I eat only one egg and I eat 1 katori of dal a day. And when you calculate the protein intake, he is not even taking nearly 50 grams of protein, whereas the recommendation goes up to 80 to 90 grams. So how will you achieve that? So that's the first question that you put in his mind. When you put this in his mind, he thinks that he's talking to a learned person, and he starts buying in with you, and he starts building in confidence in with you, and he's willing to follow the diet plan that you are telling. You are not a XYZ dietitian to whom he has visited, because that's very crucial. Your prescription has to convert into the plate. That should be your goal, right? So you have to tell him the calcium, because most of the people have stopped taking milk. How will your vitamin D and calcium balance happen? Micronutrients, doctors have already been prescribing them vitamins, so you're not that bothered, but you need to check that on their prescriptions. And if you have to see that if they have edema, what salt prescriptions you have to give, and do they need a bedtime snack, is what you have to write it on your prescription, because when they see this prescription, it acts as a reminder to them. Definitely work on ideal body weight. The calorie, energy, protein, and fat requirements have been spoken about my previous speakers. I'm not going to go in deep, but definitely work on their goals and said that this is what you have to do. Calculate in front of them. Talk to them about their ideal body weight. Talk to them about the dry body weight. Doctors don't have that much of time to do. That's your work to do, right? So this I will be skipping. So start educating the patient first. Make good handouts so that patient is able to understand whatever we are talking in this forum. The points of those have to be in a handout, because whatever we have learned through experience and our practice, patient does not know it. Patient does not understand what is malnutrition. So you have to tell what will happen if he does not eat and what is malnutrition. So make a handout for them and talk about an organ. So we have multiple handouts in our organization for this. Use pictorials, because that will have a better impact rather than giving a written prescription. Tell them, if you have to tell them that you have to eat 5 to 6 small frequent meals, tell them when a child was born, you were feeding the child every 2 hours. You have to feed yourself 2 hours to achieve to the calories. You have already taken a diet recall. You've already taken a diet assessment where you've already told him you're eating 1000 calories, you're eating 1200 calories, and you have to go to 2000 calories. So tell him the gap. So when he understands the gap, he will make an attempt to eat. If it is a behavioral diagnosis, then your way of handling this patient would be different. So decide what you need to do, because when you're handling a nutrition diagnosis, your approach has to be that ways. You have to focus on a balanced diet approach. Enough carbohydrates, enough proteins, and enough fats. All have to be included. Yeah, I will conclude. Yeah. 50 to 60% of your calories have to come from carbohydrates. You have to eat more in breakfast, because that's where the circadian cycle works. Your appetite is the best in the breakfast time. So whatever you are giving, make, for example, if it is a porridge, you tell a patient, please add ONS syrup, add some nuts into your porridge and make it more calorie dense. Add a little 1 teaspoon of ghee into your porridge. So whatever he is eating has to be a calorie dense. Regular porridge, 500 calories. If you make it calorie dense, convert it into 800 calorie porridge. I'm giving you an example. So think like that. Give solutions like that to these patients. That is very, very important, right? We know Indian diets are carbohydrate and fat rich. And since morning, we are talking about proteins. We are only talking about proteins. So how will we be achieving proteins is what you need to give them the solutions. Give them a technique that this is a plate. Finish your proteins first and then go to the non-protein calories. Ask them the leading questions. Do you eat protein in all the meals? All your meals should have proteins, and give them, these are the sources of protein. Now you start calculating. You can give them an exchange also, that okay, 1 katori of dal will give you 7 calories, because we don't have nutritional labeling very strongly available in India, but still it is improving. So you give them the exchange of proteins and tell them, you calculate, you have to come back and you will have to tell me, make them their dietitians. Now, when we talk about sodium and their palatability, we know if we give a very low sodium diet, the palatability would be an issue. So give them solutions from your side rather than no. But also warn them. On salt, I would like to mention, there was a survey which has been done by WHO, which says an Indian average diet consumes around about 15 to 16 grams of sodium, 50 of salt every day. So 2 teaspoons of salt is consumed by an average Indian, and in cirrhosis it has to go to half to 3/4 teaspoon. And every patient walking in my OPD chamber, I have never heard he saying कि मैं नमक ज़्यादा खाता हूँ. He will always say मैं नमक कम ही खाता हूँ. So you have to tell them how to quantify that namak, how he has to make sure that the 2 grams of sodium that has been prescribed to him, how he will be doing that. So you have to give him some solutions. You have to give him solutions each food group wise, so he understands. Tell him to read nutrition label. FSSAI is working a lot on nutrition label and also is making a mention on low sodium labels. So tell them, if you're taking packaged food, that has to be taken. If you're taking butter, take yellow butter. Processed food mat khao, because they are high in sodium content. Cheeses mat khao, ghar ka paneer khao. Greek yogurt ko paneer bana ke khao. So you have to give them solutions. Chutney khani hai तो खाओ, बट उसमें नमक मत डालो. यूज आमचूर इनटू इट, यूज इमली इनटू इट, यूज भुना हुआ जीरा इनटू इट टू गेट द टेस्ट एंड टू गेट द palatability, so that the intake improves. Handle the myths on fat consumption. We have already spoken. Talk about meal and snack timing. Give them examples. What mealtime snacks? Doodh pee ke they are bored. They also want variety. So give them the examples of mealtime snacks. Answer to their queries, when to eat when they are full early, when they achieve early satiety, how can they combat it? So give them these answers. Give them smoothies when they achieve satiety. Make their fluids high calorie, high protein dense. So that is one way they can achieve. For weight loss, I've already spoken. We have to take care that the weight loss happens and healthy calories are given. Healthy fat is given. Trans fat is avoided. Give them the healthy choices. Enough water is given. Healthy proteins is picked up, and whole grains have to be stressed upon. Biscuits should be out. From my point, I'm not saying like biscuit is not a very healthy item. Eat biscuit जब कुछ और नहीं है खाने को, right? Give them a handout for choices. Just last 2 slides, I'll finish. Give them the handout of the choices, the vegetable, the fruits, the cereals, the proteins, and give them the alternatives. ये खा सकते हो, ये अच्छा है, ये नहीं खा सकते. So that's what a patient is asking a doctor. So when he comes to you, and when you have given them these choices, he is not going to go back and ask these questions to the doctors. So if you give a sample diet, what is important is monitoring of this. Now, I have not purposely put a calories on these diet. On the meal options, I've given the variety options to the patient. Calories you have to discuss with him. You have to quantify the calories with him and tell him, okay, I've made a 2000 calorie diet. Now, after 1 week, you have to come back, and on this calorie prescription, you have to tell me how much did you consume. So, as a dietitian, you are able to derive how much is the dependency on oral nutrition supplement. Rather than just vaguely prescribing an oral nutrition supplement, this would be an objective way of prescribing an oral nutrition supplement. 2 scoop, 4 scoop, 20 scoop, kitna? When a patient is taking 500 calories, what will 9 scoop of oral nutrition supplement do? From 500 calories, 9 scoops is going to just add 500. So you're only giving 1,100 calorie diet. So that's what, and you have to tell the patient the oral nutrition supplement requirement will reduce when your dietary intake is going to increase. And that's what brings the patient partnering with you. So these are few examples. The challenges of the hospitals have been spoken, has to be met. Procedure challenges, NPO challenges, and the kitchen feed challenges. The highest calorie kitchen feed when you have prescribed or planned, and at that time the patient has a procedure planned. So what happens to the calories? So my recommendation is, during the stay in the hospital, prescribe ONS, prescribe the commercial formulas, and to even oral eating patients, because that's the maximum time. And I've practically observed it. Somebody very close in the family from 113 kgs went down to 70 kgs. And I've seen how the decompensation has happened, and from decompensation to compensation journey is also seen. So you have to see the maximum nutrition deficiency happens during the hospitalization stay, right? So this I will be skipping. Encourage for regular visits. That's what is very, very important. And to a qualified nutritionist. To summarize, reduce dietary intakes, metabolic alterations, and modifications in disposable of energy sources are few of the among causes of malnutrition. Treatment of malnutrition starts from its recognition, patient education, dietary assessment, and intake analysis. All has to be taken care. Eating an adequate number of calories and proteins is much more important than avoiding any specific kind of a food, and the myths have been debunked today in this session. Generally, healthy eating and a variety of protein. Variety would be the crux. Having a balanced diet approach, including all food groups, is what is very, very important. That is what you need to see. Fats should be restricted. The bad quality fats should be restricted. Trans fats are totally out. What you need to do is encourage omega-3 fatty acid. Your mustard oil, your soybean oil is rich in omega-3 fatty acid. There are other dietary sources of omega-3 fatty acid. So prescribe those kinds of fats to your patients. A moderate salt restriction, fluid restriction is not advisable for these patients. Some patients with liver disease and other comorbidities and overweight, the dietary regime may change. Supplementation of ONS has to be objectivized. Cultural and socioeconomic differences have to be taken care, and higher protein content in the breakfast is advisable. Thank you. Namaskar. Thank you.
This will conclude this session. Questions can be taken by everyone in nutrition. So with this, we conclude this session.
Thank you, speakers and chairperson, for the valuable talk. I now request the faculties, dignitaries, and my colleagues to join us for lunch in ground floor RK block, and we will continue the session following lunch.
Good afternoon, everyone. Welcome to the post-lunch session. In this session, there will be a case discussion for which I would like to invite our respected panelist, Dr. Abhinav Sharma sir, consultant medical gastroenterologist, CK Birla Hospital; Dr. Sunil Taneja sir, additional professor in Department of Hepatology at PGI Chandigarh; Dr. Sudhir Maharishi, associate professor in Department of Medical Gastroenterology, SMS Medical College, Jaipur; Dr. Medhavi Gautam ma'am, director of Medhavi's NutriFit, former chief dietitian, SDMH. For this, we will have moderator Dr. Vivek Saraswat sir, professor and head of Department of Hepatology at Mahatma Gandhi Medical College, Jaipur.
Well, good afternoon. I think as people trickle in after their lunch, we can get going. Dr. Medhavi, please come and join the panelists on the podium. All morning you have listened to some very educative and illuminating talks on the subject of nutrition in chronic liver disease. I thought what we will do in this session is talk to you about a patient, the kind of patient that many of us see in our centers, and how would we specifically manage the nutrition, and how did we manage the nutrition in this individual. So can I have the slides projected onto the screen, please? Right, so this is a patient with autoimmune liver cirrhosis who was planned for liver transplant, and how did we manage her nutrition? So I'll first take you through the clinical case history background, and then we'll come to the nutritional issues a bit later. This 31-year-old lady had first come to our center in November 21 when she presented with marked abdominal distension and anasarca, which had been waxing waning for the previous 3 months. For the previous 1 month, she had developed deep jaundice, and during this period of 2 or 3 months, she had had at least 3 bouts of altered sensorium, confusion, drowsiness. She had been diagnosed to have a joint disease, which she was told is rheumatoid arthritis, for the previous 5 years. And also, for a similar period, she had been aware of a large lump in the left upper quadrant of her abdomen. No fever, diminution of urine output, or GI bleeding. Diuretics had been used off and on for the previous few months, and earlier she had received treatment with NSAID for a prolonged period for her joint problems, but of late joints had been pain-free for the previous few months. On examination, conscious, oriented, no flap, quite pale, deeply jaundiced, gross anasarca, pitting pedal edema was present up till the mid-thighs. There was cutaneous edema on the abdominal wall, and sacral edema was present. Marked thinning of the limbs was noted, and there was flexion deformities in the right wrist and the right elbow, and many of the small joints of the hands were also showing restricted movement. At 158 centimeters of height, she weighed 72 kilograms. A lot of it must have been the fluid that she had retained, to give a BMI which was apparently 28.8 with the actual weight. But if you correct for this, and I think we'll come to that in the next few slides, then the BMI actually came out to be much lower. Empirical correction for the fluid retention and grading of fluid retention was used for this. Tense grade 3 ascites was present with a big spleen felt on dipping. The liver was not percussible or palpable. So this was the overall picture that she came with. Since we're not really talking about her clinical management overall, but mainly about her nutrition, I'll quickly take you through the investigations which we had at this admission, which showed that she was quite pale, hemoglobin was low, and there was pancytopenia. Platelets were only 18,000 with the total leukocyte count of less than 1500 per cubic millimeter. The liver function showed bilirubin of 13.7, some elevation in her transaminases. The serum proteins as well as the albumin were reduced, and the PT-INR was prolonged 2.2. Autoantibodies were present. ANA was positive 4 plus, and speckled pattern was noted. Asthma anti-smooth muscle antibody was present, and the total immunoglobulin levels was elevated. Over the anti-LKM, ANCA, AMA, other thyroid antibodies, they were negative. Ascitic fluid showed high SAG ascites. They were, sorry, that got missed out. They were grade 2 esophageal varices with no red color sign. And the other organ functions, renal, lipids, thyroid function, the anemia, although she was hemoglobin was 8.7, but the transferrin saturation was not bad. Iron profile showed a 35% iron saturation. So with this, we made a clinical diagnosis of decompensated liver cirrhosis due to autoimmune hepatitis, because I think as a joint disease, I have not elaborated on the findings there. Small joints of the upper limbs and to a lesser extent of the lower limbs were affected. Axial skeleton was not involved. There was portal hypertension, grade 2 varices, and a high SAG uncomplicated ascites. The decompensation was in the form of moderately deep jaundice with grade 3 ascites and history of grade 2 to 3 hepatic encephalopathy episodes. As a comorbidity, she had a marked splenomegaly with hypersplenism, whether part of portal hypertension or part of her rheumatoid or connective tissue disorder, accompanied by a moderately severe anemia, which appeared to be more like anemia of chronic liver disease. Child score was 10, MELD sodium was 22. No complications like GI bleed, infection, or AKI or cardiopulmonary symptoms were present. So with this, I'll ask Dr. Sunil Taneja. He's done an excellent talk this morning on assessment of nutrition in people with liver cirrhosis. In this patient, what would be your approach? You told us in the morning, but maybe you can compress it for this specific patient. How would you go about assessing her nutritional status? And to begin with, like with her grade 3 ascites, BMI, one of the basic anthropometric indices, I mean, what sort of corrections do you think she would need before we can actually use this parameter effectively?
I think and so if you want to correct grade 3 cycles of 5, 10, 15% so actually get this patient and first time is correction for the private, then that would be
so 20% or so reduction in her actual weight, which if she was 72 would come to around 56 or 58 kg would be her weight, right? That is resumed weight. So that's exactly, I think the 2019 EASL guidelines mention this. So is there some evidence that these are accurate applications, or this is a rule of thumb empirical corrections that are applied in this? I mean, you get closer to the actual dry weight, but I think validation of these numbers is probably not evidence based. Right. But anyway, it's a useful thing that one can use empirically in these people to try and assess their nutrition. So I think this is the usual thing that we do. Maybe we'll just go through these slides. I think some of these were discussed very early. Some of you were there for the first phase that was done. So anthropometry, biochemistry, clinical examination for screening and assessment, and the dietary recall method is what we've been following here at Mahatma Gandhi. So what anthropometric indices would be relevant in this patient, Sunil?
I think all the guidelines
Fallacies.
It's not accurate. I would say better to be to an extent that assessment whether
Right. So the numbers are shown here. If in this patient at 158 centimeters, her height was 72 kg. I think dry weight, I think this is minus 25 was applied, minus 20 should have been done. So she was about 50 6 kg would have been this weight, and appropriate BMI would have been about 20 odd. Tricep skin fold thickness, which that we have tried to show here, is measured at the midpoint of the triceps using calipers that are applied, was just 4 millimeters, and generally tricep skin fold thickness of less than 10 millimeters is considered to be underweight. So basically you use this index only to decide about a person being underweight or undernourished, but you can't really grade the severity of undernutrition using this parameter. The mid upper arm circumference was 17.8 centimeters, which is then measured as has been shown here between the acromion olecranon and the midpoint, and using a tape to measure the circumference give us a circumference of 17.8 centimeters. This is usually a part of the anatomy where you do not have much fluid retention or pitting edema happening, so it would be more reliable and applicable than trying to say do a calf circumference or some in measuring in other parts of the body. Generally, mid upper arm circumference of less than 23 centimeters is considered to be underweight, and the mid arm muscle circumference, which is calculated by this equation here, that is this is the value for pi, and like 2 pi r is the usual circumference formula. So if you use the triceps skin fold thickness multiplied by 2 pi, you get, and subtract that from the mid upper arm circumference, you get the mid arm muscle circumference, which was 16.3 centimeters in this patient. And as Sunil has told us, while these give you a general idea that the patient is undernourished, but doesn't really help very much in deciding the severity of malnutrition, or in well, it will be useful for follow-up. So these were the numbers suggesting that there was a moderate degree of malnutrition. So I think coming back to this, I think this is, well, I think Dr. Sudhir will tell us about the nutritional risk screening tools that have been used in cirrhosis. What are your some of these scores I have shown here for the benefit of the audience. So what are your thoughts on this? How relevant are these for our patients who, I mean, like this person appears to be already clinically moderately to severely malnourished. So what relevance would such tools have in our patients with cirrhosis? More in compensated, you think, than in decompensated? Just keep the mic a bit closer, closer to you. Right. So I guess the ones that are shown in pink at the bottom are more liver specific. First is a screening tool, and I think the RFH-SG, Royal Free Hospital subjective global assessment allows you to grade the severity of malnutrition in these patients. So I think these slides were shown, some of these were shown early in the morning, mainly in Dr. Sunil's talk. I'll just quickly take you through. This is a subjective global assessment is what is most widely used. It has been one of the first tools that was introduced, and that is why most people are familiar with it. And this table shows you what all do you look at in the points looked at in the history, points looked at in the examination, and based on this you grade the person into a well nourished, mild to moderately nourished, or severely undernourished. And this is most of these parameters are subjective, related to current or recent or previous dietary intake and recall, etc. So that's why it's called a subjective global assessment. Further, most people now talk about the Royal Free Hospital nutrition prioritizing tool, which Dr. Taneja showed us earlier in the morning. Again, you can directly look at this at 3 steps and grade them using a score between 0 and 7. And this has allowed grading into low, moderate, and high risk for malnutrition. As you can appreciate, most of these tools are most applied in the OPD in relatively compensated patients where a large number of cirrhotics attend, and their risk of malnutrition can then be assessed. In compensated patients, malnutrition is more to the tune of about 15 to 20% compared to 50 to 80% in decompensated patients who have the risk of malnutrition. And this helps us in the management guidelines. Finally, the Royal Free Hospital Subjective Global Assessment Tool is basically based on BMI and mid-arm muscle circumference that I just showed in the earlier slide, and dietary intake. Using these three parameters, you grade people on the basis of yes, no responses into moderate or severe grades of malnutrition or adequately nourished. And as Dr. Sudhi told us, this can then help in deciding how intensive your nutritional care or your nutritional management will be for the individual. So these are some of the tools that have been used. So now I think Abhinav, you could tell us about what would be the further workup for nutritional assessment that we could use, something that Dr. Taneja referred to earlier regarding frailty and sarcopenia, which are shown here.
We have to have objective to so here we have to focus on two things. And then reality. Most objective. So we have used for that is three component paid from and then there is the strength coordination between
strength and coordination as well you do. So I think I'll not spend too much time on this because I think several speakers in the forenoon sessions have talked to you about the short physical performance battery and the LFI liver frailty index. And this is, I think Professor Sareen spent some time emphasizing that how with crossed arms without taking support from the armrest, the person has to sit up and stand, how to sit and how to stand at the edge of the chair and to stand up. I think he elaborated quite lucidly in the morning sessions. And the 3 feet position for assessing tandem walking as well as gait speed. The 6 meter walk test is separate, but for gait speed, you look at the time that people take to walk 4 meters. And the numbers as they were in our patient are shown here. In the balance test, which is each one of these is supposed to be held for 10 seconds to score 1. Here, the patient in the semi-tandem and they could hold the tandem position for much shorter periods of time, and so they had a low score for this. So it's 0 or 1 for the balance tests. The gait speed, the patient took 3.12 seconds for the 4 millimeter walk, and according to the nomograms, this was a speed of 3. While the chair stand test, patient took 12.5 seconds to do 5 chair stands, based on which these scores were given, so that the overall score is 6. And if you look at the interpretation for severe, moderate, and mild frailty, and for a robust person for the SPPB, these numbers are shown here. So according to which our patient was moderately frail. The liver frailty index, again the same test, instead of which hand grip is used other than this. And again, since that was his topic, I think we can't really go into the kind of detail that Professor Sareen went in the morning when he talked about liver frailty index in great detail and very critically. We looked at it in our strength. So while 25 kilograms was the strength that was mentioned as a cutoff to show frailty, our patient's hand grip strength was very weak. Possibly not just muscle loss, but as I mentioned, she had a problem with her joints. She had fused wrist and elbow joints, and may also have contributed, the joint disease may also have contributed to a loss of hand muscles, and thus a weak grip strength, which are confounding factors. So this is not all liver disease alone contributing. And time taken in 5 chair stands is mentioned here, as well as the balance test score was poor. So which meant that the patient had a score of 5.78, and anything more than 4.5 indicates severe frailty, which is what our patient had. So patient is malnourished according to the objective indices we have shown, and the patient is quite frail. And the numbers showed the anemia, low transferrin saturation, low levels of vitamin D. So there were specific nutrient deficiencies were also identified. Um, and the now the previous when she this is refers to a first admission in November of 21. The dietary recall method generally is reliable only for the previous 3 to 7 days. So for the previous 3 days, they averaged out dietary requirement actually shows you the numbers which are very low. What she should actually have been consuming, what was her real requirement, and versus what she was actually consuming. Almost um, 50% reduction in calories, similar reduction in protein and carbohydrate intake was noted. Some of these numbers are was present. So sorry. Now, yeah. So nutritional diagnosis. This is what it shows you according to the ABCD. We said underweight, malnourished, moderately frail, and L3SMI, unfortunately wasn't able to retrieve her X-rays to get it, but that also had shown indices which were sarcopenic. Vitamin deficiency. Clinically, there was no overt sign of malnutrition, and there was poor dietary intake according to the dietary recall. So I think with this, come to you, Dr. Medhavi. I think we'll go through these slides that uh, how would you plan her nutritional management and the goals and the specific steps that one would like to go through for this patient?
So when we come to the nutritional management, seeing the profile of the patient, the patient was extremely low on the intake part. So we gradually start with the intake of food, start with full fluid diet, and then gradually come to some solid and solid. Concentrating on the nutritional part, when we are planning, it has to be a very small and most frequent meals. The averagely what we should plan is 3 meals and 3 snacks with the small intermittent duration of some fluid or liquid also in between if required, because the appetite burn was extremely low. And gradually then we can come to semi-solids, concentrating on proteins, specifically plant-based proteins, and then second choice would be a dairy-based protein rather than the animal-based proteins. And talking about energy, as we know, we would have to anyways the concentration of energy has to be maintained with this patient for primary source of expenditure of energy. So it has to be more from the complex carbohydrates than giving them the simpler forms. And then concentrating on micronutrients equally because they have a major role in it, specifically vitamin D, vitamin E. Also, I would want to highlight on giving them a good source of antioxidants, as oxidative stress is quite high in the decompensated patients. And the role of antioxidants have been nicely seen in these patients. So we should incorporate more of vitamin A, beta-carotene based things, also with vitamin C because that's going to improve on the sarcopenia and the frailty also of the patient. So and vitamin E along with zinc. So these things should be incorporated when we are planning the nutrition plan because they are going to play a major role. Along with the macronutrients that we are already focusing. Fats, as we know, has to be on the buffer side. Saturated fats has to be less than 10% of the total calories. And oil, as it was also mentioned in the previous presentation, has to be a combination of oils. Rather than specifying on some particular oil, it has to be a combination of oils. I would also want to highlight the role of millets when it comes to these patients because millets has been a wonder food as long as the decompensates the patient because we have to have good amount of iron as we have to see the patient, calcium because we don't want any kind of further weakening of bones also, and millets will provide good amount. So specifically jowar and barley and all these will be good for such patients.
So I mean,
Yeah.
no, please go ahead. You're finished and you can come back.
And proteins, as we have already discussed, has to be a good amount of protein. Anyways, it should not be cut down because there have been many misconceptions also that you have to keep a little low profile of protein for such patients. But we know that it has to be more of so obviously all the nuts comes into this and your all the lentils come into this, so where protein has to be highlighted.
So I think
It's
what
just
we are
that
talking about are the general principles. I think we had an excellent talk on that in the earlier session from Dr. Ashish. So specifically for this patient, like you say, you want to give antioxidants. So from the dietary route, are you able to provide sufficient doses of antioxidants that these people need only as food items, or should they will invariably require supplementation by pharmacologic, I mean by drugs?
absolutely, initially they will be requiring a supplementation only by the drugs because we have to get it to that bar level as the patient can come to that. And then it can be further maintained with dietary incorporation in the food on a daily basis. So initially it has to be supplementation of vitamin A, vitamin C, and vitamin E, and also vitamin D. So specifically the three antioxidants, why I'm saying A, C, and E is because these are the only three antioxidants which are available in dietary sources also. So that can be incorporated later in the dietary sources, but yes, initially supplementation has to be.
Okay, so I think that is the other general principles, and I think I'll just take you through what we actually did here. Would any of the other
One small thing is to also add some anti-inflammatory herbs also in the diet, which can be like curcumin, has already been a lot of discussion on this, and such things can be incorporated later in the things so that you can maintain the profile.
Right. So I think you have indicated the general principles fairly clearly, but I think all these need to be translated into a specific diet about what foods, what items, and what quantity need to be consumed. So, anybody else would like to add anything to what Dr. Medhavi has just told us?
Two things which I think to add is heat, a lot, is and nuts. So giving a lot of calories, giving some fat and addition to whatever it is. And there is some food.
I think let's finish from the panel and we'll invite comments from the floor. Yeah.
A very important thing which we forget is that basically we patient have to do procedures. So they should be planned only in the morning of the procedure because which are fasting from the day they are distributed before starvation. And nighttime fasting night should be added. And I prefer prescribe my patient a bowl of boiled corn because it has sustained starch, which we can.
Yes, I think very good practical points. I think Dr. Ashish also emphasized that a late evening snack and the problem of nocturnal hypoglycemia in a cirrhotic liver with no glycogen reserves, prolonged fasting is very detrimental. So Abhinav's point that for procedures, don't keep them fasting too long. In a busy list, you have a set of patients with cirrhosis and portal hypertension posted, 8 guys waiting for EVL. The last fellow comes in at 3 p.m. after fasting for since 10 p.m. the previous night. So that is definitely got to be discouraged. You have to schedule your procedures in such a way that the fasting is the bare minimum required for the procedure, about 3 to 4 hours, and the late evening snack. So I think these are very practical points that the practicing hepatologists need to look at in regarding the caloric intake. So based on the NASL guidelines, also similar to the EASL guidelines, the energy, the protein, and the mineral requirements were emphasized. And I think this was again discussed in the earlier talks. In this very severely malnourished person, we planned for 35 calories per kilogram per day with 1.5 grams per kilogram of protein and the recommended dietary allowances for the important minerals and vitamins. I think the addition of branch chain amino acids was emphasized by Ashish, and I think there are good evidence-based recommendations that branch chain amino acids should be included in the diet in these patients. So what we could calculate in this patient based on the previous recommendations was these numbers. This patient needed 2000, roughly 2000 calories, 84 grams of protein, 294 grams of carbohydrate, 50 grams of fat, and the kind of fat also has been adequately discussed with the recommended doses of vitamins. So with this, eventually, the high protein diet that we could calculate a specific diet split into frequent meals. The requirement for frequent meals has been again mentioned here. Actually, this was when she was in the ward, and she spent a bit of time in the ICU. So these feeds were advised at that time. Now, once you prescribe the diet, I think Dr. Charu also emphasized in her talk that monitoring the intake is really crucial. Now, these are inpatients, admitted patients. Procedures are a problem. They are anorexic because they have a distended abdomen, they have tense ascites. To control that, a degree of salt restriction, though not extreme salt restriction, has to be observed. So, how do you practice monitoring the caloric intake in your patients, Dr. Medhavi? And is there an objective way to do that? There would be problems in intake. How does one overcome those problems? Maybe you could address this issue.
Calorie intake, the first thing which comes is the 24-hour diet recall, which will be by what patient says that they have had in their previous day. And it has to be a consecutive 3 days diet recall, which we see, and then the every amount of calories and everything is calculated how much they are consuming, and then they are planned according to the required amount of calories and proteins to be given to the patient.
So do that as a daily basis practice in your patients when they are in the hospital.
It is a daily basis practice so that we know the nutritional, actually how much of amount, because this is the calculated amount of diet which is going to the patient, and then how much the amount of diet patient has consumed, and accordingly we can then plan better for the next day how we can manage the other things which has been planned.
What are the usual problems which see you set a target? This is the target that they have to consume. Often they are not meeting the target. They are underachieving due to problems, some of which I have alluded to, and the others. So how would you circumvent this?
Initially, like I mentioned, that the consistency of food is always a important thing. That what kind of consistency of food is, and we have to obviously set up on supplementation also, because unless you are not supplementing the proteins and the calories through commercial nutrition, you are unable to achieve those targets as much as we want, which is actually not possible by just the kitchen feeds or the dietary plan.
Right. So we would look at the targets they meet, and if they are not meeting them, then use nutritional supplements, but in a monitored way. Anything else that people would like to add?
Compliance is always an issue for the patient because collectivity and because of the disease process. These patients, along with the relatives, we should be doing nutritional education. We should teach them the importance of nutrition so that they will take and the it is said and done.
Absolutely.
Out of 100 patients, around 65
Could
in a controlled setting where the patient was for fiber digestion, the fellow, and regular visits, weekly call.
encouraged, motivated. So this was 65% inpatient or outpatient? Outpatient.
It's not easy as it appears there. They maintain the food diet and recall level, and they in fact sending pictures of what they were eating.
Exactly.
In spite of that, in a controlled setting, we not able to.
So what was your take on dietary supplements? So then how often did you have to take recourse on a regular basis to dietary supplements?
Home-based food.
Okay.
We know how to make supplements. But
Right.
here, there is a role of supplements. Not if they're not able to clarify.
Right. Anything else? Okay, so please, Avina. Right. So yes, juggling. You want to give them protein, but not too much sodium. So how about you make sure that they get their protein, and if they retain the fluid, use a touch more of diuretics? What do you think? You'll have to do that juggling because there are limits. You allow them certain amount. But with the supplements, are you crossing the recommended 5 gram salt that most of us advise our patients? Even with ascites, even on diuretics, there must be at least a 5 gram salt intake to maintain palatability. So do you actually cross that with dietary supplements? Somebody's used them?
We look into cross. This is what we do. And if you try to stick too much of salt, then they will not be.
It is counterproductive. I would more favor using a slightly liberalize the salt, and if there is significant bothersome fluid retention, then try and manage it pharmacologically. Right. Okay, so I think this is some of the what Dr. Medhavi was just referring to. We drew up a chart, and every day we would have our patient or their relatives fill up exactly what they are consuming. This was in the inpatient. We encourage them to do this at home as well. Not every patient, but many of them would do that, and on their visits or periodically to the dietitian. So this is the initiative of our dietitians here, and they have been able to do this. So for every single day, the patient who's in the ward is filling up, and at the end of the day, they are calculating the protein, carbohydrate, and fat intake, and seeing how targets could be met. So this patient had been listed for a diseased donor liver transplant because there was no living donor. It took almost a year of waiting before she got an organ, and she had 3 admissions from between November 21 for complications, and when she got transplanted in January 2023, admissions for ascites, infection, etc. And I had underwent a transplant. I'd just like to show you this graph which our dietitians worked on and figured out. Here what it shows is the percentage compliance for intake of energy and protein for this patient, and this is 100%. So after the first admission, once he had got attuned to keeping a diet chart and started taking diet, we could see that at home her intake actually on some days of the or some durations actually crossed the 100% mark. She could eat more. Each time she was admitted, in the 3 admissions, their nutrition actually drastically dropped even to below 50%, 35, 40% of the recommended intake, because one gets admitted because one is sick. There are problems, and the sick people do not eat. Plus, we had the other problems that you already alluded to of tense distension, frequent taps, investigations, and so on. And thereafter, once patient had been stabilized and went home again, she was able, pale bars are the energy and these are the protein, dark bars are the protein, go up to around 100% of her intake for various periods. Finally, after liver transplant, I'll just show you the numbers. Now, currently, she is maintaining, again, she hasn't gained too much weight, but she's been maintaining on her recommended dietary intakes. And this is in a recent visit. This was when she was admitted with us in May when we did a detailed workup, number that I've shown earlier. By March 2023, we could see that there was gain in weight and she's completely dry now. BMI had improved. The tricep skin fold thickness, the mid upper arm circumference, and the mid arm circumference had improved, although they still have not crossed the malnutrition cutoffs of 22 and 23 centimeters. So I guess this is one patient who was compliant with keeping records, so we could analyze and show them for this presentation. But such our patients are an exception. Secondly, I would point out that there was time for the improvement in nutrition to show a result. She had to wait for her organ for close to a year, and while there were dips in between, but for the greater part of the year, she could actually come close to a recommended intake. Yet, despite 100% of the recommended diet allowance being met, she did not cross the threshold of malnutrition. So again, I'd ask the panelists, I mean, what is their experience? They have seen many such patients and those who have undergone transplants as well. Does the sarcopenia, the frailty, the malnutrition, to what extent do they find recovery happening after transplant when the liver is normalized? Sunil, you would have seen many of these.
The data is there from the it's shown that at 6 months it might be somewhat normal. And once it is beyond 1 to 2 years,
Then they start improving, and then they tip over into overnutrition, obesity, NAFLD related issues. So it is the nutrition role doesn't really stop. Well, I would like to thank the panelists very much and the audience, and particularly our patient and our dietitians who have been quite meticulous in making sure that the intake is advised and monitoring it. And in fact, at times we felt because the nutrition is not improving, whether we could actually go up beyond the recommended allowances to increase their nutritional intake, because over a fairly prolonged period of 1 year and fairly normal intervals, we really could not achieve come close to correcting the malnutrition. So obviously we need to do better, and maybe even the guidelines need to do a bit better. Well, with that, I'll close this and I'll thank you very much and hand over to them.
I think they should strictly go to that. They don't require any other.
And the dietitian and the hepatologist have to be on the same page and closely interacting, because there are still different perceptions. I think that was the idea of this. We have the data, we have the tools. Dr. Serene was at pains to point out that our tools are still primitive. They are not the best of tools. Great. But we have something, and if we try to use them together and first get your patient to buy into the concept that a major part of his treatment is not medications, not drugs, not procedures, but plain simple diet and nutrition, I think we can make a huge difference to the outcomes in our cirrhotic patients. On that note, I'd like to draw this session to an end, and thank you all.
Thank you, sir. Now we'll move on to the next session, which will be the States of Art lecture. For this, I would like to invite respected Sir Dr. Shyam Sundar Sharma, sir, Senior Professor from SMS Medical College, Jaipur, and Dr. Vivek Saraswat, sir, Professor and Head of Department of Hepatology, Mahatma Gandhi, Jaipur.
But we know now from multiple studies that body composition extends really beyond muscle mass, and there's other measures associated with the worst prognosis, including myosteatosis, lower subcutaneous adipose tissue, higher visceral fat or visceral adipose tissue index, and we're including Thank you for the opportunity to present today. It's my absolute pleasure to be presenting at this meeting, and I wish I was there in person with everyone, but hopefully can join you soon at another meeting. So I've been asked to speak about sarcopenia and frailty and whether management is effective in improving outcomes. No relevant disclosures. This is some of my research funding. And I want to start just by grounding us again. 101, frailty and sarcopenia are driven by various etiologic factors, which we'll touch on in a moment. But these are manifestations of muscle dysfunction or impaired muscle health that then lead to adverse clinical outcomes. When we're talking about frailty, it's a geriatric construct that's generally thought of as global frailty in the geriatrics world. So it's this decreased state of physiological reserve and increased vulnerability to health stressors. In individuals with cirrhosis, we've mainly studied the physical components. So that's physical function, muscle contractile dysfunction. And it occurs in up to 43% of patients. If we think of it in a figure conceptually, functional capacity on the y-axis, a person with, let's say, a stressor or a variceal bleed coming in, they're physically robust to start with. They go down in their function, come back up right to baseline recovery. Whereas a frail person over here comes in with a variceal bleed, goes down in their function, goes into the zone of dependence, disability, and death. The most commonly validated tool in the literature, although there are many for cirrhosis, is the Liver Frailty Index, composed of grip strength, chair stands, and balance testing. When we're looking at sarcopenia, that's loss of muscle mass. It occurs in up to 70% of patients with cirrhosis, more in men, more in decompensated disease. Cross-sectional imaging is the gold standard. You've got muscle in red here. There's, as you know, a lot of heterogeneity in the choice of what measures we use and what cutoffs we use. Most commonly, I would say, is the skeletal muscle index at the third lumbar vertebrae. But we know now from multiple studies that body composition extends really beyond muscle mass, and there's other measures associated with a worse prognosis, including myosteatosis, lower subcutaneous adipose tissue index, higher visceral fat or visceral adipose tissue index, and worse muscle quality. So looking at high radiodensity of your subcutaneous or your visceral fat. The pathogenesis of both sarcopenia and frailty are multifaceted. So when we're looking at sarcopenia, we're thinking this imbalance between muscle mass, protein synthesis and protein breakdown or proteolysis. So factors such as bacterial translocation, alcohol, and other pathogens, reductions in dietary intake, reductions in glycogen stores, reductions in physical activity time, increases in ammonia, and reductions in testosterone. And when we look at these, there are significant gaps. So let's just look at a couple of them. Protein. This is North American patients. These are our patients on our liver transplant waiting list, 630 of them. We looked at their protein intake. Only a quarter were actually meeting their protein needs according to target. Of the remaining, the 26% who were eating less than 0.8 grams per kilogram per day, that was an independent predictor of death, so independent of liver disease severity, age, etc., potentially modifiable. We know that those intake targets are even less likely to be met in inpatients. This was, again, work from our site and replicated in a couple of other studies. 137 patients at day 3 of a hospitalization, target calories met in 7%, target protein in 20%. Another study kind of looking at how much are people eating when they're coming in, how much of their plate are they eating. Less than half are eating all of the food on their plate. Now, wow, just want to show you how, yeah, for sure there's challenges with the inpatients who are on the wards, but let's look at those who are in the ICU. What happens to their muscle mass?
This is a landmark study by Puducherry, 2013. Doesn't involve cirrhosis patients specifically, but has relevance. So this is 63 ICU patients, mean age of 55. Over 10 days, these guys are losing cross-sectional area of their rectus femoris, or their thigh muscle, of about 20% over 10 days. The study was beautiful in that they not only did ultrasound, but they also did muscle biopsy. And so you can see here that this is the measures of muscle wasting. Look at the loss in their fiber, muscle fiber cross-sectional area, and even more when they looked at the level of the ratio of the protein to the DNA. So DNA is not going to change, but your protein loss in that muscle was substantial. And then, of course, the muscle morphology itself microscopically changed as well. And relevant to our patients, those people with multi-organ failure, which many of our acute and chronic individuals have, even more than 20% reductions in cross-sectional area. As mentioned, patients with cirrhosis have amongst the lowest activity levels of individuals with chronic disease. 76% of their monitored waking time is sedentary. And it would be really interesting to get this kind of data in an Indian cohort as well. As a result of all of those gaps and deficits, our patients are what I would really like us to start to think about are geriatric. Okay, this is a study, a systematic review rather, of 7 studies that we performed looking at over 1,100 patients, all of these patients on the liver transplant waiting list. When we got them on exercise bikes in each of those centers, peak baseline VO2 of 17.4 mils per kg per minute. So if you're an exercise physiologist, that means that your patient is just able to function and do their daily activities, but they're quite tired and need breaks in between. And so not surprisingly then, although they had a mean biological age of 55, their mean physiological age was 85. So remember that. These are geriatric individuals. As we're trying to change this, and do frailty and sarcopenia improve with nutrition and exercise? Think about the people that we're also trying to change here. 30 years older than their age. One slide on, because I'm sure this is going to be covered in other lectures, these are really relevant for mortality. And just to summarize, they increase mortality by about 2-fold. So this is looking at data in frailty. Over 1,000 patients, if you were frail on this liver frailty index, hazard ratio of death increased by almost 2-fold. Sarcopenia, if you're in this meta-analysis, 7,000 adults, if you're sarcopenic, again, about a 2-fold increased risk of death. Myosteatosis, that fat infiltration, 678 adults, about a 1.4 to 2-fold increased risk of death. So it's associated with death on the transplant wait list. It's associated with morbidity on the transplant wait list. What about post-transplant? And I'm going to pick frailty here because the sarcopenia studies are a bit challenged by the fact that not all patients have the sarcopenia CT scan done in a systematic way, standardized timing post-transplant. It's usually just people who have had a scan done and, oh, let's look at their results. So where this is different, and this is a standardized assessment post-transplant and pre-transplant for frailty. So over 1,000 liver transplant recipients, they had the liver frailty index. What did they find? Again, that 2-fold increased risk of death. If you're frail beforehand, 2-fold increased risk of death after transplant. But also increases in length of stay, increases in ICU time, increases in the people who didn't actually go home. They went to another facility to recover or to a long-term care facility, for example. Okay, so with all of that, prevalence is high, sarcopenia and frailty is bad, increases death rates by about 2-fold, increases morbidity, has an impact on post-transplant outcomes. There's lots of gaps that we can address. Can the management of these things improve outcomes? And I would say for certain outcomes, actually, we do have really quite good and evolving data, and much of it is coming from India, which is great. So can we improve things? Yeah, we can improve nutrition status, we can improve muscle status, we can improve reduce hospitalizations, and we can improve patient-reported outcomes. So let's go through a few of those studies. Number one, landmark trial, flank study looking at the late evening snack. 103 patients, isocaloric intervention, 710 kilocalories given either in the daytime or in the evening, improved muscle mass by over 2 kilograms over the 1 year period. Total body protein change went up regardless if you were Child-Pugh A, B, or C. Second study from India looking at a randomized controlled trial design of nutrition education with a dietitian, monthly reinforcement versus standard of care. 120 patients, they were sick, MALD of 17, going to guideline-based targets for protein calories. What did they find? Reversal of minimal hepatic encephalopathy in 71% versus 23%. We know muscle is a secondary site of ammonia detoxification, but also improvements in quality of life, muscle mass and strength, and significant reductions in hospitalizations. Another beautiful study from India by Dr. Taneja's group, 100 patients, 60% alcohol, mean MELD, again quite sick, 19, 88% male, a third of them Child-Pugh C. Again, this intervention of usual care versus usual care plus a dietitian-led counseling intervention. And that was weekly visits for 4 weeks and then monthly visits. Significant improvements in protein intake. Really nice study because they actually looked at objective metrics like the liver frailty index and the skeletal muscle index, the two gold standards, and found significant improvements in both of those, albeit that the skeletal muscle index was evaluated in a smaller subgroup of patients, and it just showed significant results in the males, although there was very few females to study. Moreover, the intervention group had fewer hospitalizations. They've put in their supplementary materials, I love these kind of meal plans that can perhaps even be replicated at your centers as well, if that's valuable. What about the inpatients? I'm going to show you this study from Bajaj's group saying if we go in, do nutrition education for the nurses on the unit, teach them about nutrition assessment, what happens? Good things happen. We have in these patients more dietitian consultation after the intervention. More patients are getting meal supplements like Ensure or Boost. Length of stay goes down, 90-day readmissions go down. What about the rest of the kind of inpatient data? And a lot of it is summarized with this systematic review. And I will say some challenges with the review in that it really mixes together a bunch of different studies, including those with just branched-chain amino acids alongside parenteral, enteral nutrition. But regardless, this is the most recent review of a mix of nutrition support studies. Most of them are poor quality, 52 studies, really no impact in this systematic review on mortality, but some benefit on certain outcomes like infections, for example. Of one of the better studies in here, this is a randomized control trial in gastroenterology published in 2016, the Moreno study looking at individuals with severe alcohol-associated hepatitis. What did they do? They gave an intervention for 14 days of enteral nutrition, and then they said, what's their outcome going to be 6 months? Do they die more or survive more? And there was no real difference when they compared the two groups. Importantly, I think this study in particular points out how difficult it is to do these studies in these very sick patients. Half of them were unable to tolerate the two. The authors did say, although the study was negative, the authors did say that nutrition is still important because having less than 21.5 kilocalories per kilogram per day of calories predicted mortality as one of the factors. Where are we going with these nutraceuticals or supplements? And I think growing data for these. HMB, this is an interesting study from Manuela Murley's group. HMB is a leucine metabolite. It stimulates protein synthesis and activates mTOR pathway, reducing muscle breakdown. 27 patients, 90% Child-Pugh A. They looked at 3 grams per day in addition to counseling and nutrition and activity. And they measured a few things. I'm just going to show you the liver frailty index. It was measured within group, not between groups, so comparing the placebo and the intervention group. But you can see that within the HMB group, there was an improvement over time in frailty. But when you look at this randomization, it was very small numbers. There was significantly more people in the placebo group who were less frail. Okay, so this may have some challenges with interpretation, but I do think, again, some promising results. What about exercise? Does exercise have benefits as well? And I'm going to show you our first randomized control trial. It was the first randomized control trial in the area. And I want to bring this up because it brings up this concept of this aging and this geriatrics again. These were 19 patients who were randomized, majority of them child QA, 8 weeks of getting these people on a bike to exercise 3 times a week. They went from looking like 80-year-olds to looking like 67-year-olds, okay? More than a decade younger in that time. Multiple others have done exercise studies since then. Randomized control trials were summarized in an American Journal review in 2022. Most of the sample sizes were pretty small. Most of the patients were child QA. Most of them were done supervised, so in the facility, and adherence really ranged from 14 to 100%. Peak VO2 increased, 6-minute walk test distance increased in many of these studies, quality of life improved, muscle mass improved, and reductions in portal pressure occurred. So definitely seeing some benefits. Obviously, we don't have any mortality data in this population with this intervention. I think really importantly to try and think about this idea of multimodal interventions. And my recent obsession in the last few years has been digital technology and how do we use it to scale these kinds of interventions. And so this is an app that we've created looking at protein counting and having exercise videos. And we trialed this out in 18 patients. They got nutrition support with group sessions with a dietitian as well as one-to-one check-ins with a dietitian. And they were asked to do exercise videos 3 times a week, and they got check-ins from an exercise specialist as well. And I show you this because although it wasn't an RCT, we did measure the liver frailty index. And this is one of the first exercise studies to do that. And what we found is that there was a significant change in the LFI. You can see some people actually going from frail to robust or frail to pre-frail. We did notice there was a lot of interruptions. These people are sick, and they do often need to take breaks in these study protocols, and a reasonable number of either dropouts or people who got transplanted, one person who got bad hepatic encephalopathy and couldn't continue. So again, I think exercise as well has significant improvements that we can see in these studies. So that's the patients kind of waiting for transplant. What about in the post-transplant period? And again, I'm going to focus here on frailty because it's easier to measure systematically over time. The sarcopenia studies, again, use scans that aren't necessarily standardized as far as timing. So for post-transplant frailty, I think we need to remember that there's certain things like aging, like poor comorbidities like diabetes that continue to progress potentially post-transplant, and that contribute to things like frailty, as well as sarcopenia. And then there's things that are modifiable, but that we often don't address as well as we need to. Things like that sedentary time or low activity levels or low protein intake. And as well, the fact that we're giving them medications that can cause myotoxicity, such as mTOR inhibitors, as well as tacrolimus-based inhibitors. So this was data from Jen Lai's group looking at that large cohort of patients. Pre-transplant, 29% were frail. Post-transplant, that increased at 3 months. By 12 months, still only 30% were actually robust. And again, I point out to you, we may not be giving them exercise, nutrition. We're also giving them medications. So again, when we're looking at thinking about improvements in post-transplant frailty, we do need to think about the overall context of the support that's provided to these patients as well. So Can the management of sarcopenia and frailty improve outcomes? I hope that I've shown you that in these certain areas, I think it can. I want to show you next that I think there's many gaps and opportunities that remain. And with India kind of leading the way in a lot of this research, I'm super excited to see what's produced next. So, tip of the iceberg is where we're at. We've been studying some about calories and protein. I don't think we understand yet much about nutritional requirements, truly, timing and length of these interventions, optimal nutrient mixes, and really more evaluation is needed in these multimodal, getting together nutrition and exercise interventions in this population. Let me show you a bit of a vision and the fact that I think we need to start thinking of these interventions across the liver transplant continuum if we're hoping to actually improve care in these patients. So in the waitlist period, for example, for nutrition, we know this from guidelines, calories, we need to meet them, protein, we need to meet it, timing, the late evening snack that I showed you. But we also then need to support these patients in the perioperative period. And here we're looking at things like ERAS, which stands for Enhanced Recovery After Surgery. So immediately before surgery, looking at patients who don't have risk for delayed gastric emptying, thinking about carb loading, that thinking about a shorter preoperative fasting period, that improves outcomes. Immediately post-operatively thinking about how fast can we feed these patients, as long as there's no contraindications, of course, looking at the parenteral route if the enteral is contraindicated. Longer term, still thinking about supporting these patients in their sarcopenia and frailty journey, so supporting energy and protein. And here we're looking at supporting body composition. Many of them become obese, and we want to reduce the gain in fat mass, increase muscle mass and function. Exercise across that continuum. We need to continue to support the patients. And we need to think about this idea of whole person care. Again, reminding you that many of these patients are truly geriatric. We're going to get better bang for our buck. We're looking at optimizing other things as well, like cognition, depression, reducing polypharmacy, reducing alcohol, overall managing their medical comorbidities, and really involving as much as we can social supports and community. Okay, so this is a comprehensive support of our patients to really, can we shift outcomes? Yes, we can, if we're giving them support across each of the key periods. And I would say there's other key periods as well that I haven't pointed out in that figure, and this is really beautifully laid out. Nutrition and critical care hepatology, just recently again from India, looking at the importance of nutrition in the ICU, and that it's not hammering in protein and calories, but rather it's dependent upon where they're at in their stay, and acutely or just kind of gradually increasing their daily protein intake, especially those who are on, for example, high-dose vasopressors. Where else do I think we can use as an opportunity? Sarcopenia, really relevant as far as outcomes. Tougher to measure if we're doing CT scans, although I think that may get easier with time. But this area of bedside measures is evolving. So things like ultrasound, this is thigh ultrasound, DEXA for the upper limb, which isn't as affected by fluid shifts. And then BIA phase angle, which is a measure of cellular integrity. And all of these studies, these have predicted mortality. There's another interesting measure, and we've been gathering some information on this, that's calf circumference, which can be corrected for BMI because you need to correct for some of that fat that can be there in the calf. And that seems to be a really good surrogate for a true sarcopenia measurement based on cross-sectional imaging. There's even some fancier tools that are coming out rather than even just thinking about muscle mass by CT, or as I talked about, fat quality and fat mass. Some groups are even doing 3D segmentation of the various organs, and this is all automated. So one would just put the scan in the system and it would spit out what's happening to your lungs, your kidneys, your heart, your liver, all of the different muscles, put that all together, ideally for an individualized plan. So this is a group called Bora and I Health, which is interesting. Where else is the future going, and where else do we currently have a gap? we think we may know how much we need to tell people to eat, but I think the research that several groups have done, including our own, show that we are missing the mark when we're using predicted estimates. And so this is a study that we published in JHAP last year, looking at 900 patients with cirrhosis and 282 controls. And this was data gathered from various different studies, but looking at measuring resting energy expenditure, either that was directly measured, so a metabolic heart, versus indirectly measured, predicted by prediction equations. And there was really different results, all the way from minus 500 to plus 500 kilocalories, suggesting we really, in the sicker patients especially, need to measure this directly. And there are tools that are getting better and better for measuring this. I think we need to learn from the oncology literature a little bit more around risk stratifying individuals. And I think this will help us to say we can't give every single patient as intensive support, but can we risk stratify them by, for example, the PGSGA, which is a patient-generated subjective global assessment. I love this tool, it has 4 components to it, which are really relevant. And then depending upon those results, maybe they don't need as much support. They can get just handouts. Maybe they need a bit more support meeting with a dietitian, or maybe they need really that intensive specialist care. So thinking of designing our studies this way as well. I talk about this a lot, think about this a lot, is these are lifestyle changes, and we need to recognize that for long-term sustained change, behavior change is hard. And I think this was really demonstrated in this one study, a large study of exercise that we have so far, 83 patients. They got them to do 12 weeks of home-based exercise. 14% of them adhered, and not surprisingly, there was no change in the liver frailty index. We wrote a bit of an editorial on that, looking at we need to really deliberately focus on adherence. So my learnings over the last few years doing some of these in this focus on adherence is involve, when you're planning studies, when you're doing any kind of interventions in the clinics, involve people with living with the condition, involve feedback from them. Learn how to kind of speak to patients to invoke change. And that's concepts of motivational interviewing. I've done a 6-month course, but there are weekend courses available. And when you're researching, if you are researching this area, think about looking at behavior change frameworks. So why do some people improve and some people don't? Why do some people adhere and some people don't? And this can really help us to understand that. We need to become champions of nutrition and exercise. Our word as clinicians is really, really important to our patients. So I give everybody education material because that makes them know that I care about these topics. I talk to them like it's a prescription for their health, their nutrition and their exercise prescription. Cirrhosiscare.ca, there is some translations now in Hindi as well, and so you can use that information there if that's helpful for you. We're going to learn, I think, a lot more around pharmacological therapy, so that's currently a bit of a gap, and in particular, perhaps ammonia-lowering therapies have some benefit, and there's several reasons why ammonia is myotoxic to the liver. So we have some, we don't, but others have done some preclinical studies looking at rifaximin combined with LOLA, as well as rifaximin and L-carnitine that have shown some positive results. There's many more learnings, I think, to come around nutraceuticals, including various agents that are in various phases of study. And I think very importantly, it's clear that we need to not just think about one thing. There's many factors that are going to play into sarcopenia and frailty. Ideally, in the longer run, we're going to have a way to be able to say, for you, you need this nutrition, for you, you need this exercise, oh, you need both nutrition and exercise, you need this, you need that, ideally individualizing, personalizing based on risk factors. We're not close to that yet. And in the meantime, I think what we understand is probably multimodal, so hitting different aspects are best. This is a study that I'm quite excited about that we're doing using our digital platform in our pre-transplant patients. And we're going to be starting that in the next few months, but looking again at nutrition, exercise, and behavior change all in one intervention. So in conclusion, Chairman, ladies and gentlemen, I hope that I've covered for you today that frailty and sarcopenia are really relevant predictors of poor outcomes, that nutrition and exercise and potentially some pharmacological therapies are in the pipeline. And the question that you posed me, can the management of sarcopenia and frailty improve outcomes? Again, I hope that I've convinced you, and a lot of the data coming out of India, nutrition status, muscle status, hospitalizations, patient-reported outcomes, I think we can say yes, that we can improve those things. I hope that I've also shown you that there is a lot of room for more high-quality research, and there's a lot of gaps right now. What should be given, how much should be given, how long should it be given, and who should it be given, and who is kind of not going to necessarily have a response, and what kind of degree of benefit can be expected. I really hope that together we can learn the answers to these questions in the future. I'd like to acknowledge my research team members and all the students and also my family for all their understanding of the time I spend on this. So thank you so much. And again, really, really looking forward to meeting many of you in person soon. Take care. Thank you for the opportunity to present today. It's my absolute pleasure to be presenting at this meeting, and I wish.
Since this talk was recorded, we give thanks to Dr. Saraswat for arranging this excellent, practical, very informative talk on sarcopenia in management of chronic liver disease and its importance in complications post-transplant management. So, any questions, Dr. Saraswat? If you will be, I think, answering this.
Thank you, Dr. Sharma. I think I requested Dr. Punita to tell us, but I thought I was a skeptic in this issue, whether if you're saying you're doing changes in sarcopenia and frailty so that outcomes will improve. So does it really happen? And at least the off the cuff, my impression was that it is probably doesn't really happen. We are trying, but we haven't got there. Well, we've got some clarity from Dr. Purita on this issue that yes, it can be done, but it is very difficult. So I guess our impression that it doesn't happen is possibly because we are not trying hard enough, and because we are not trying hard enough, so our patients are not trying hard enough, and so we are not seeing the outcomes. But that if you do it systematically, nutrition, exercise according to a plan, along with, I thought the new input we had today was behavioral modification therapy. Modify first the physician's behavior. I guess so that's why we need to get motivational courses, and then we can motivate our patients to modify their behavior, and then it will achieve results. So I guess the light at the end of the tunnel is still a distance away, that everybody or the majority achieve a result is still far away, but we are now finding the route and moving in that it is a doable goal is what I think. And I think much of the information we heard today was relatively novel information, which has accrued in the last couple of years. So this is very much an evolving field, and I think in absentia, I will take this opportunity to thank. I'll do so later in person, Dr. Punita, for all the effort she has put in for this novel talk. With that, I think we can close the session and hand over to the announcers. Thank you.
Thank you, honorary chairpersons and the speaker, for the very engaging and educative session. To begin our next session, Special Situations in Chronic Liver Disease, let us please invite to the dais our esteemed chairpersons for this session, Dr. Pankaj Puri, Sir, Director of Hepatology and Medical Gastroenterology, Fortis Escort, Liver and Digestive Disease Institute, New Delhi, Dr. Anjan Kalia, Ma'am, Professor in the Department of Internal Medicine, Mahatma Gandhi Medical College, Jaipur, Dr. Kanika Verma, Ma'am, Professor, Department of Home Sciences, Maharani's College, University of Rajasthan, and Dr. Sushil Jain, Sir, Senior Consultant in the Department of Medical Gastroenterology, Indus Group of Hospitals, Jaipur. All right. I'll be handing it over to you now, sir. Thank you.
Good afternoon, everybody. Without wasting any time, we'll go to the next session. The next talk will be by Dr. Akash Shukla, and he'll be speaking on dietary management in alcohol-related hepatitis. Dr. Akash is professor and HOD of medical gastroenterology at St. GS Medical College and KEM Hospital, Mumbai. And I think there's a little change. Sorry, I'm just reading what is there. His areas of interest include vascular liver diseases and liver transplantation. And everybody knows Akash, and I think he will correct what's here.
Good evening, everybody. At the outset, I must thank Professor Saraswat sir and organizing team for having me here. I'll be talking about nutrition specifically in alcoholic liver disease in the next 15 minutes or so. So why are we talking about alcohol and nutrition when alcohol itself has got a nutritious value? If you look at whiskey, around 100 ml of whiskey has 252 calories. Wine is the least, it's 28 and 38.5, white and red. And the other ones are having their own caloric value. So this basically means that if you're drinking alcohol, you should be gaining weight, you should be getting obese. And those who are heavy drinker should actually be overweight and obese. But why doesn't it happen? The epidemiological studies are somewhat contradictory. Way back, more than 120 years ago, Benedict and Atwater demonstrated using direct calorimetry that healthy non-alcoholic volunteers, when they took alcohol, it was utilized as efficiently as fat or carbohydrates as a source of energy. No difference. In normal volunteers, a progressive substitution of carbohydrates with ethanol in an otherwise balanced normal diet results in a decrease in body weight. So why does this happen? If somebody adds 90 grams of alcohol to daily diet, it increases the daily energy expenditure by 7%. And if you have additional alcohol to 50% of the calories, then the lipid oxidation in the body actually is inhibited, especially in the hepatocytes. The average energy intake from alcoholic beverages can account to up to 1000 kilocalories per day. And in this study, it was added to the daily non-alcoholic energy intake, and they demonstrated that there was no development of obesity. So what is happening? The results of these studies suggest that either alcohol bears a negative effect on the energy yield, implying that ethanol is not efficiently metabolized, or the consumption of alcohol alters dietary intake, absorption, and metabolism of other nutrients, subsequently leading to a negative or at least diminished energy yield, or a combination of the two. So let's see, do we really waste energy when we metabolize alcohol? We are all familiar with this metabolism of alcohol by the alcohol dehydrogenase. The key thing to note here is that NAD gets converted to NADH, and in the subsequent step as well, from acetaldehyde to acetyl coenzyme A, NADH is produced. Now we are all aware that NADH is the energy-rich substrate, and you expect it to produce a lot of calories. The problem is the ADH ethanol oxidation happens in the cytoplasm, and the NADH cannot pass the mitochondrial membrane. It is mainly metabolized, therefore, through the reduction of pyruvate to lactate and oxaloacetate to malate, and which is then used for production of energy by the mitochondria, and therefore there is some loss of efficiency there. The acetaldehyde which is produced, which is metabolized further by the acetaldehyde dehydrogenase, unfortunately the mitochondrial ALDH2, which is the main metabolizer, is not there in the hepatocytes. And therefore, once this gets saturated, you do get a lot of wasting of the NADH, and it is not utilized in the TCA cycle the way you expect it to. The acetate which finally gets produced enters the circulation and is metabolized to CO2 in the TCA cycle in the tissues which have the enzyme. So instead of utilizing it in the hepatocytes, it gets utilized in the tissues. Which are the tissues? Heart and the skeletal muscle. And that is why your liver is not really protected. The energy is not really efficiently produced in the hepatocytes as you expect it to. The other thing which you have to remember is the MEOS pathway. Now, the MEOS pathway is something which is different from the alcohol dehydrogenase pathway. It has got a high Michaelis constant, and therefore its activity increases when alcohol is consumed regularly, chronically. The difference is here, instead of NADH, it is NADPH, which gets converted to NADP. And over a period of time, somebody is consuming alcohol, NADP increases, NADH reduces, and therefore, although you expect this also to produce equal amount of energy, what happens is your NADH is capable of producing 16 ATPs, whereas in the first step itself, here you are wasting 3 ATPs. So the total amount of ATP production actually comes down. So what happens to the acetate? The acetate itself is associated with loss of energy. 80% of the acetate, which is derived from the ethanol metabolism, is actually found in the hepatic veins. So it doesn't get metabolized in the liver, reaches the systemic circulation. And those who are fasting and take 50 grams of alcohol, their blood acid levels will rise 90 minutes later, and it can go up to 900 to 950 millimoles. This acetate is very poorly taken up by the muscles. Only 3% of all will be utilized by the muscles. So it will keep on circulating, and therefore it is not utilized to produce energy the way you expect it to be. Also, the enhanced energy which is required for the lipogenesis from this lactate almost accounts for the 25% of the energy content of alcohol. So 25% of the energy is utilized for this purpose. And therefore, despite taking alcohol, despite having a large calorie intake, these patients are not able to actually utilize these calories for their purpose. We are all aware of the empty calories, and that's why I'm not spending much time on that. We are all aware there's not much of nutrition, as we saw in the first slide itself, except for the highest amount of protein present in alcohol is actually in the red wine, which is 0.6 grams in 100 ml of red wine, which is like negligible. So the other thing which happens is, what are the other mechanisms by which malnutrition develops in alcohol-related liver disease? Of course, you have various mechanisms causing reduced appetite. You have several mechanisms which are responsible for dysfunction of the intestine, and absorption is affected. And there are mechanisms which impair the energy metabolism and increase the losses. Another thing which happens typically is, which we have observed in clinical practice, is when the patients come to you, they've been drinking alcohol, they get admitted. Once they get admitted, in the next 1 week or 2 weeks, they have stopped alcohol, you're trying to feed them, they actually start losing a lot of weight. They very rapidly lose muscle mass in the hospital under the supervision. Why does this happen? This happens because they were getting a significant amount of calories, although poorly utilized, but they're still getting them from the alcohol. Once they're admitted, those calories are not given to the patient. They only get the calories that we are giving them, and very often this is very poor. And that is what leads to this rapid downward nutrition spiral which can happen in these patients. Especially if they go into alcohol withdrawal, they are restrained, very often they're kept nil by mouth, and that is when they will lose this very quickly. What is the impact of alcohol on specific nutrients? So on carbohydrate, in acute alcohol intake, if the patient has sufficient glycogen stores, then you will get hyperglycemia. If the patient has glycogen depleted in the liver, the patient will get hypoglycemia. With chronic alcohol intake, you get hyperlactatemia, and you get a delayed paradoxical hypoglycemic state. Of course, we all know for proteins, there will be a lot of muscle wasting and myopathy, as discussed by Dr. Punita in the previous talk. With lipids, we know that there is accumulation of triglycerides in the hepatocytes, which then leads to fibrosis, also can give rise to steatohepatitis and cirrhosis. We can also get deficiencies of thiamine because of reduced absorption. Same way for folic acid as well. For vitamin A, the alcohol actually inhibits the cleavage of beta carotene, and therefore you get very rapid vitamin A deficiency in these patients. Same way, vitamin C, zinc, and magnesium are the ones which can be directly absorption is inhibited. Coming to sarcopenia, we should spend some time on this. You can have, in patients with alcoholic liver disease, three mechanisms by which sarcopenia can happen. The usual hepatic factors, which have been discussed before, the non-hepatic factors, which have been discussed before, and in addition, you have alcohol-related direct effects on the muscles which can cause sarcopenia. What are these? It is changes in the redox ratio, alcohol-induced skeletal muscle mitochondrial dysfunction, protein adducts, which increase the muscle autophagy, and impairment of muscle protein synthesis. Now, most of the methods which have been described so far for assessment of malnutrition in cirrhosis have been validated in alcoholic liver disease, as you can see here, and almost all of them can be used in patients with alcoholic liver disease. So I'll not spend much time here because it is exactly what we have been discussing throughout the day today. So all these methods are validated in alcoholic liver disease as well. So coming to specific therapy. So let's start with what do we do in patients with alcoholic cirrhosis. The general principles, the overall provision is 30 to 35 kilocalories per kg of dry body weight. The 50 to 60% of these calories should come from carbohydrates. 25 to 30% should come from proteins, which should be 1 to 1.5 gram per kg body weight, and fats should comprise around 15 to 20%. Avoid unnecessary dietary restrictions, and low sodium diet should be recommended only if ascites or edema is present. Frequent small meals, including nighttime snacks, and screen for the deficiency of zinc, calcium, vitamin A, D, E, K, and supplement them if required. Enteral nutrition is to be preferred over parenteral nutrition whenever feasible. Intravenous glucose should be administered if the fasting period is more than 4 hours according to some, more than 12 hours according to some. But I think 4 hours is a very reasonable period. If you're going to keep the patient fasting for more than 4 hours, it is better to supplement these patients because of the state of accelerated fasting. The BCAA supplementation should be performed in ALD patients with hepatic encephalopathy, and folate should be properly supplemented in these patients with alcoholic liver disease, although there are inconclusive results regarding the final therapeutic effect of its final product, and that is acid-inosylmethionine. So there is no data to support routine supplementation with acid-inosylmethionine in patients with alcoholic liver disease. What about alcoholic hepatitis? So in patients with alcoholic hepatitis, the nutritional assessment has to be very aggressive. Also, we have to be aggressive in replacement of electrolytes because there is a risk of refeeding syndrome much more in patients with severe alcoholic hepatitis than in patients with alcoholic cirrhosis. The water and electrolyte intake has to be according to individual needs, renal function, and diuretic sensitivity. The total energy goal is 1 to 1.4 into resting energy expenditure, which can vary from 25 to 40 kilocalories per kg per body weight per day. And if you look at the initial studies in 1991 and 92, they said that those patients who were on 35 to 40 kilocalories per day, they perform better than those who are on 25 to 30. Protein should form 1.2 to 2 grams per kg per day, and fat should form 30 to 40% of non-protein energy. Replace vitamins and minerals as indicated. More importantly, avoid excessive iron, copper, vitamin A, and also manganese. We have to remember is something which can precipitate hepatic encephalopathy, and we should avoid multivitamin tablets or protein supplements which have manganese. If you read carefully the labels of the commercial products that are available, many of them actually have a large amount of manganese. And that is something which we should avoid in our patients with cirrhosis as well as patients with alcoholic hepatitis. Those who are obese and BMI is more than 35, for them we need to give hypocaloric, high protein diets. So their protein intake should be the same 1.2 to 2 grams, but the total calorie intake has to be lower. And of course, small frequent snacks and late night snack, which has been discussed very often. Now, when we replenish and give supplements, There are certain supplements which should be given only if there's a deficiency, like the zinc, iron, copper. These should be given only if there is a deficiency. Vitamin A, if you give them empirically and you get an overdose, then that can actually cause worsening of the liver function or hepatic encephalopathy. And therefore, the others, which water-soluble vitamins can be probably given more freely, but these minerals and fat-soluble vitamins have to be given only if there is a deficiency. We must identify those patients who are at risk of refeeding syndrome, extremely high risk if the BMI is less than 14, or if there is negligible intake of food for more than 15 days. There's nice criteria for defining high-risk patients. The BMI is less than 16, unintentional weight loss more than 15% over last 6 months, little or no nutrition intake for more than 10 days, or low potassium, phosphate, or magnesium before feeding. Or 2 or more of the following: BMI less than 18.5, weight loss unintentional more than 10% over last 6 months, little or no nutrition intake for more than 5 days, and history of alcohol abuse or use of the following drugs: insulin, chemotherapy, diuretics, or antacids with magnesium or aluminum in the last 4 weeks. Coming to the most controversial topic, fats in alcoholic liver disease. It is recommended that they should comprise 30 to 35% of total calories and should have sufficient amount of essential fatty acids. We all know the benefits of polyunsaturated fatty acids. They have several mechanisms of helping with the fat, lower blood triglyceride level, increase adiponectin, promote lipid degradation, inhibit the accumulation of lipids, and reduce lipid peroxidation, reduce oxidative stress. But these basically prevent the alcohol-induced fatty liver and steatohepatitis. They are not useful once you have established severe alcoholic hepatitis or alcoholic cirrhosis. Now let's see what is the role of saturated fats. That is probably the more controversial, because very often the moment our patients are diagnosed with cirrhosis or alcoholic hepatitis, we tell them not to have saturated fats. And in fact, very often no fats at all, but definitely not saturated fats. But what is the logic of using or giving saturated fats to patients with alcoholic liver disease? Lactobacilli basically thrive on saturated fats. And use of lactobacilli is shown to improve gut lactobacilli level and therefore decrease the progression of alcoholic liver disease. Low levels of microbial long-chain saturated fats caused due to alcohol compromise the growth of lactobacillus, and that is what is one of the mechanisms for disruption of the gut barrier integrity. There's a very good study, multi-center, prospective study, which showed that intake of saturated fats is associated with lower mortality as compared to unsaturated fats in patients with alcoholic liver diseases. The mechanism has been demonstrated to be through improvement in the intestinal tight junction expression and elevation of intestinal inflammation caused because of alcohol in animal models. Alcohol-induced disruption in the intestinal tight junction protein levels, enterotoxemia, and lipopolysaccharides were found to be elevated by these saturated fats. So what is the best source of this saturated fat? Desi ghee. So in animal models, it has been shown to improve liver histological changes despite continued intragastric ethanol administration. And therefore, administration of saturated fats like desi ghee is actually logical in patients with alcoholic liver disease, as most of them would be malnourished. They are concentrated source of energy, they make the food palatable, and therefore attainment of high calorie diet is actually possible. And therefore, we must consider it as a promising modality in the medical armamentarium. Coming to the last part, what is our recent understanding of the pathways in pathogenesis of sarcopenia and ALD? So while Dr. Tandon talked about hyperammonemia and the myostatin pathway, the AMP kinase pathway, which increases the autophagy, alcohol directly through the MT-ROS and the mTOR pathway not only inhibits the autophagy, increases the autophagy, but also inhibits the protein synthesis. And this gives rise to novel targets like myostatin antagonists, mTORC1 activators, muscle-targeted antioxidants, autophagy regulators, mitoprotective agents, and cell-permeable TCA cycle intermediates, and specific amino acid and analog supplementation. So to summarize, my dear friends, we have several screening tools which are applicable to general cirrhotics, which are also validated for patients with alcoholic liver disease. While the requirement for acute alcoholic hepatitis is higher, 35 to 40 kilocalories per day, and the recommended protein intake is 1.5 to 2 grams per kg. For cirrhosis, it is slightly lower, 25 to 35, with protein intake of 1.2 to 1.5 grams. However, in decompensated, the requirement can be as high as 1.5 to 2 grams. We must optimize the nutritional intake, regular eating pattern, frequent meals, bedtime snack, and good protein supplements. But beware of the refeeding syndrome, and we have to be very aggressive in preventing and managing this refeeding. Oral thiamine forms the backbone, liberal supplementation of vitamin D, but for other minerals as well as fat-soluble vitamins, do it only if it is deficient. No unnecessary food restrictions should be done. There is an important role of unsaturated fats in the early stages, especially for prevention, and there is an emerging role of saturated fats in severe disease. The risk of refeeding syndrome has to be identified, and we have to preempt and proactively prevent it. The identification of newer molecular pathways has given rise to potential targets for the future, like the myostatin antagonists and mTORC1 activators. Thank you very much for the patient hearing.
Thank you, Dr. Akash. That's wonderful. We'll hold on to the questions to the end. And may I now request the next speaker? The next speaker is a close friend of mine, Dr. Bhaskar Nandi. He's professor and head clinical and transplant hepatology at Amrita Institute of Medical Sciences in Faridabad. Dr. Bhaskar will be speaking on dietary management in hepatic encephalopathy, types of proteins, when to restrict, and the role of BC branch chain amino acids. Dr. Bhaskar, please.
Thank you, Pankaj, for the kind introduction. Good evening to all of you. A sincere thanks to Professor Saraswat and the organizing team for giving us this opportunity to come to this wonderful institution. Thank you very much, sir. The topic assigned to me is dietary management in hepatic encephalopathy, and with the special focus will be on types of protein. Is there any need to restrict protein in hepatic encephalopathy, and what could be the place of branch chain amino acids in the dietary management of hepatic encephalopathy? Before I start my talk, going to the topic, I'll just like to emphasize on two important facts which we are all already aware of. One is, this is a very familiar diagram that how do we generate ammonia in the body. It has got three main mechanisms. One is, of course, from the dietary nitrogen components. The second is from the deamination of glutamine by glutaminase in the gut. And finally, by the metabolism of nitrogenous substances by the gut bacteria. And of course, the total amount of ammonia is modulated by the skeletal muscles and the kidneys. What I like to highlight over here is the debate as to what is the actual contribution of dietary protein to the ammonia pool in the body. And in fact, today I think the evidence is very much there that most maximum contribution of ammonia to the whole body is through the endogenous breakdown of the proteins, the protein turnover. It is the deamination of glutamine by the glutaminase. They contribute more towards the ammonia pool rather than what you are taking, the dietary protein, the amount of dietary protein you are taking. And the second fact, this is the ammonia trafficking. It's a very simplified cartoon. One is in health, when the liver is normal, as we can see that whatever ammonia is generated is metabolized in the liver and goes into the urea, and this is how it is eliminated. But now if we come to the other diagrams, one in which there is a well-nourished cirrhotic patient and in the other is a malnourished cirrhotic patient. In the well-nourished cirrhotic patient, whatever ammonia which is not being metabolized in the liver because of the liver disease, the muscles take over that role. So the amount actually crossing the blood-brain barrier is much less. But now, if you look at malnourished cirrhosis, and in fact, most of the cirrhotics are malnourished, as we have heard repeatedly today, even this muscle component, that safety is also removed. So the most of the ammonia which is there generated is actually at risk of crossing over to the cerebral circulation and having an effect on the astrocytes and the neural cells over there. The second fact which we all know is the malnutrition. It has been covered very well today in cirrhotic malnutrition and cirrhotics, and there are many reasons for this. And we also know that protein calorie malnutrition is, though it's common and it is an adverse factor for clinical outcome and survival, the cirrhotics require more protein, 1.2 to 1.2 at least, to achieve a positive nitrogen balance. Having said this, this entire talk for the next 10 minutes or so is actually a debate that is there any role for dietary protein restriction and does it help in hepatic encephalopathy? The problem is you have a good debate if you have got a good evidence with you, solid data, good trials. And here we run into the problems if we try to discuss the issue of protein and hepatic encephalopathy. Because when I reviewed the literature, what I find is all uncontrolled studies, small studies, and in fact, most of it is from observational and clinical experiences that we have rather than any randomized controlled trials. So what is very clear on one side is that dietary protein contributes towards the ammonia pool. And there is one small RCT which I have quoted here, though this was not the intention of this RCT, but it did show that as you go on increasing the quantity of protein, it precipitates or aggravates hepatic encephalopathy. And of course, from time immemorial, protein restriction has been advised. And to be fair to them, what they have said is protein restriction for a transient short periods. Nobody is talking about depriving the cirrhotic for a long duration from the proteins, but only during, let's say, the first initial days when you're having a hepatic encephalopathy. Whereas if you go to the other side of the fence, the contribution of dietary proteins is suspect, and we know that the endogenous protein metabolism, the breakdown, is more important as a source of ammonia, and there is no really hard proof that restriction of content of protein in the diet has any beneficial effect on HE. And in fact, proteins in hepatic encephalopathy is something like, how lactulose came into our clinical practice. Lactulose, the use of lactulose, if you actually go looking for hard data, there are hardly any trials or randomized good quality studies. It is more based on your experience and down the ages what has been passed. And in fact, what I could feel is after reviewing the literature that this is one RCT by Cordoba which has actually changed all our recommendations. When I joined my residency in early 2000 in gastroenterology, I remember our chief dietitian at All India Institute, Dr. Namrata, she always used to give us some pink colored solution for hepatic encephalopathy. And it was very common seen in our AV2 ward that all in the coma room and the hepatic encephalopathy patients, all of them have got some inverted pink colored solutions going down to their Ryle's tube. So they were those pure carbohydrate solutions, I gather, and they contained zero protein. So we started off from there. And if you look back at the most widely read book worldwide on liver disease, as late as these later editions, Sheila Sherlock was very clear that during symptoms, all dietary protein is stopped during hepatic encephalopathy. Zero proteins. And as you are recovering, you go on increasing it in increments of 20 grams till you reach your target. And of course, since there were lack of good studies in this, there were studies, but very small and controlled. So a lot of it was based on authority, the opinion of the authorities on this. I'm just showing you two opinions, Roger William Group and of course Kevin Mullen. Both of them are stalwarts in hepatic encephalopathy. And I just highlighted, and both of them agreed that there should be restriction of proteins, especially at the beginning stages of hepatic encephalopathy. What changed after some time is this. Let's see what do the guidelines say. This guideline says that daily energy intake should be so and so, daily protein intake should be 1.2 to 1.5. And in fact, this guideline doesn't mention anything about protein restriction in the initial stage of a hepatic encephalopathy. If you look at the guidelines by the International Society for Hepatic Encephalopathy and Nitrogen Metabolism Consensus, I think they are also very clear that we are not restricting proteins on this. So the question is, what has, and this is the latest guideline from ESPN, and that is clearly said in its recommendation that protein intake should not be restricted in cirrhotic patients with hepatic encephalopathy, as it increases protein catabolism, and which actually in the long run and in the short run is more deleterious than that. And in fact, this is worth reading. I'll read it aloud. A very select subgroup of cirrhotic patients termed protein intolerant develop encephalopathy on normal protein intake. These were the uncontrolled trials. But this seems to be a historical phenomenon, as such patients are rarely encountered nowadays. So they are very categorical about it, and they are putting the only RCT which has changed the prescription patterns, that protein restriction should not be there. Well, this is the study which I think this change in opinion has come not because of too many hard studies, but I think with the passage of time and our clinical experience and this one particular RCT, which has actually made a lot of difference in our protein recommendations. It's a very elegantly designed study in which patients were divided into two groups, low protein diet and high protein diet. There were patients of hepatic encephalopathy. In the low protein, they received zero protein from day 1 to 3. And then in aliquots of 12, 24, 48, it was increased gradually till they reached a target of 1.2. The total duration of therapy was 14 days. And in the high protein group, right from day 1, there was no restrictions in the protein. And as per the recommendations, about 1.2 grams per kg per day protein was given from day 1 to 14. And this gram per kg is based on the ideal body weight. This study had taken ideal body weight for calculation. Objective was twofold. One is to see the protein turnover between low protein diet group and the high protein diet group. And of course, what's the outcome in hepatic encephalopathy? Now, if we look at the protein metabolism, it was very clear that protein breakdown at 2 was much higher in the low protein diet group. So there was more breakdown, and today we know that this is the one which actually generates more ammonia, and it has got more adverse effect on the outcome of hepatic encephalopathy. There was a statistically significant difference between the two groups when the protein was restricted initially. Later on, by day 14, when the low protein group also had caught up with the normal protein, this difference had vanished. And as far as outcome of hepatic encephalopathy was concerned, there was no statistical difference between the two groups. So it actually didn't matter whether you were giving a low protein or zero protein in the initial days, or if you are giving full protein in the initial days, that there was a difference in the outcome of hepatic encephalopathy. There were several limitations of this study, but I think it gave a very important message to all us clinicians that protein restriction in hepatic encephalopathy, it doesn't pay you dividends, it doesn't help you as we used to think in the last 2 decades. Now the question is, we have discussed about amount. Is there any difference in the type of proteins that we give? Well, again, we fall into the problem of having very small studies and really no big trials on this. But I think if I just show you the end result of all these small studies is that dietary proteins, milk-based proteins are much better tolerated than animal proteins. And similarly, vegetable-based proteins are much better tolerated. Now, if we look at the vegetable versus animal protein, this has been already discussed here, and vegetable proteins have been recommended, especially in hepatic encephalopathy, to meet our protein requirement. But what I want to highlight is that today we know that it is not the difference in the ratios or in the quantities of the different types of amino acids, aromatic, branched chain, and all that, which makes vegetable protein a bit better than animal. I think vegetable protein is much better. It is because of the fiber content. And the fiber has its own effect on how it expels nitrogenous waste products and how it controls the nitrogenous producing bacteria over there. So I think it's the fiber content in the vegetable protein which is actually doing the wonders over here. Now, these I've just collated about 6-7 studies. They are all small, and sorry for the small font. but most of them, I think the largest study has got about 10 patients. And of course, there are other studies which show about 4 patients on 6 patients. So small sample size is a big limitation. Variable dietary complexes. So actually the studies are very heterogeneous. The duration is variable, conflicting conclusions. But I think at the end of the day, this review had shown us that vegetable protein is better than animal protein. And if we have to cover up the protein requirement in hepatic enceph or in a cirrhotic, it is better to substitute, give vegetable protein rather than animal protein. If we look to the branch chain amino acids, they are the building blocks, these amino acids, especially for building of the muscles. And we all know that later in the years of a cirrhotic, in a malnourished cirrhotic, when the liver is failing, it's actually the muscle which takes over the functions of the liver. And so it's very important for us that to not only maintain nutrition but also a good physical rehabilitation of our cirrhotic patients so that the muscle mass is maintained, because in later years when the liver fails, this is the muscle which takes over. So the main job in this is done by the BCAA. These are certain studies of which these are the 6 randomized studies which are taking place on branch chain amino acids in hepatic encephalopathy. And results, though not very exceptionally well, but they all suggest that branch chain amino acids are a good alternative of filling up our protein requirement in a cirrhotic. I'll just highlight on 2 of them. One is, this is the largest one, and it had about it's a meta-analysis, 760 participants, 15 trials. There is a beneficial effect on hepatic encephalopathy, but the rider is that this benefit of BCAA had come when you have removed the trials which had used neomycin and lactulose. So if you are already using neomycin and lactulose, the addition of branch chain amino acids didn't make any difference in the outcome of hepatic encephalopathy. The problem with the BCAA is its tolerability, because it's very unpalatable and very difficult to tolerate. This is the other double-blind randomized controlled trial. It had shown a significant reduction in combined event rates, and combined event rates included death, and decompensation. Average hospital admission rates were much lower in the BCCA arm, and the nutritional parameters and LFT, they all improved. There was reduction in CTP, and this study was all in this Italian BCA study group was in favor of use of branch chain amino acids as compared to protein, and of course also maltodextrin. So what's the current perspective? To cut it short, I think this editorial from Dr. Y.K. Joshi way back in 2003 had clearly mentioned that evidence suggests that protein intake plays only a limited role in precipitating encephalopathy. In fact, the more you restrict it, the more is the breakdown of the endogenous protein, and the more deleterious effects and more of ammonia production. So it is very important to keep up our protein intake even during the hepatic enceph period, and of course in the long run for any cirrhotic. These are the current management suggested algorithm. Even these algorithms show that there is no reduction in the protein. And if you want to substitute, instead of animal protein, better to give vegetable or milk-based proteins. Use of branch chain amino acids, definitely when the patient is protein intolerant, it is much better to substitute it with branch chain amino acids to meet your protein requirement. So finally, what will be the conclusion? That I think today we do not restrict protein in hepatic encephalopathy. And if you are not able to meet in a very refractory hepatic enceph where you feel one, we are losing on the total protein being given, or if there is still a doubt that if I reduce the protein, the dietary protein, will it help in reducing ammonia? I think it is better to substitute it with branch chain amino acids and complete our quota of proteins to be given. Because remember, endogenous breakdown of protein is far more important than your dietary protein. There is no conclusive evidence for restriction of protein in hepatic enceph. And of course, this point I have brought out, neither there is a conclusive evidence that transient restriction of proteins in non-responsive HE is deleterious. Suppose I reduce, I'm not talking of zero protein for 2 to 3 days. I think further studies are required on this, whether this move is beneficial or not. Type of protein, we have already discussed, BCA and milk-based proteins are beneficial. And my last point is, I think we have a task force on CLD and nutrition and all that. But I think what we require is something more bedside. I have my doubts on how do we prepare the protein meals that we are giving. I think in most centers, is it the formula feed? We take the pre-packaged formulas and how much of branch chain it contains, how much of other amino acid contains. I think it's not very clear from the ingredient data that is written on the on the boxes of this. So something, a guideline or a beyond guideline to tell us how to prepare the protein feeds and what are the available commercial formulations, or is kitchen feed better than the formulary feeds? I think some sort of a guideline or a task force on these aspects should be instituted. Thank you very much. This is our hospital. We are 6 months old, doing well, and this is our wonderful gastroenterology team. Thank you for a patient here.
Thank you so much. We'll have the questions at the end.
It's my very proud privilege to invite the next speaker, Dr. Namita Bhandari, who also happens to be my student. And as Dr. Bhaskar just said, that there is definitely need to work, work together of dietitians, of nutritionists, and the doctors. So Dr. Namita Bhandari is a consultant nutritionist in Jodhpur, and her PhD work is on nutrition in liver cirrhosis patients, and she has seen the effect of branch chain amino acids. So over to Namita.
Thank you, ma'am. Good afternoon, everyone. I know it's being very boring to be listening to me right now at this hour. Post-lunch sessions are usually very boring. But I think you'll all bear with me. And it's my very, very, very esteemed privilege to be standing here and being introduced by my guide, my mentor. So let's start with how to choose between dietary supplements. I think since morning, we are listening to this, that what are the nutrients of importance in CLD. So we have calorie, protein, fats, carbohydrates, our macros, then branch chain amino acids. Like in the last lecture, we had gone through the importance of branch chain amino acids. So these are the recommendations. These are from ESPIN 2020 guidelines. Then sodium, another important nutrient that has to be taken care of for patients, especially the decompensated patients. The sodium, this is the recommendation. And this is about the sodium restriction. In the previous lecture, we had some insight about that we don't need a very strict sodium restriction for these patients because it affects the dietary intake. As it is, the appetite is very low, and then unnecessary imposed sodium restrictions make the diets all the more unpalatable. So this is just in some references that I thought would be useful. Fluid restriction. So in case of severe hyponatremia, where serum sodium levels are below 130 millimole per day, there we require fluid restrictions. Micronutrients, zinc, selenium. So all this, I think you all have listened enough about it. So why do actually liver patients need some supplements? Firstly, malnutrition. Protein energy malnutrition is a very, very common feature that we find in patients with CLD. They are obviously nutrient deficient also. And protein calorie malnutrition often correlates with other symptoms of disease. Then malabsorption because of accelerated intestinal transit, bacterial overgrowth, pancreatic insufficiency, use of lactulose, alcohol in case of ALD, the villi is damaged, so that can lead to malabsorption, vomiting, anorexia, and nausea. Poor oral intake because of the symptoms like varices, ascites, already existing anorexia, early satiety, delayed gastric emptying, and the risk of being progressing to encephalopathy. Sarcopenia, there are dietary requirements that are increased and the need of specific nutrients like branch chain amino acids or arginine, glutamine, anything of that sort. There is this study from 2020 which showed that the patients with chronic liver disease, after discharge, when they adhere to an oral nutritional supplementation, the ascites, muscle strength improved and the ascites decreased. So there is a positive correlation because obviously these supplements are able to provide some nutritional benefits in addition to the already existing home-based diet that these patients are taking. Why do we need supplementation? This is quite an old review, though. This is from Hepatology 1994, where this has summarized that there is a definite positive effect of oral nutritional supplementations in patients with CLD. So what do we look into a formula or a supplement before we decide to use it for a patient? So they have to be higher density or hypertonic solutions, providing approximately 1.2 to 1.5 kilocalories per ml, because as it is, there is fluid restrictions and increased requirements. Protein from the formula has to be 11 to 15%, 57 to 77% of carbohydrates, 12 to 28% of fat. The sources are as listed here. So we need, in fat, we need a combination of MCT and polyunsaturated fatty acids, because MCTs will not provide all the essential fatty acids. So we need to supplement them a little bit with the polyunsaturated fatty acids, and we need to add MCT because of fat malabsorption that might exist. Sodium, the requirement is the limit of a formula has to be 80 to 120 millimole per day. Specialized nutrients, osmolality, another factor, because gut related issues are very common in these patients. They're already suffering from malabsorption, and if we happen to give a solution which is of high osmolality, that can lead to increased gut permeability and symptoms like diarrhea. And definitely the cost of the supplement for the patient. So we in the previous lecture we just had a word about the source of protein, that whether it has to be casein or whey protein. So these are some studies that I have just added to this, that whether a casein supplement is better or a whey protein supplement is better. Though in the upcoming slides we'll be seeing that most of the supplements, the hepatic supplements that we are getting in the market, are basically based on whey protein supplements. So whey protein basically contains the branch chain amino acids, the 3 branch chain amino acids, and casein, if we choose to give casein or vegetable protein, then we'll have to supplement those branch chain amino acids. So what are the supplements that are available in the market? This is just a comparative study of the hepatic supplements that are available in the market right now. Most of the commonly used are only Resource Hepatic, that is from Nestle, contains casein, and I have also listed the branch chain amino acid content for all of them. For HEPA-Pro, they were not available to me, the osmolality and branch chain amino acids. So most of these solutions, most of these supplements are hypercaloric, they are hypertonic solutions. They provide, most of them are providing branch chain amino acids, most of them have sodium within the limits, the recommended limits. So, and most of them are based on whey protein concentrate. They have their base as whey protein concentrate. And these are the 6 that are being commonly used: Resource Hepatic, Pentasure Hepatic, Frezubin, HEPA, HEPA-Pro, and Essential Hepatic 1.75, and Celevida Live. So these are the basic 6 supplements that we are commonly using. Apart from this, we are also using certain high protein supplements which are not specifically designed for liver patients. So Pentasure 2.0, these are definitely hypertonic. Most of them are hypertonic, but they are mostly isocaloric also, because they are giving more of protein. They are emphasizing on giving more of protein. So giving just protein is enough is one question. And secondly, can we use these just high protein supplements which are not specifically designed for liver patients? Can we use them in daily practice for liver patients? However, the cost for most of them is the same, whether they are hepatic or they are high protein supplements. The cost is more or less the same. So these are some of them. Ensure Plus Peptide. This Ensure Plus Peptide is just a peptide formula, so that we get the protein in the elemental form, the pre-digested form. Rest all have this whey protein, and some are the mixture of whey protein and casein. Now there are some add-ons. This is one product, this is one new product which I came across. This is from Myelin. This is basically peptidase. These are enzotenes. We are giving protein, but do we actually know that how much of this protein is being digested in already malabsorptive gut? So what they have done is they have added the enzyme to the supplement itself. So this is peptidase by the name of peptidase. because we know that protein digestion is often impaired in critically ill patients. So apart from the composition of the protein, in spite of being having a good composition of a protein, do actually that protein is being absorbed in the gut. So they have just added an enzyme which facilitates the absorption of this protein. So this is 100% whey isolate and the protease enzyme which is required for protein digestion, with the added advantage of a low phosphorus and potassium content. This facilitates fluid restriction because this can be reconstituted in small amounts of water. So maybe if we are giving a hepatic supplement, we can often add this kind of a substance on which aids in the digestion and absorption of that protein. So that is the cost of the this. Apart from this, this is proteinase 98, which has this enzotin, that is the protein, the amino acids and the enzyme and the protein powder. So this is basically a complete meal replacement therapy. So the patients who are on enteral feeds cannot ingest too much quantity of food orally, though in liver diseases nowadays we are working on having simple home based foods with minimal restrictions. So in these cases where they are enterally fed or have a lower intake of food, we can use something like this, some product like this also. This is the composition of the product. I hope it's visible and readable. Apart from that, we have Newsam from Sun Pharma, which is S-adenosine and methionine. It's a natural physiological molecule. SAM is a natural physiological molecule. It is useful in the synthesis of various hormones such as adrenaline, noradrenaline, and serotonin. It is the precursor of antioxidant glutathione. Now, hepatocellular concentration, as we know that liver is the major metabolic factory of the body. So hepatocellular concentrations can affect pathophysiological processes such as oxidative stress, mitochondrial functions, hepatocellular apoptosis, and malignant transformation. The synthesis of SAM itself is decreased in patients with chronic liver disease. So studies indicate that this could, though there are studies which indicate that this could exacerbate the liver injury. So there is no firm data on the use of these kinds of this product. Now, how to choose? We have a lot of things available. How to choose? Firstly, oral nutrition supplementation for chronic liver disease patients is definitely required. Most of the specifically designed formulae that we have in the market usually fit in the criteria of a good hepatic supplement. And supplements enriched with branched chain amino acids, there is a controversy also that whether branched chain amino acids help or not, but definitely they'll help to improve the protein status of the patient because all the three branched chain amino acids are basically essential amino acids. So they've shown to improve muscle mass and lean body mass. My PhD was also on this, so we got a very good result with branched chain amino acid supplementation. Electrolytes mostly provide, most of the supplements are providing sodium within the recommended range of 2.6 to 4.9 grams per day. And like in the previous session, there was a lecture whether the supplements add on to the sodium content of the diet. Usually they are not adding on that. Fluid, most of them are hypertonic solutions. So they can be used, they are fluid restricted solutions, so they can be used. Or most of these supplements contain medium chain triglycerides, fructooligosaccharides, and inulin for promoting gut health and absorption, and to be making them easily digestible. Osmolality is in the standard range. They are all below 950 milliosmoles, so they are in the standard range. Cost, they are similarly priced, but we have to assess before prescribing whether what cost it is adding to the already existing cost of the treatment that the patient is undergoing. So we rely mostly on the need, the availability of the supplement in your city, and the affordability of the patient. Thank you.
Thank you so much, Namita. Actually, supplements for the liver patients are a must. The next speaker,
We are running late,
so the next speaker is Dr. Neeraj Sarra. He is the Director of Hepatology, Medanta Medicity, Gurgaon. He has interest in portal hypertension and MT, and he has over 150 publications to his.
Thank you, chairpersons, and I'd like to thank Professor Saraswat and Dr. Dadich for inviting me here for this meeting. In the next few minutes, I'll be talking on hepatic osteodystrophy, diagnosis and management. So, bone health is compromised in chronic liver disease. So, I think nutrition in general is neglected by most physicians. And within nutrition, I think bone health is probably the most neglected part, clearly. And when I was reading about it, I realized that I'm probably guilty of, not looking at bone health as seriously as I should. So, bone health is compromised in chronic liver disease. It warrants timely identification and therapy, and it negatively affects quality of life. In the past, bone disease in patients with chronic liver disease was described using the term hepatic osteodystrophy, and that's my topic today. However, I think this term has sort of become a little dated now, and this hepatic osteodystrophy actually includes osteomalacia, which is caused by impaired bone mineralization, which is rare and has been reported only in isolated patients in advanced PBC. So currently the most frequently diagnosed bone diseases in patients with chronic liver disease are osteoporosis and osteopenia. So I think hepatic osteodystrophy is now more replaced with, just metabolic bone disease in liver or bone disease in liver, and this term is less often used. So the two major components of hepatic osteodystrophy are osteoporosis and osteopenia. So osteoporosis is defined as bone mineral density at the spine or proximal femur less than 2.5 standard deviations below the mean of a young adult population, expressed as a T-score on a DEXA scan. And osteopenia refers to those with a T-score between -1 and -2.5. So it's a lesser variant of osteoporosis or less severe than osteoporosis. What about prevalence? So prevalence of osteoporosis in patients with chronic liver disease depends on the patient selection and the diagnostic criteria, and about 1/3 of the patients of chronic liver disease have osteoporosis, and it probably has a higher prevalence in cholestatic liver disease like PSC and PBC. It has been seen that in patients who are undergoing liver transplant, the prevalence of osteoporosis is again at least about 30%, and in some studies even goes up to 60 to 70%. Now, what is the importance of osteoporosis? So why are we talking of osteoporosis? Because eventually it can lead to fractures. So fracture prevalence ranges from 7 to 35%, being more frequent in post-menopausal than young women and males, and in patients undergoing on corticosteroid therapy. So more fractures in post-menopausal women and in those on corticosteroid therapy. Now, there is some studies which show that eventually up to 2/3 of the patient with chronic liver disease sooner or later will have severe osteoporosis, and this is, I think the font is a little small. So there are various studies looking at different etiologies and the percentages of patient having osteoporosis. So it ranges from 35%, and there's some small studies in which it even goes up to 100%. But when I went through this, I realized that it's not just PBC and PSC which have high osteoporosis. Even viral-related cirrhosis, alcohol cirrhosis, have almost as high a prevalence of osteoporosis as cholestatic liver disease. And what are the risk factors for hepatic osteodystrophy in chronic liver disease? So there's basically a disbalance in osteoclast and osteoblast function, and that can happen with age. There's imbalance, or there's a change in hormonal status. So this happens in post-menopausal status, hypogonadism due to altered hypothalamic pituitary thyroid function. It also depends on the severity of liver disease. So it's more common in end-stage liver disease, and cirrhosis rather than hepatitis or fibrosis. Vitamin D and calcium metabolism play a role in risk factors, and disturbed enterohepatic circulation, impaired hepatic hydroxylation, increased urinary excretion of these minerals can cause decreased calcium and vitamin D, again leading to osteoporosis. And there is direct effect on osteoblast and indirect by altering the PTH, vitamin D, testosterone, IGF-1 cytokines, and cortisol. These are all affected by alcohol. So alcohol again is a risk factor for osteoporosis. So if we look at clinical risk factors, so higher age, hyperthyroidism, hyperparathyroidism, chronic liver disease, diabetes, these are all risk factors. Glucocorticoids, especially in the setting of cholestatic liver disease or autoimmune liver disease, and again in post-transplant patients, is a risk factor for osteoporosis and osteopenia. Nutritional factors, low body weight, low BMI, low calcium intake, poor nutrition are again risk factors for hepatic osteodystrophy. Now, this is a study from PGI in which they showed that frailty again was a risk factor for bone disease in patients with liver disease. So they saw that the fail group had significantly higher bone disease as compared to the non-fail group. So again, frailty being a risk factor for hepatic osteodystrophy. Now, why does this occur? Why is there bone disease in patients with liver disease? So it's basically an imbalance between osteoblasts, that is bone formation, and osteoclasts, which is bone resorption. So this homeostasis is disturbed, and there is increased osteoclast activity, decreased osteoblast activity, and the bone remodeling unit where all this is happening is there is an imbalance in liver disease. So chronic liver disease has a negative effect on osteoblast differentiation and proliferation, thus decreasing bone formation and leading to osteoporosis and osteopenia. Now, predominant changes in bone cell activity in various liver disease. So there's probably more resorption in viral hepatitis and in post-transplant and corticosteroid therapy patients, and there's probably decreased formation in cholestatic liver disease, Wilson's disease, and even in hemochromatosis. So it is thought that probably the high bilirubin in cholestatic liver disease has a negative effect on osteoblast, and that is why the prevalence of osteoporosis is more in patients with cholestatic liver disease. Again, just to sort of highlight the pathogenesis. So bone loss is due to decreased bone formation, mostly a direct or an indirect toxic effect on osteoblast differentiation and survival. So again, like I said, there's a disbalance between osteoblasts and osteoclasts. So there is decreased formation of osteoblasts because of decreased IGF-1, increased bilirubin, increased sclerostatin. There's various pathways, and the OPG, the rank L, and the rank. So rank L is receptor activated nuclear factor K beta ligand. So this is a very important pathway, and there are now being drugs being developed which are using which are anti rank L, and they act on this pathway to actually improve osteoporosis. So the pathogenesis is important because the drug development now is happening along these pathways to prevent or decrease osteoclastic activity. Gut liver bone axis again also probably plays a role in osteoporosis, and a leaky gut is likely to elevate the levels of osteoclastogenic cytokines and influence bone density. So how do we diagnose hepatic osteodystrophy? Well, you need to assess the risk factors. Patients with chronic liver disease, especially cirrhosis, screen for bone disease. If normal on evaluation, on the initial evaluation, perform a BMD every 2 to 3 years. Patients at risk for rapid bone loss, such as cholestatic liver disease, and with multiple risk factors for osteoporosis, surveillance should be probably done every year. And all liver transplant candidates must be screened for osteoporosis prior to transplantation. So according to WHO, bone densitometry of the lumbar spine and hip is the gold standard procedure for diagnosis of osteoporosis and osteopenia. Lateral x-rays of dorsal and lumbar spine should be performed to disclose vertebral fractures. Laboratory tests like calcium, vitamin D are also needed, along with probably a hemogram, a LFT, and thyroid function. And the presence of ascites in patients with cirrhosis may actually, affect the accuracy of the BMD in the spine. Ascites can cause fluid artifact in the soft tissue and can underestimate the real BMD value. So this assessment should be done in a patient with ascites, preferably after paracentesis. And when you do it after paracentesis, it has been seen that you get a higher BMD value as compared to if you do it without paracentesis. So I've already gone through the definition. What is important when we are diagnosing osteoporosis is that the bone should be free from other systemic problems, including osteomalacia, local abnormalities such as osteophytes, extraskeletal calcification, or deformities due to previous fractures. So if these are present, then you cannot really accurately diagnose osteoporosis or osteopenia. Osteoporosis, I've already said, is a t-score less than -2.5. Osteopenia is a t-score between -1 and -2.5. So vertebral fractures are associated with osteoporosis and osteopenia with a t-score lower than -1.5 in patients with PBC and PSC, and patients with a t-score between below -1.5 have a high risk for hip and vertebral fractures, thus supporting that the t-score may be a practical guide for starting specific therapy in these patients. Again, in diagnosis, there's something called a fracture risk assessment tool, the FRAC score. Again, this is a score which, there's a questionnaire and there are various parameters like the weight, height, previous fracture, use of glucocorticosteroids, rheumatoid arthritis, alcohol, secondary osteoporosis, and based on this, you get a score, and more than 4.2 has major osteoporosis and a higher risk of fracture as compared to a lesser score. So this is basically to assess the 10-year probability of a hip fracture in a patient with osteoporosis. Now, some special situations in which osteoporosis or osteopenia are important: metabolic bone disease in the liver transplant recipient. Studies estimate a post-transplant prevalence varying from 3 to 35% of fractures. There is accelerated bone loss after liver transplant due to high bone turnover, and over a period of 1 to 30 years, a much higher prevalence of its precursor osteopenia, which occurs in almost 1/3 of the patients as compared to osteoporosis. So it is important to assess for hepatic osteodystrophy or osteoporosis and osteopenia even after liver transplantation for early identification and adequate management, even though they may be asymptomatic. So why is there more bone disease in liver transplant recipients? So we've already discussed the risk factors prior to transplant, which are the etiology of liver disease, drugs, the severity of liver disease. What happens after post-transplant? Well, again, it's the liver transplant related factors like immunosuppressive drugs, glucocorticoids, calcineurin inhibitors, and some other factors probably like immobilization, poor oral intake, low testosterone, etc. So bone disease is significant in patients who have undergone a liver transplant as well. How do you evaluate bone health in a liver transplant recipient? It's very similar to a cirrhotic. So post-transplant labs should be done when the patient is stable 1 to 3 months after transplant. Calcium, phosphorus, vitamin D, and a DEXA scan. Categorize patients based on BMD, perform a FRAC score to assess fracture risk. And again, like in a cirrhotic patient, if the BMD score is greater than -1, normal bone health, follow up with a DEXA scan maybe every 2 to 3 years. BMD between -1 and -2.5. Osteopenia is probably there. Vitamin D supplementation should be done. Calcium should be supplemented, and yearly DEXA scan should be done for 5 years. And if a post-transplant patient has osteoporosis, if vitamin D deficient, then it should be corrected and probably treated with more definite agents, which I'll talk about in the next few slides. Another important area of bone disease is in patients of hepatitis B, especially those taking tenofovir. Loss of BMD is a major side effect of tenofovir difumarate. The relationship between bone disease and TDF has been seen in various studies and a lot of HIV studies actually, in which tenofovir is also used. And a recent a study by Gill et al. Showed that chronic hepatitis B patients treated with TDF had a significantly higher BMD loss as compared to the control group. The reduction in expression of an osteoclast-related gene that is involved in inducing osteoblastic activity would ultimately result in a loss of BMD, and this is reduced by tenofovir difumarate. So patients with TDF, we should be careful in looking at their BMD and look for osteopenia and osteoporosis. So what about management of hepatic osteodystrophy? So there are the primary recommendations are tackle and eliminate the modifiable risk factors. We've been hearing about a balanced diet. So there's really no change in diet. The kilocalories, high proteins, 40 to 50% carbs, 30% lipids, doubtful role of branched chain amino acids in bone health. Preventive measures are important. Home safety assessment, careful dose adjustment of antihypertensive agents, calcium and vitamin D supplementation, and corticosteroid and immunosuppressant agents should be reduced in patients with osteoporosis. I think one thing very important when we talk of management and especially prevention is avoid falls that may lead to fractures, as any surgery in these patients is extremely difficult and is high risk. And I think this is a common problem. As I speak, I have a patient admitted who is for transplant next week. She had a fall 2-3 days ago, had a vertebral fracture, and now we're trying to do kyphoplasty, and patient is in a lot of pain. So I think fall is very important, especially at home and even in hospital, and that's something we should be very careful about. In terms of treatment, vitamin D and calcium have a role in patients with osteopenia, osteoporosis, and post and perimenopausal women. Daily calcium intake should be about 1500 milligrams per day, and vitamin D supplements about 1000 IU per day of calcitriol may be advisable. Since calcitriol is the final active metabolite of vitamin D, it is probably better to treat the patients with this. Vitamin D levels should be measured annually in patients with advanced disease. Again, continuous use of vitamin D and compliance is an issue in patients who need long-term vitamin D. Now, this is a paper from Ames Group. Dr. Saraya is sitting here, published in the American Journal of Gastroenterology. So they looked at the effect of vitamin D supplementation on vitamin D level and BMD in patients with cirrhosis, and this was a randomized controlled trial, 164 patients. So what they saw was that there was significant increase in vitamin D levels in the intervention group after 1 year, and the vitamin D levels improved, but supplementation with vitamin D for 1 year improved the levels, but did not show any improve in BMD at lumbar spine and left hip neck in patients with cirrhosis. So it improves the level, but in this study they showed that it did not improve the fracture risk and the BMD. The other agents used in the management of osteoporosis, probably the most common, are the bisphosphonates. These are attached to bone surface and prevent osteoclast activation and bone resorption, that is called the anti-resorptive effect. Bisphosphonates are able to increase bone mass. They do cause esophagitis, and sometimes they can cause ulceration on the esophageal varices, and that is something we should be careful about in cirrhotic patients. Again, very small studies of bisphosphonates in liver disease patients. Compliance again is an issue with long-term oral bisphosphonates. Alendronate is probably the most commonly used, and zoledronic acid, which is IV preparation, can be used once in a year, and now there's data to show that this is probably a good agent to use. Hormonal treatment, not really a lot of data. Transdermal estrogen has been used. Again, very little data in liver patients, and limited studies. Selective estrogen receptor modulators, or SERMs. So raloxifene is such an agent which maintains anti-resorptive effect of estrogen on bone. And again, very few studies, a single pilot study examined its role in PBC, and they showed that a small but significant improvement in lumbar BMD was seen as compared to controls, and no difference in femoral BMD, and no data on fracture risk. So again, small studies, small numbers, so we really don't know how good they are. Other drugs, calcitonin, vitamin K, parathyroid hormone, not really a lot of data. What I want to talk about is denosumab. This is a human monoclonal IgG antibody that binds to the rank L pathway, which I talked about in the pathogenesis, and inhibits bone resorption. And this is a fully humanized monoclonal antibody to rank L pathway. The therapeutic effect of denosumab is based on its capability to inhibit osteoclast differentiation. So this is a drug which I think has future, and it is already being recommended by the American College of Endocrinology. And on the top right corner, I've just shown a study which was published in Hepatology in 2020, a pilot study of 10 patients, 6 PBC patients, 4 autoimmune hepatitis patients, and they showed a significant improvement in BMD using this drug. Another study of about 60 patients, a retrospective study, which showed that denosumab significantly improved BMD regardless of sex, patient age, and presence of liver cirrhosis. And no patients experienced fractures or moderate or severe adverse effects except for transient hypocalcemia. So I think this is a promising drug for moderate to severe hepatic osteodystrophy not responding to calcium, vitamin D, and bisphosphonates. So this is just a table to summarize what I've already said. Bisphosphonates, I think alendronate is probably the most commonly used. Hormonal therapy, teriparatide is something which is being used now, and this is a subcutaneous injection which is to be given daily. We have used it in some patients, but I really can't give you any data. Very few patients. And like I said, in other drugs, denosumab, I think, is upcoming liver safe, and probably has a promising role. So this last couple of slides, this is a management algorithm suggested by the EASL guidelines published in 2019. So evaluate BMD in cirrhotics in patients with cholestatic liver disease, long-term corticosteroid treatment, and before liver transplantation. DEXA scan at lumbar spine and hip. Lateral X-ray of dorsal and lumbar spine should be done. Laboratory measurement of to identify abnormal calcium and vitamin D metabolism should be done. If the T-score is greater than minus 1.5, that's normal. Repeat a DEXA scan in 2 to 3 years, and probably treat these patients with calcium and vitamin D. If there is osteopenia, repeat a DEXA scan in 1 to 2 years. Give calcium, vitamin D, and possibly bisphosphonates. And if there is osteoporosis, repeat a DEXA scan every year, and calcium, vitamin D, bisphosphonates, and possibly, if available, a newer agent can be tried. So these are the EASL guidelines. In ASL guidelines, again, similar, lateral vertebral X-ray, BMD should be done after So in ASL stresses on the need for paracentesis before doing a DEXA scan to assess BMD. Again, similar guidelines that it should be done in patients with cirrhosis and in patients with chronic cholestatic disease and in those receiving long-term corticosteroids and pre-transplant patients. And the monitoring with the DEXA scan is similar to that given by EASL. So to summarize, osteoporosis is a common complication of chronic liver disease. Pathogenesis of osteoporosis is mainly characterized by low bone formation, although increased bone resorption has also been seen. Severity of bone disease is related to increasing age as well as severity and duration of underlying liver disease. Risk factors for bone disease should be assessed, and modifiable risk factors can be tried to be removed. Diagnosis is by X-ray and DEXA scan. A healthy lifestyle measures good nutrition, adequate intake of calcium and vitamin D is recommended. No pharmacological therapy is completely effective. Oral and intravenous bisphosphonates increase bone mass and should be used. Reduction of fracture risk has not been adequately demonstrated by these drugs or by calcium or vitamin D in most studies. And the development of larger trials with bisphosphonates and evaluation of new drugs like dansumab for osteoporosis may change the future for these liver disease patients with bone disease. Thank you.
Thank you, Dr. Neeraj. I think with this we'll close the session.
Thank you.
Thank you. Thank you to all the esteemed chairpersons who have graced the dais today. Thank you and a heartfelt bow to the many learned speakers who have graced the stage with their elocutionary and educative talks. Respected dignitaries, let us now conclude our day one of midterm meet on nutrition and chronic liver disease with a final session of case discussion on nutritional management in the case of a post-liver transplantation patient now with pneumonia on ventilator. So let us please call to the dais our esteemed panelists, Dr. Rajat Bhargava sir, Associate Professor in the Department of Medical Gastroenterology, MGMC, Jaipur, Dr. Akash Rajendra sir, Associate Professor in Medical Gastroenterology, MGMC, Jaipur, Dr. Varsha Shastri ma'am, Chief Clinical Nutritionist, ILBS New Delhi, and Dr. Preeti Vijay ma'am, Chief Dietitian and Nutritionist at CK Birla Hospital, Jaipur. Let us also extend a warm welcome to the moderator, Dr. Anand Kumar Jain sir, Associate Professor in Critical Care Medicine, MGMC, Jaipur. I'll be handing it over to you now, sir. Thank you.
Good evening. So, as the number of liver transplant and solid organ transplant are increasing every day, so are the complications post-transplant because of the immunosuppressants and many other things. Sarcopenia and nutrition becomes very important in these cases. We have a case which has been admitted with us a few days back, and let's see, let's unfold how this case. And I would request my panelists up over here to answer a few questions to help us in managing this case. So, to give you a brief history about this patient, he was a 32-year-old male, had a ACLF grade 3 with severe alcoholic hepatitis. His index presentation was with bilateral pneumonia requiring ventilatory support. He had shock, later leading to AKI, which required CRRT and a prolonged ICU stay for optimization and even stay in the hospital, which accounted to say somewhere around 40 days. After optimization and once the recovery of all extrahepatic organs had occurred, he underwent a liver transplant with right lobe graft with new MHV. The post-op period was also quite eventful in the form of sepsis with early allograft dysfunction requiring 5 cycles of plasma exchanges, IVIG, and high doses of immunosuppressions. The total duration extended from the normal being, say, somewhere around 15 days to 40 days again. This patient was discharged back to home. Again, presented to us on 11th of March with the complaints of swelling in the left parotid region,
for which he was seen by an ENT physician, and he diagnosed him to have a parotid abscess and was advised antibiotics. But because of this abscess, he had a total dependence on liquids for almost like 4 or 5 days. On the day he presented to us this time, he had a history of fever for 1 day and shortness of breath. At presentation, as the hemodynamics were normal, so he was shifted to ward for further evaluation and management, and empirical antibiotics were started. The immunosuppressants were modified from the regular ones to injection hydrocortisone, being given 50 milligrams every TDS. These were the investigations at the time of admission. Okay. So, and this was the chest X-ray. The very next day, he had continuous fever with worsening tachypnea and was shifted to ICU. The HRCT, which was done to rule out what are the fluffy opacities on the bilateral X-rays, we found that there are many cavitary lesions on bilateral lung feeds, which is supposedly most likely to be a fungal pneumonia. All the reports were sent. Antimicrobials were modified based on his HRCT reports and other findings. The very day, he developed desaturation and with a decreased sensorium and was intubated and mechanically ventilated. All the things were optimized for him, including antimicrobials, fluid status, and everything. Now, my first question is for Dr. Akash. How will you assess the nutritional status of this patient now in an ICU? How would you like to do that?
Very good. Last session. These, as far as I can understand, if the patient has been successful with and the nutrition status of this patient is of most importance because it will decide what to do instead of in this patient, the first of all, the basic measures like weight, height, BMI, which have been done traditionally to assess the nutrition, used to be done, used to be known. After that, Vidam system, which include Vidam circumference and passive skill code into 1 and passive skill code. These are the anthropometric values that I would like to discussion. There are certain compositions, body compositions, like hexagon, which have been widely used. It has a limitation basically that in patients with ascites, it gives an overestimation of these values. Also, there are scores like NP-1 CT assessment, which have been normalized for time. We can it has a very good sensitivity to assess nutrition. Which, mostly liver transplant patients have already having these CT. Also, new modality that is the CT, the Hounsfield unit of that is the steatosis status of the liver. That is the CT index, which the gamma is less than 25, less than 40 value is celestial parameter. Because more than that, 33 less than 33 value. This is a new modality, the data is but apart from these functional modalities like hand weight test and all these, they can't be done in patients who are quality.
So similarly, the DEXA and CD scanning isn't possible. So we took up the anthropometric data for this patient, as you said, and these were the anthropometric findings for this patient. Okay. So now the next question is to Dr. Akash. How to assess the severity of nutritional risk in our patient? How would you assess it?
There are several scores which have been validated and which have been prescribed by several societies. Like ESA would suggest us using an NRS 2002 score, that nutrition risk score. Whereas INASA suggests that we use a Royal Free Hospital nutrition prioritizing tool, which would divide the levels more than 6 to suggest the patient who would require a more care as far as nutrition is required. Apart from these, there are subjective global assessment scales which have been used from able assessment. Dr. described for the critical patients, we have nucleic score that previously the subjective global assessment is a good score by which we can assess the requirement that the nutrition has.
Dr. Bashir, what is exactly this Nutric score?
Nutric score is usually it is to categorize patients who are mostly benefited from the aggressive nutritional therapy. It is basically done in general critically ill, which has been also validated in liver cirrhotic patients as well. But here we have to see there are no actual nutrition parameters in this score. This is developed by Hela and al. In 2011. So when they put all the parameters for risk stratification, none of the nutritional parameters such as BMI, weight loss, none of these parameters came. So the most driving factors were the disease severity in the form of your critical illness scores and interleukin 6, age, and presence of comorbidities, duration of hospital stay. These were the main factors which came out as predicting for the nutritional risk. So in this patient, I would like to add 32-year-old male with prior ACLF, prior hospitalization with sepsis, akin 3 on CRRT, already a severe he is already severely malnourished. And as you see the BMI change from pre-transplant to post-transplant, 24 to has dropped down to 18. So in such patients, actually there is we have to consider them as high nutritional risk and start treating immediately rather than because for academic purpose, yes, we can do all these previous CTs and everything, but for practicality purpose, directly these are the person who needs immediate management.
So how does this Nutric score helps one? Is it a prognostic, any prognostic implications or anything to add on to dietetics?
Yes, it has all the prognostic scores included in the score itself. So it prognosticates also, but actual purpose is higher the Nutric score, more chances of getting benefited from the aggressive nutritional therapy. That is what the meaning of Nutric score is all about.
Okay. Is it anyhow better than the regular MELD scoring, Apache, SOFA, what we usually do for prognostication of a patient in an ICU?
Cirrhotics, it is not very well validated as a prognostic score, but yes, we can use as of now in critical illness. This is the only score available for the
Great. So this was the scores which we found out for this patient. And as the question was, does it helps in managing the nutritional requirements?
Definitely. This only suggests that they are benefited from the otherwise how much we need to give and all are not decided by this.
Okay. Can we actually see the scores and how?
No, like if, aggressive in the sense. So the term aggressive means yes, you can give like more of calories, more of protein. So instead of say 30, 35, you can go like 35, 40. So the rough value of this aggressiveness it can be.
Okay. What about the improvement? If we start up with a Nutric score of say supposedly C, the patient was and has gone down to B, will it be of any help to this patient or would it be of help to the clinician?
With this score.
Yes.
So as I say, see, with all other kind of managements, if it's Apache score and SOFA score, sorry, Apache and SOFA score comes down, naturally the Nutric score comes down. So
Right.
whether it is because of nutrition per se, it is very
It is difficult to say. Good. So the next question is for Dr. Preeti. What are the factors that dispose this patient to have nutritional risk?
See, generally, whenever we are talking about two kind of patients, so we have to see
their condition, how they are already feed, and whenever we start to feed, the patient is supposed. Generally, we have the parenteral nutrition or enteral nutrition. We generally see what we are supposed to start. Preferably, we start with the enteral nutrition, and in this case, generally we see the patient will tolerate feed or not. And first, we start with the very less volume, and then we increase the volume of the calories.
I would like to interrupt. What are the factors that predispose this patient to have risk for nutrition? What are the factors, Dr. Basha?
So clearly, when we see the reduced intake days, so overall, from last discharge till now, around 6-7 days of loss of poor intake is there, and the basic diagnosis of ACLF, going through prolonged hospitalization, a major surgery, sepsis, all these put him into severe nutritional risk and poor intake throughout these days. So we
So
have
yes,
to
he
look
is at
into
risk.
malnourishment and also the risk of refeeding and all in these patients.
So good enough. The increased metabolic demands because of sepsis and the other critical illness which he's having, prolonged mechanical ventilation, reduced oral intakes, all those can be responsible for increased nutritional risk in this patient. Now the next question is, how would you calculate? We have been talking about a lot about these things, like the calculation says somewhere around 30 to 35 kilocalories per kg per day with 1.2 to 1.5. So there are various formulas which have been used, like predictive equations, indirect calorimetry, as well as weight-based calculations. Dr. Varsha, once again to you, what is indirect calorimetry? Could you please tell us?
So basically, indirect calorimetry measures the volume of oxygen consumed and volume of carbon dioxide released by the body by using some equations, inbuilt equations. So it indirectly, it is a mathematical calculation, not the experimental one. So mathematically, it gives a rough idea about the energy expenditure irrespective of the age, gender, body weight of the patient. So it gives a snapshot of the energy requirements at that particular scenario.
Okay.
So ideally, by guidelines also, indirect calorimetry should be used in assessing, especially patients like this, in whom it is very difficult to estimate calorie requirements using Harris-Benedict and any other calculations. But indirect calorimeter does have its own pros and cons. There has to be a steady state. The measurement should be accurate to be validated study. So it has lot of prerequisites for doing it. So in other words, we use only weight-based only for the practical purpose. Again, come back to that only. Otherwise, Bensted and Item Johnson are the we call it dynamic kind of equations where we take temperature, where we take heart rate as the parameter. So they are much better than Harris-Benedict, at least in film.
Okay, good enough. So most of the places have been using these weight-based calculations. Now the question is, which weight? The actual body weight or the ideal body weight? Dr. Preeti.
Generally, in this case, so generally we take the actual body weight, and but in these cases, because generally the liver patient have the edema, so we take the ideal body weight.
So since he is a sarcopenic, so I think ideal body weight would be a better option. Anything to add, Dr. Akash?
Should we take the calculate dry weight as well? Should we take
Right.
the weight before the patient have sex? Or should we, there is a controversy regarding this also, not about that 5%, 10%, 15% reduction that we have been studying so far. Is it a realistic?
But generally, if a patient is not having the edema and all, then we can have the actual body weight, because after liver transplant, if the patient is having the pneumonia, so we are supposed to give the good amount of proteins, and that proteins is supposed to be calculated through your actual body weight only. And if a person is malnourished, then yes, we have to give the additional calories, that like the 30 to 35 kilocalories per kg body weight, we can calculate that.
Okay.
And but if the patient is overweight, then yes, we need to think something else, that we have to reduce the calories. But in practical scenario, we do the 30 to 35 kilocalories per kg body weight we can do, so that the protein sparing action should not start. And we generally calculate the NPC and ratio also.
Okay. So my next question is this these weight-based alliances good enough to manage the nutritional requirements for this patient?
So that's what I'm saying. Generally, whenever you are recommending these kind of calories, and you should calculate NPC and ratio also, because in generally critical care patients, it should be 100:1 or less than that, so that the patient should not get headache, diarrhea, and other things, and the patient will tolerate the feed very easily.
Okay, so you says that the patient should tolerate the feed and we should
That's
calculate.
very important for us.
There have been I've been seeing that at many places there are beds which have got weighing scales. Are they good enough for measuring weights in these patients, Dr. Varsha, and to calculate our calories and nutritional requirements?
My experience, dry body weight, we used to calculate BMI, actual BMI, so that we can put them into particular category of underweight, overweight, or obesity, class of obesity. The dry weight helps in that, because when you see a patient, so you feel that he is obese, but when you calculate dry weight and then calculate BMI, he's actually either overweight or even weak. So when calculating calories and protein, so majority of the times in normal weight person, ideal body weight is ideal. So if BMI is very low, less than 18 or so, we can go for ideal body weight is better than. In normal weight, actual body weight can be used, and in obese, you can use either ideal or adjusted. So for calculation. And weighing scales, because we always depend on recent history of weight, recent recorded weight for baseline weight in the critical illness. So ideally, weighing at least one bed should be available to just first day with record patient and then shift.
So it would be better to have a weighing bed. Thank you. Yes.
Then we have to reduce, yes. Yes, sir. To actually calculate his BMI and categorize each category.
Mike. Okay. So as you said that daily allowances couldn't be calculated based on the actual body weight. It has to be the ideal body weight. First thing is that. Second important thing is we have to calculate it on the daily basis. It can't be that if the patient has been admitted on X day, we can't calculate the caloric requirement on Y day with the same body weight. Am I right?
Yeah, for ideal body weight, see.
No, not for the ideal body weight. If it has to be ideal body weight for calculations only and has to be done only on the measurements of them only, and everything should be calculated based on the ideal body weight. That's what you are saying now?
Yes, because I always feel for anesthetist it is more important, because they have to calculate the tidal volume per kg body weight, everything per kg body weight. So for nutritionists also it is very important कि even for a calculation of ideal body weight, you need at least height. So we even we don't have height at many times. We measure from head to
Had to like.
toe and then calculate ideal by using Broca's formula.
Thank you. Now, what is the diet that should be prescribed to our patient, Preeti? I think we have talked about a lot.
Liver transplant cases, generally we are supposed to give the first of all the neutropenic diet that we have to give in the post transplant, and but because this patient was on an because of ventilator, so we are supposed to give the enteral nutrition, and this enteral nutrition is supposed to be on a, like the around 1.5 gram protein per kg body weight. We can calculate through our RT feed, and in the enteral nutrition we can start with like the 100 ml second hourly or 200 ml second hourly feed, and gradually we can increase the feed to achieve the nutritional requirement, whatever the nutrition, the calories, protein, the other nutrients that we have recommended to the patient.
Okay. So as you said, the calorie requirement is 30 to 35. Protein requirement is 1 to 1.5. So I think this calculation fits it. And as you said, that the ideal body weight should be taken into account for calculating all those things. Similarly, we took into account the daily RDA for the micronutrients, and we started him on the all these fits.
Yes.
Yes.
There is a controversy regarding human nutrition. The agenda is
Generally, we are not giving that the human nutrition through the rice tube. And generally, there are many injections and the other things are available for immunonutrition. So generally, the consultants they are deciding and they are providing to the patients. But earlier, like in the RD feed that we are not.
So what SPEN guidelines says is that the immunonutrition has
We
been
have
nowadays.
something like in the liver cases. Generally, we have the hepatic formulas. So we recommend that to patients. Generally, we add that in our the RT feed, and whenever we feed, there are requirements of protein. So we additionally we add the protein supplements also in the patient.
So as such, it's a gray area still in ASPEN guidelines, so haven't been cleared off. But yes, many people are still using immunonutrition in these patients. So as you said, the RT feeds were started for this patient, and this was actually the prescription was given by our dietitian. We added up some trace elements, minerals, and vitamins to this. But on day 3, he developed an intolerance as increased rice tube aspirate. Now, Rajat, how would you approach this condition? The mic is off.
Yes, so the patient is sick on ventilator with sepsis. There are chances that the gastric emptying may get delayed. Also, we have to check the position of the Ryle's tube, and we can add prokinetic agents like lesoride or the etopride to increase the gastric emptying. Or sometimes they may not tolerate that bolus feeds of 200, so we can reduce them to intermittent feeds, or we can give the continuous feeding, a slow feeding over a period of 18 hours or 24 hours.
So as you said, we did the same thing. We
I'd like
assessed
to
that the
add,
overall
even
claim-
hyperglycemia needs to be treated in these patients.
Pardon?
Even hyperglycemia needs to be treated for gastric emptying. That could be one cause. And another one being that the data is quite clear about 2 or 3 prokinetics like metoclopramide and erythromycin. And the data is quite clear. And apart from these others, one like domperidone, this is not very clear about that whether they will work or not. And metoclopramide and erythromycin both can be in a suspension form as well. We can get that in a suspension form.
But is erythromycin available?
Intravenous, IV, we can give all these prokinetics, and the US FDA approved for gastroparesis is the drug that's Reglan and erythromycin. Other drugs are not FDA approved, but the drugs like etopride and levosulfuride, they all act on dopaminergic and they have their prokinetic action, so they can be given IV. So levosulfuride is available, IV etopride is not. So those we can add as IV drugs, and then we can see whether the patient tolerate these feeds or not.
So erythromycin through the rice tube, and all the rest is the IV drugs. Now we started with the slow feeds, as you said, checked all those things, and on day 5th, he had sudden atrial fibrillation with hemodynamic worsening. The cardiology opinion was sought, and he advised for serum potassium, calcium, magnesium, and phosphate. These were the values. Dr. Varsha, what could be the reason for this dyselectrolytemia now? Can it be related to nutrition?
Patients BMI 18, poor intake for less than 6 days, plus on immunosuppressive therapies, sepsis, everything can definitely, and feeding begun directly with 200 ml full feed. So could have led to refeeding syndrome. So with this kind of dyselectrolemia. But when we see baseline dyselectrolemia like this, first we need to correct that and then start feeding. Like target is 500 to maximum 1000 kilocalories per day. 500 is ideal.
So could you please elaborate what is actually the pathogenesis of this refeeding syndrome?
Refeeding syndrome, when patient is NPO for a longer period of days and suddenly receives full feeding, so there is displacement of all the electrolytes like phosphorus and intracellular, they go intracellular. So their levels fall down in the serum. So they finally end up in cardiac dysfunction.
Okay. So there could be many things which could be responsible. It is usually a potentially a life-threatening condition which occurs in an individual who is malnourished, and as you said, it is because of the electrolyte disbalances, and apart from that, many metabolic disbalances can happen, and it can lead to an organ dysfunction like seizures, heart failure, and even death in severe cases have occurred. How to prevent?
So first we have to categorize whether they are a high risk of developing this feeding syndrome. Using we have nice guidelines for that. So we are taking into account the BMI and their past 7 days intake, significant weight loss, and also I think serum electrolytes levels. Serum electrolytes levels are very important in these cases. So baseline we have to do, correct it, and slowly start feeding.
Okay, so the treatment would comprise of actually correcting the electrolytes and then starting the nutrition therapy in small scales and adding up the vitamins.
Yes.
And the
Yes.
most important vitamin here is, I think, I have been reading about it. Cash? Thiamine,
Thiamine.
yes. So we did the same, but and initiated the slow feeds. Now on day 7, he had diarrhea, 8 unformed stools. Rajat, reason for this diarrhea now?
So the patient is in ICU with multiple antibiotics going on. So the cause of diarrhea could be the antibiotic-associated diarrhea. Then it may be drugs can always be there. We are giving prokinetics, so that can be there. Infections again. Uh, Infections can develop GI infections because patient is immunocompromised and also post-transplant already on immunosuppression. So, and then the intolerance to the diet is sometimes when the patient is on milk-based diet, then there may be some intolerance to the feeds and lactose malabsorption. So they all can cause diarrhea in such patients.
So we looked into it and we found out that the patient was started on injection Raglan in view of the intolerance to the feeds, and were laxatives were also added to him. So those were found to be the reason for this diarrhea now. But as you said, the medications, infection, formula related factors, and malabsorption can be the responsible factor for this. After a few days, we continued him, and the general condition of this patient improved with normal hemodynamics and decreased oxygen requirements. He was attempted to wean off the ventilator, but since he had a poor muscle power, so had to underwent a tracheostomy, and post tracheostomy, the nutritional rehabilitation was continued. On day 17th, he had sudden increase in urine output, and by the afternoon, he became unconscious. The mechanical ventilation was initiated immediately, and an ABG was done. This was the ABG. A pH of 7.259 with a PCO2 of 56.9, a sodium of 150 with a potassium of 3.3, calcium of 1.43, and Billy of 10.4. What do you think? What had happened? Dr. Varsha, you have been working on diabetes.
But anyhow, I have not clearly seen increased either carbohydrate or high calories leading directly to increased carbon dioxide. This clear cut, but yeah, that could be one of, if we want to learn. Yes, one of the cause would be overfeeding, so which can cause increased CO2 levels. But I would say because patient is tracheostomy, we usually if patient is conscious and tracheostomy, we start him feeding sips of semi-solid like custard,
Right.
this kind of thing, so that patient feels good about it after eating after a long period of time. So there might be sometimes like yeah, aspirational risk might be there, micro aspiration or something like that, even though on tracheostomy.
So, if the patient is conscious, I am conscious, my airway is protected. So, how could it be responsible for a microaspiration risk if the subglottic, the tube has been inflated with the cuff inflated below the glottis. So I don't think, but yes, definitely we tried for it, and this had actually what had happened with him. So yes, as you said that yes, he had an overfeeding syndrome, which can have many risk factors like extremes non-protein caloric intake, as maybe injection propofol somewhere in ICUs. There could be difference in the height and weight measurements and failure to account for the clinical state because there was decreased energy need. We don't have a direct calorimetry with us, indirect calorimetry, sorry, and the use of parenteral nutrition. These could all be the risk factors. And the effects are hyperglycemia, hyperlipidemia, hypercapnia, which we can see on the EVG as well with liver dysfunction, and it can also be responsible for refeeding syndrome. We treated it again. We started again him on low caloric feeds, 200 ml now every second RD with a calorie intake of say somewhere around 1900 kilocalories per day. And this is the present condition of our patient. He has been weaned off from the ventilator. He is stable with the on room air and has improving organ functions, which are evident even on the EBG. This is his EBG from the last day itself. He's still admitted with us in our ICU, and the nutritional rehabilitation is still ongoing. As you can take a look, the PCO2 has come down, distal lipidemia more or less settled, the belly is on a declining trend, each and everything is appearing good. So it was, although our diagnosis of exclusion that it was overfeeding syndrome per se, but when we looked back, yes, we found out, yes, it could have been the responsible because he was getting formula feeds per se, except from the normal daily routine feeds which were prescribed to him. So the attendants were actually feeding him through the oral feeds. They were bringing the formula feeds with them and was feeding him. So that was the probable or responsible cause.
Is he still on rice tube?
So we actually removed his tube, but what had happened, he wasn't having a very good oral intake, so I had to reinsert it.
Exactly. Rice tube should be continued till patient at least takes himself more than 80% of what we provide to him. That is the criteria.
Actually, the rice tube was not removed by us. It was the patient itself who actually pulled it out. We were continuing him on the both the feeds.
And second thing is always thin bore freca should be placed because normal rice tube they cause severe esophagitis and they end up in upper GI bleed, melena. We were thinking why melena in this patient. See, because patient is now mobile, he is sitting and he is doing physical activity. So there is severe esophagitis can occur with the rice tube. So soft silicone this freca tube would be beneficial and it should be there for till patient is at least more than 80% of his oral intake.
Thank you, Dr. Varsha, for your inputs. We would do the same for our patient, and I hope it will help in a good recovery of this patient. And we'll be sharing the photographs of this patient when we are discharging him. Thank you. Thanks for your inputs.
I think this is a victory for our intensive team for
Yes.
Thank you.
Syndrome. The patients were very difficult to feed, and we are getting overfeeding. So that is also a victory.
This is actually an entity which we don't look on too frequently in our ICUs in our daily practice. That's the reason even we didn't observe it until we weren't able to find any other reason for it. Yes. Thank you.